This is Audible.
Tantor Audio, a division of Recorded Books, presents Anxiety Disorders, edited by Zelda Espinel, M.D., M.Ph., and Elizabeth A. Crocco, M.D., narrated by Eleanor McCormick. Limit of liability and disclaimer of warranty. This material is not intended to be, and should not be considered, a substitute for medical or other professional advice. Treatment for the conditions described in this material is highly dependent on the individual circumstances, and, while this material is designed to offer accurate information with respect to the subject matter covered and to be current as of the time it was written, research and knowledge about medical and health issues is constantly evolving, and dose schedules for medications are being revised continually, with new side effects recognized and accounted for regularly. Readers must therefore always check the product information and clinical procedures with the most up-to-date published product information and data sheets provided by the manufacturers and the most recent codes of conduct and safety regulation. The publisher and the authors make no representations or warranties to readers, express or implied, as to the accuracy or completeness of this material. Without limiting the foregoing, the publisher and the authors make no representations or warranties as to the accuracy or efficacy of the drug dosages mentioned in the material. The authors and the publisher do not accept and expressly disclaim any responsibility for any liability, loss, or risk that may be claimed or incurred as a consequence of the use and/or application of any of the contents of this material. Introduction. The Clinician's Roadmap to Anxiety Disorders. Zelda Espinel, M.D., M.Ph., and Elizabeth Crocco, M.D. Anxiety disorders represent one of the most prevalent health conditions globally, affecting a significant portion of the population. Anxiety is a natural human emotion that plays a vital role in preparing us to face challenges. When anxiety becomes overwhelming and persistent and starts interfering with day-to-day function, individuals typically turn to a health provider for assistance. Primary care and other non-mental health providers are often the only point of contact for individuals experiencing anxiety symptoms. Additionally, mental health providers may need assistance in managing these very challenging and common conditions. Being knowledgeable about anxiety disorders enables clinicians to recognize these conditions early, leading to timely interventions and better outcomes for both their physical and mental health. In this book, we aim to provide clinicians with an understanding of anxiety disorders in a case-by-case format, equipping them with the practical knowledge and tools necessary to navigate the complexities of each clinical scenario presented. Our objective is to empower clinicians with a better understanding of anxiety disorders so that they are better equipped to develop individualized treatment plans that include medication management, lifestyle modifications, and psychotherapy. We hope to serve as your curbside consultants, ultimately addressing your critical question, what do I do now? 1. Connecting the dots. History gathering and anxiety diagnosis. Natalie Martinez Sosa, M.D., and Philip D. Harvey, Ph.D. Ms. A is a 33-year-old woman who presents with complaints of feeling stressed for the last year. She describes herself as easygoing and carefree until last year, when she noticed she was increasingly worrying about her finances after seeing how the economy has been affected. She has a stable job at an accounting firm and recently received a promotion. She expresses being afraid that something awful will happen to her parents, although they are well and live in a safe neighborhood. She says she feels as if she cannot control her worry, which often leads her to become short of breath and have brief episodes of chest discomfort. As a result, she has become concerned and has visited the emergency department multiple times, with a normal workup each time. She now spends a lot of her free time searching online for causes of these symptoms. She has difficulty concentrating at work, develops back pain toward the end of the day, and has trouble falling asleep. What do I do now? As outlined in the case of Ms. A, anxiety can be manifested as excessive worry and increased vigilance, fear, and avoidance of perceived threats. Anxiety can also be manifested by physical symptoms such as palpitations, sweating, shortness of breath, chest pain, dizziness, paresthesia, and nausea, symptoms that are commonly seen in panic attacks. The likely origin of these symptoms is from interactions of the sympathetic and parasympathetic nervous systems. Additionally, anxiety disorders can present with behavioral manifestations, such as avoidance, which is a maladaptive response to excessive fear and anxiety. Anxiety can be a normal reaction to stressful events, but it becomes a concern when it leads to lifestyle changes to accommodate the symptoms and prevents the individual from fully engaging in day-to-day activities. The case presented exemplifies the great variation in symptoms that can present in the anxious patient, even a very high-functioning one like Ms. A, highlighting the importance of history gathering to determine the correct diagnosis and treatment strategy. Anxiety disorders are the most common mental illness, but vary in terms of duration of symptoms, their triggers, and their behavioral manifestations. The National Comorbidity Study Replication, NCSR, estimates that 19.1% of adults in the United States had an anxiety disorder in the past year, with higher prevalence seen in females. Additionally, it is estimated that about 31% of adults in the United States are affected by an anxiety disorder at some point in their lives. Furthermore, the World Mental Health Survey estimates that approximately 1 in 4 individuals is likely to have had an anxiety disorder. Table 1.1 lists the current Diagnostic and Statistical Manual of Mental Disorders, 5th edition, text revision, classification of anxiety disorders. Anxiety disorders vary in their age of onset and commonly begin in childhood, adolescence, or early adulthood. For example, phobias and social anxiety usually arise during childhood and adolescence. Meanwhile, generalized anxiety disorder and panic disorder most commonly emerge in adulthood. As we learned in the case of Ms. A, female sex and a family history of anxiety and depression are examples of risk factors for the development of anxiety disorders, which also reflect a hereditary aspect to these illnesses, as confirmed by genomic studies. Other factors that contribute to the development of these disorders include dysfunctional parental interactions in childhood and environmental stressors, such as abuse, chronic illness, financial struggles, and death of significant others. Furthermore, certain personality traits, such as neuroticism, have been linked to the development of anxiety disorders. When assessing individuals who present with a chief complaint of anxiety, it is important to inquire into the symptoms, the situations in which they occur, and any common precipitants. History gathering is instrumental in being able to achieve this. Family history is an important component of history gathering, as are inquiries into any potential comorbidities or physical causes of the symptoms. It is important to identify the environmental setting in which the anxiety occurs. For example, a patient with social anxiety will commonly experience symptoms anticipating and during social interactions, such as public speaking or even eating in public. Meanwhile, a patient with panic disorder may experience recurrent panic attacks without any apparent trigger. Patients with agoraphobia will become fearful when anticipating or being outside of the home alone, as well as in enclosed spaces. Those who suffer from generalized anxiety disorder, as in the case of Ms. A, will experience anxiety and worry about a variety of situations that is difficult to control and that can change dynamically. Determining the duration, intensity, course, and progression of symptoms is also important in differentiating between possible anxiety disorders. For example, patients with panic disorder experience an unexpected surge of intense fear that peaks within minutes. Meanwhile, those who suffer from generalized anxiety experience excessive worry on more days than not, often triggered by common, everyday stressors, as outlined in the case of Ms. A. In most anxiety disorders, Symptoms must be present for at least 6 months, as in this case, for the diagnosis to be confirmed. But in many cases, people with anxiety disorders will present for evaluation prior to the 6-month period required to meet this timeline. Anxiety disorders are characterized by a response that is out of proportion to the actual risk posed by the triggering situation, object, or event. Patients with anxiety disorders may develop maladaptive behaviors in an effort to diminish the anxiety and avoid it, which commonly becomes a self-defeating cycle, leading to significant impairment in daily life. It is important to recognize these behaviors, as they may be the reason an individual seeks care. Asking the patient about the thoughts that emerge when feeling anxious is helpful in identifying a specific anxiety disorder. For example, patients with social anxiety disorder might worry about being embarrassed in social situations and fear they might be rejected by others. Patients who suffer from agoraphobia might worry about being in a place where they feel trapped. As a result, they avoid situations that may trigger panic symptoms and where escape may be impossible. Specific phobias are accompanied by worries that are disproportionate when encountering the phobic object. Exploring the degree of impairment in social and occupational areas will highlight the severity of the symptoms. As highlighted in this case, anxiety symptoms are causing significant distress and are affecting interpersonal relations and work. It is important to keep in mind that realistic concerns, such as being a crime victim when residing in a high crime area, are expectable and understandable and do not constitute an anxiety disorder. A critical element of the assessment will be an examination of previous traumatic experiences of the patient, including exposure to childhood abuse of various forms. People who have had a motor vehicle accident and are subsequently fearful of driving are likely to have a different history from those who have never had the traumatic experience. Further, childhood emotional abuse can be associated with a more extreme reaction to potential social situations. Childhood sexual abuse is commonly associated with panic attacks and should be examined as well. Anxiety can be accompanied by symptoms that are seen in other psychiatric disorders, such as restlessness, problems with concentration, sleep disturbance, and irritability. These symptoms may indicate the presence of a comorbid condition, such as clinical depression, that needs to be evaluated. Anxiety can also manifest itself as physical symptoms, including muscle tension, fatigue, headaches, palpitations, sweating, shortness of breath, chest pain, and paresthesias. These symptoms may require further assessment to evaluate for a medical cause. Table 1.2 provides a summary of factors that are important when evaluating anxiety symptoms. Table 1.1. Anxiety Disorders in the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, text revision. Separation anxiety disorder, selective mutism, specific phobia, social anxiety disorder, panic disorder, agoraphobia, generalized anxiety disorder, substance or medication-induced anxiety disorder, anxiety disorder due to another medical condition, other specified anxiety disorder, unspecified anxiety disorder. Table 1.2. Evaluation of anxiety symptoms. Onset and duration. When did the symptoms start, and how long do they last? Timing. Are the symptoms present on more days than not? Do symptoms develop suddenly and peak within minutes? Precipitating factors. Are the symptoms triggered by a particular situation or object? Associated thoughts. Do you fear being embarrassed or humiliated by others? Do you worry these symptoms will happen again? Do you feel these symptoms are excessive or unreasonable? Trauma history. Have you ever had a major life trauma or chronic traumatic experiences? Maladaptive behaviors. Do you avoid situations and places that produce anxiety? Functional impairment. Have the symptoms affected your relationships? Do symptoms impair your ability to function at work or at school? Mental status examination of the anxious patient. The mental status examination, which consists of observational information, is essential in the diagnosis of anxiety disorders. The appearance and behavior of a patient suffering from anxiety can manifest differently depending on the circumstances that provoke anxiety. Patients may present as well-groomed, while others may have debilitating anxiety that leads to social isolation and poor hygiene. Patients who suffer anxiety in social settings may exhibit poor eye contact or avert direct gaze with the examiner. Commonly, patients with anxiety will exhibit psychomotor agitation, which can manifest as pacing, fidgeting, and tugging at their hair and clothes. Speech is not commonly directly affected in patients with anxiety. However, they may experience difficulty speaking if they are in the middle of a panic attack, and those with social phobias may experience subjective changes in their ability to communicate. A patient who presents with complaints of anxiety may describe their mood as nervous, worried, tense, stressed, irritable, or on edge. The outward expression of emotion, or affect, can vary greatly. Some patients appear guarded because they do not want to disclose some information, while those experiencing acute anxiety may present as more labile in their emotional states and communication. The thought content of a patient with anxiety might reveal repetitive negative thoughts, commonly known as ruminations, or anticipatory worry about the identified triggers. For example, a patient with social anxiety might be preoccupied about being ridiculed by his or her peers, while a patient with panic disorder might worry about having another panic attack. Meanwhile, patients with phobias may ruminate about coming into contact with their feared objects, even when it is not realistic. Subjective and objective changes in cognitive function can be assessed throughout the interview, as patients may report difficulty with concentration, and this may or may not be observed during the conversation. To determine level of insight, which will likely predict therapeutic engagement, it is useful to ask patients if they believe the symptoms are a problem and if they attribute their symptoms to a psychiatric illness. Most adults with anxiety disorders tend to have good insight, as they are able to understand that the symptoms they experience are out of proportion to their precipitant and notice the symptoms interfering with their daily lives. In fact, they can be exquisitely sensitive to subtle changes in heart rate, facial flushing, and other changes in physiological functions that are then fed back into their self-assessments. Judgment can be assessed in the interview when the patient recounts experiences or reactions to the anxiety triggers, including whether fears and reactions to them are so extreme that other causes, such as psychosis, should be considered. Medical history and physical examination. A complex relationship exists between anxiety disorders and physical illnesses. The symptoms reported by the patient as anxiety can be a sign of physical illnesses, such as the angina experienced in the setting of myocardial infarction or panic attacks experienced by a patient with untreated hyperthyroidism. Thus, it is crucial for the evaluation, especially for those patients at high risk of medical comorbidities, to include a thorough medical history and physical examination. Oftentimes, assessment will include laboratory and diagnostic studies tailored to the patient's presentation. For example, patients who report episodes of angina, chest pain, or history of hypertension may need an electrocardiogram to screen for a cardiac etiology. Meanwhile, those who report unexplained panic attacks, weight loss, and irritability may require blood work to assess thyroid function, as these symptoms are associated with hyperthyroidism. Evaluation should include medication use, as well as substance use history. Medications such as corticosteroids, theophylline, and others can be a cause of anxiety. Withdrawal from substances such as amphetamines, cocaine, caffeine, and alcohol can trigger anxiety. Screening tools. Anxiety disorders pose a significant burden on healthcare resources. Reliable diagnosis and accurate assessment of its severity is essential in guiding therapeutic interventions. Screening tools can be helpful for the primary care and mental health clinician, as they provide a qualitative and quantitative assessment of symptom severity. The GAD-7 is employed as a self-report assessment tool for individuals like Ms. A. This questionnaire prompts patients to gauge the frequency of anxiety-related symptoms they experienced during the last 2 weeks, rated on a scale of 0 to 3. As depression and anxiety are commonly comorbid, assessment with self-report scales of depression, such as the Patient Health Questionnaire 9, may also be helpful. Key points to remember. Anxiety can be manifested as excessive worry, along with physical symptoms. The timing and duration of symptoms and precipitating factors, as well as thoughts and behaviors, are key in differentiating between anxiety disorders. A thorough medical history and evaluation is necessary to rule out possible medical causes of the anxiety symptoms. 2. Beyond the surface. Medical evaluation of anxiety conditions. Ash Mehra, MD, and Vanessa Padilla, MD. Ms. T is a 45-year-old woman with no prior medical or psychiatric history who presents to the emergency department complaining of the acute onset of severe shortness of breath, chest pain, and feeling like she was going to die. She reports intermittent episodes of anxiety that are worsening in their intensity and frequency over the last 2 months. Her primary care physician prescribed alprazolam without improvement of her symptoms. She does not report any family history of medical or psychiatric conditions. Vital signs were significant for tachycardia. The physical examination shows thinning hair, moist and warm skin, a fine tremor, and an enlarged goiter in the neck. An electrocardiogram, ECG, was performed and showed no cardiac abnormalities. Further laboratory results showed that her thyroid function was abnormal. What do I do now? Many medical problems can initially present or manifest with symptoms of intense anxiety, worry, nervousness, or unease. These symptoms can be the direct manifestation of medical illness or a reaction to the impact of that illness. Anxiety symptoms can be the result of a medication or substance rather than a primary anxiety disorder. Patients who experience the acute onset of anxiety symptoms, who suffer from underlying medical illness despite a previous diagnosis of a primary anxiety disorder, and who have unexplained medical findings, should have a comprehensive medical evaluation. When obtaining the patient's history, key findings can point clinicians toward the possibility of a primary medical illness. As outlined in the case of Ms. T, these can include a lack of prior psychiatric history, a late age of onset, an absence of family history, and no response to anxiolytic agents. The past medical history was non-contributory in the case of Ms. T. A thorough evaluation should provide detailed information on pre-existing medical conditions that can present with anxiety symptoms. In the case of Ms. T, the physical examination revealed significant findings that suggested thyroid disease as the primary diagnosis. These symptoms include tachycardia, moist and warm skin, a fine tremor, hair changes, and a goiter. Without performing a physical examination, these important signs could easily be overlooked. When performing a medical assessment of a patient presenting with anxiety, basic laboratory tests should be obtained. It is recommended to order a complete blood cell count, a chemistry profile, thyroid function tests, a urinalysis, and a urine toxicology test as initial medical workup. Typically, an ECG is also necessary to evaluate for arrhythmias or cardiac disease. If additional medical symptoms are present along with the anxiety, further diagnostic tests should be ordered on an individual basis to identify the diagnosis. For example, if neurological symptoms are present, physicians may need to perform additional diagnostic tests, such as electroencephalogram, EEG, lumbar puncture, brain computerized tomography, CT scan, or magnetic resonance imaging, MRI scan. Once a medical diagnosis is suspected, the appropriate referral should be made to a specialist if needed. In the case of Ms. T, an abnormal thyroid function test result triggered a further evaluation and possible referral to an endocrinologist. General medical conditions commonly associated with anxiety. An extensive number of medical conditions can be present with anxiety symptoms. Table 2.1 lists those that are most commonly seen in clinical practice. Hyperthyroidism. Hyperthyroidism is one of the most common medical causes of anxiety as a primary presenting symptom. Hyperthyroidism can be caused by increased thyroid-stimulating hormone, TSH levels, or increased thyroxine, T4 production. Common etiologies include multinodular goiter, pituitary adenoma, and ingestion of exogenous thyroid hormone. Anxiety is a common complaint in hyperthyroidism, as are other complaints suggestive of activation of the sympathetic nervous system, such as tremors, heart palpitations, irritability, and feeling on edge. Patients can present with both generalized anxiety and panic attacks, as we learned in the case of Ms. T. However, patients may also present with a wide variety of physical symptoms, including diarrhea, fatigue, thinning of the skin and hair, weight loss, and weakness. Physical examination findings may include increased sweating, thinning hair, pretibial myxedema, bulging eyes, exophthalmos, lid lag, tachycardia, hyperreflexia, and tremors. Depending on the cause, a physical examination may also reveal a goiter. The medical workup of hyperthyroidism includes a thyroid panel, TSH, triiodothyronine, T3, and free T4 serum levels. Generally, the level of TSH is found to be significantly decreased, and T3 and T4 significantly elevated. Depending on the clinical presentation and laboratory results, further workup may involve a referral to an endocrinologist and treatment of the underlying cause. Hypoparathyroidism. Hypoparathyroidism is a disease of low calcium due to low levels of parathyroid hormone and can have multiple etiologies. The most common cause is removal of the parathyroid glands during thyroid surgery, but the disease can also be idiopathic. Anxiety and hypoparathyroidism may present with other symptoms that differentiate it from generalized anxiety disorder. Patients may have a sensation of tingling or numbness in the toes and fingers or around the mouth, twitching, fatigue, headaches, and diarrhea. As the disease progresses, the twitching may give way to muscle cramps and tetany, as well as seizures and cardiac arrhythmias. Physical examination findings include Voss-Tex sign, tapping on the facial nerve leads to facial muscle spasms, and Trousseau sign. Inflating a blood pressure cuff on the arm for over 3 minutes leads to spasm of the hand. Workup of hypoparathyroidism includes obtaining calcium, phosphate, magnesium, parathyroid hormone, PTH, and serum albumin levels. An ECG may be used to evaluate for any cardiac arrhythmias. As with other thyroid conditions, further workup and treatment may include referral to an endocrinologist. Cancer. Cancers of various types can present with a host of different symptoms, including anxiety. Studies show that 12% of patients with pancreatic cancer can present with anxiety symptoms, as can 10% of patients suffering from lung cancer. Anxiety that presents with unexpected weight loss or fatigue could suggest a cancer diagnosis. Depending on the type and stage of cancer, patients may have other cancer-related symptoms, such as blood in their sputum, as may be seen in lung cancer. It is important not to dismiss any relevant medical symptoms a patient may have that cannot be explained by an anxiety diagnosis alone. Additionally, in patients already diagnosed with cancer, anxiety symptoms can be due to pain, hypoxia, medication side effects, substance withdrawal, or dehydration. Full and frequent medical evaluations are necessary when anxiety is present in this population. Myocardial infarction. Myocardial infarction, MI, and panic attacks can often present with severe and overlapping symptoms, including chest pain, shortness of breath, diaphoresis, and a feeling of impending doom. Patients can present to the emergency department with the belief that they are having a heart attack. After a full medical evaluation, they may be diagnosed with a primary anxiety disorder. On the one hand, some patients who are believed to be suffering from anxiety can be found to have an MI. Studies have found that in the 6-month period prior to an MI, 38% of patients may exhibit somatic anxiety, 17% may show generalized anxiety symptoms, and 14% may have panic symptoms. On the other hand, patients with a history of cardiac disease can often have psychiatric comorbidities, including anxiety disorders. Additionally, women may present with atypical symptoms such as nausea or fatigue. The medical workup for panic attacks should always include an ECG and troponin levels to rule out MI, especially in patients at risk for cardiac disease. ECG changes can be used to rule out not just MI, but also fatal arrhythmias and other heart conditions that may be present but otherwise may be missed. Pheochromocytoma. Pheochromocytomas are tumors of the adrenal medulla, which cause intermittent surges of catecholamines, leading to activation of the sympathetic nervous system. This can often lead to presentations of panic attack-like symptoms, including anxiety, palpitations, tremors, sweating, and a feeling of impending doom. Episodes may be triggered by exercising and other sources of intense stress. Pheochromocytomas are rare, and their periodic nature makes them easy to miss. Left unmanaged, pheochromocytomas can cause serious cardiac complications and eventually death. Patients may also present with a hypertensive emergency due to the activation of the sympathetic nervous system. Therefore, the medical presentation may include sustained tachycardia, headaches, and elevations in blood pressure that are treatment-resistant and not typically seen in anxiety disorders. Diagnosis is made by the measurement of 24-hour urinary and plasma fractionated metanephrines and catecholamines. Pulmonary embolism. A pulmonary embolism, PE, is a blood clot that travels to the lungs, usually in the setting of hypercoagulation or a period of prolonged immobility. PEs can occur after times of extensive bed rest or long flights and are associated with risk factors including smoking, obesity, and various cancer types. They can also occur in the hospital setting, where patients tend to be bedbound, especially after surgical procedures. Symptoms of PEs often present early on as anxiety, with progression to difficulty breathing, chest pain, hemoptysis, and low oxygen saturation. Unfortunately, it is common to mistakenly diagnose and miss early detection of a PE, which leads to delayed medical care and potentially dangerous outcomes. Patients who are at a high risk of developing a PE and present with anxiety should have a full medical examination and workup. These patients may have the acute onset of chest pain and dyspnea, or they may have no physical symptoms at all. Patients who present with acute anxiety symptoms and are at a high risk of having a PE should not be dismissed as just experiencing a primary anxiety disorder. Studies to help establish the diagnosis include oxygen saturation, chest X-ray, arterial blood gas, and D-dimer levels. The gold standard for diagnosis is a spiral CT of the chest. Temporal lobe epilepsy. Anxiety has been reported in 10% to 25% of patients with epilepsy. Anxiety symptoms, such as fear and panic, may be part of the prodrome immediately prior to the seizure or present during the seizure itself. Patients with temporal lobe epilepsy can present with panic or other anxiety symptoms. These symptoms will typically occur more episodically and be accompanied by changes in level of awareness or consciousness. The medical workup to diagnose temporal lobe epilepsy includes an EEG, which may capture abnormal brain waves seen in focal areas of the brain. Imaging can also assist with the diagnosis. A structural brain MRI may reveal lesions within the medial temporal lobe, and functional brain imaging, such as positron emission tomography scan, may show hypometabolism in the affected region. Wilson disease. Wilson disease is an inherited medical condition that affects many organs in the body, such as the liver, eyes, and brain, due to excessive accumulation of copper. In about 12.5% of cases, anxiety has been described as an early sign or symptom of the disease. Reaching the correct diagnosis can be very challenging, but family history can help with the diagnosis because it is an autosomal recessive condition. Physical examination may show the presence of ophthalmic signs known as Kaiser-Fleischer rings. Laboratory testing will reveal a low blood level of ceruloplasmin and excessive urinary copper excretion. Genetic testing may be available to verify diagnosis before pursuing invasive tests, such as a liver biopsy. Hypoglycemia. In patients presenting with anxiety, hypoglycemia needs to be considered. Often, a hypoglycemic episode will also cause altered mental status or be associated with shakes, palpitations, and sweats. Certain populations are at a higher risk of hypoglycemic episodes, such as the elderly, individuals with renal failure, and patients with diabetes mellitus. Prompt and accurate blood glucose monitoring can easily help identify the presence of hypoglycemia. To improve outcomes and to reduce morbidity and mortality, hypoglycemia should be quickly identified and treated. Table 2.1. Common medical illnesses associated with anxiety. Hyperthyroidism, hypoparathyroidism, cancer, pancreatic, lung, and brain, myocardial infarction, pheochromocytoma, pulmonary embolism, temporal lobe epilepsy, Wilson disease, hypoglycemia. Key points to remember. Anxiety is a symptom that can be the primary manifestation of a physical health condition. When patients suffer from both anxiety and a medical condition, healthcare providers will face challenges to accurately identify the correct diagnosis. A comprehensive medical workup, including a medical history, physical examination, and diagnostic tests, when appropriate, is indicated to rule out the medical causes of anxiety. 3. When fear strikes, differentiating panic attacks and panic disorder. Jeremy C. Seng, MD, and Radu V. Savanu, MD. Ms. H. is a 32-year-old woman who presents with chest pain and tachycardia. She has presented to the emergency department with similar complaints 4 times over the past 2 months. She first recalls having attacks like this when she was in college. Since then, Ms. H has had intermittent panic attacks for 10 years. She would experience dizziness, heart palpitations, sweating, and shortness of breath. Sometimes she would also have chest pain or abdominal distress, and frequently experienced a choking sensation and had trouble breathing. They are worsening and unpredictable. She has taken time off from work out of fear that she would be judged negatively for displaying visible panic symptoms and has begun avoiding unfamiliar places. She is worried that she is going crazy. What do I do now? Anxiety, when viewed from an evolutionary perspective, is not pathological, but rather an adaptation that evolved to develop an innate sense of dangerous situations. Just as a baboon develops anxiety and fear in the presence of a lion, humans too feel anxious and fearful as a natural response to real or perceived threats. When threatened, sympathetic activation causes the release of neurotransmitters, which activates the fight-or-flight response. Even though anxiety in and of itself is not pathological, the behaviors associated with it, such as escape, withdrawal, or isolation, may become so. Anxiety disorders occur when there is an inappropriate activation of this alarm system, or when overactive alarms are persistent and severe and will not turn off. A panic attack is the result of an improper, sudden overactivation of the sympathetic anxiety response. A sustained and distressing state of arousal caused by panic attacks leads to a diagnosis of panic disorder. While a key component of panic disorder, panic attacks are not unique to panic disorder. They can and do occur in the context of other primary anxiety disorders, other psychiatric disorders, and multiple medical conditions, and are sometimes noted as specifiers for other diagnoses, such as post-traumatic stress disorder with panic attacks. Panic attacks are abrupt surges of intense fear or intense discomfort accompanied by physical and/or cognitive symptoms. Patients having a panic attack often fear that they may be having a heart attack or losing their minds. Panic attacks can be divided into two categories: expected and unexpected. Expected panic attacks occur in response to an obvious fear-inducing trigger, such as an object or situation that has caused a panic attack before. Unexpected panic attacks describe those attacks that occur in the absence of a discernible trigger. A specific type of unexpected panic attacks is a nocturnal panic attack, which, as the name implies, occurs while sleeping. Panic disorder is characterized by panic attacks that are both recurrent and unexpected. As they occur abruptly and without warning, patients are often terrified and overwhelmed by acute intense anxiety, accompanied by frightening physical symptoms such as rapid heartbeat, shortness of breath, shaking, dizziness, and an intense feeling of imminent doom. The severe distress felt during these attacks leads to a conditioned response known as anticipatory anxiety. This is the anxiety experienced due to the fear of having another panic attack. Patients start focusing on and begin to worry about their physical or mental health and often come up with distorted and catastrophic interpretations of physical symptoms. These interpretations increase arousal and intensify bodily sensations, confirming the sense of impending danger and eventually spiraling into a panic attack and creating a vicious cycle of attacks and worry. The anticipatory anxiety that develops results in the hallmark features of panic disorder. This includes both the persistent worry and the avoidance behaviors due to the fear of having another panic attack. Panic attacks can be so frightening and overwhelming for some people that they will do anything to avoid them, including staying in safe and controlled environments. Individuals with panic disorder may avoid places where panic attacks have occurred, may avoid exercise due to fear of experiencing physical symptoms that may mimic a panic attack, or may avoid places where help may not be readily available. Constant anticipatory anxiety of being in a situation where it is difficult or impossible to leave should an attack occur may lead to isolation and fear of venturing outside the home. Approximately 1/3 of patients with panic disorder have agoraphobia. Agoraphobia is defined by the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, text revision, as a marked fear of anxiety prompted by anticipated exposure to at least two common situations, such as using public transportation, being in open spaces, being in enclosed spaces, standing in line or being in a crowd, and being away from home alone. This intense reaction causes patients to actively avoid such situations, causing clinically significant distress or impairment in their lives. The case of Ms. H is a typical example of panic disorder. She has recurrent and unexpected episodes with classic symptoms of a panic attack. She spends a lot of time worrying about having new attacks and has altered her behavior to minimize or avoid situations that may render her vulnerable to having further attacks. Like other anxiety disorders, panic disorder is usually associated with significant levels of social, occupational, and physical disability. Panic disorder, however, is unique in its association with the highest rates of utilization of medical and mental health services. Like Ms. H, who recently presented to the emergency department multiple times due to her panic attacks, patients with panic disorder frequently present to non-psychiatric clinical settings with medical complaints. Expenses incurred by medical evaluations are costly to the patient, and the visits themselves indirectly increase the economic burden through lost productivity. Continued absences from work may lead to loss of employment. Ms. H has also taken time off work because she is worried about having panic symptoms in front of her coworkers. The Collaborative Psychiatric Epidemiology Survey, 2001 to 2003, found that 86.9% of people with panic disorder described avoidance interfering with occupational work, social life, or relationships, and 11.3% of people considered the interference to be extremely disruptive. The distress of maintaining a persistently elevated anxious state can be demoralizing, and often the progressive disability can lead to depressive episodes. When adjusted for other suicide risk factors, panic attacks and a diagnosis of panic disorder in the past 12 months are related to a higher rate of suicide attempts and suicidal ideation. Panic disorder causes distress not only to patients, but also to their loved ones. The experience of panic for some individuals is so intense and so frightening that subsequent avoidance significantly alters their lifestyle. Patients may gradually isolate themselves from family and friends, at times placing the burden of responsibilities on their shoulders and causing conflict and resentment. Sometimes people with panic disorder develop comorbid substance use disorders, especially alcohol, as an attempt to self-treat anxiety. Alcohol, functioning similarly to benzodiazepines, BZDs, can decrease anxious distress, but the relief is temporary, and it's likely to result in rebound anxiety, thus laying the foundation for alcohol overuse. Differential diagnosis. In the case of Ms. H, what other disorders should also be considered? The first and most obvious is clandestine substance abuse. There is notably no mention of substance use in the vignette, and there are several points in the case that are consistent with both the natural history of panic disorder and anxiety and panic attacks induced by substance use. The onset of her panic attacks started during a period of high stress and following a painful rejection. Even though in panic disorder the frequency and severity of panic attacks can vary widely over time, the irregularity of Ms. H's panic attack pattern may also be explained by covert substance abuse. The use of stimulants such as amphetamine salts or methylphenidate can often improve performance in school, work, or athletics, all three areas where Ms. H has historically excelled. Stimulants are well known to potentially precipitate anxiety, and histories consistent with repeated panic attacks or other anxiety disorders are common. Intoxication from amphetamines, cocaine, hallucinogens, cannabis, and even caffeine, or withdrawal from alcohol, opiates, and other sedative, hypnotic, or anxiolytic substances, can cause anxiety and mimic panic disorder. Smoking is also a risk factor for panic attacks. In addition to substances, other iatrogenic causes should be considered. Some commonly prescribed medications are well known to cause anxiety, including steroids, anticholinergics, asthma medications, and anti-epileptics, among many others. Ironically, antidepressants sometimes have anxiogenic effects in some patients, especially if starting doses are too high or dose increases are too fast. The differential diagnosis of panic disorder includes consideration of the numerous medical conditions that can cause panic attacks. Table 3.1 lists some of the more common diseases. Although Ms. H is generally healthy and does not take any medications, acquiring a comprehensive medical, family, and social history, performing a thorough physical examination, and obtaining appropriate laboratory and imaging studies can help identify any potential underlying or insidious medical conditions that may be contributing to her panic attacks, Other than tachycardia or hypertension that can be seen in anxious states, no other abnormalities should be seen on workup. Treatment of panic disorder. Once a patient has been diagnosed with panic disorder, the next step is to determine the treatment. This is based on the clinical assessment of severity, extent of distress or impairment it causes the patient, and the patient's own preferences regarding treatment. The goal of clinical improvement can be simplified into reducing attack frequency, anticipatory anxiety, and phobic avoidance. Several classes of medications have been shown to be effective in treating panic disorder: selective serotonin reuptake inhibitors, SSRIs, serotonin norepinephrine reuptake inhibitors, SNRIs, tricyclic antidepressants, TCAs, monoamine oxidase inhibitors, MAOIs, and BZDs. As with depression, a clinically therapeutic effect may not be seen for several weeks with antidepressants. SSRIs and SNRIs are first-line treatments for panic disorder, as they are generally well tolerated and free of many of the side effects of TCAs and MAOIs. Choosing what antidepressant to use should be based on efficacy, side effect profile, overdose risk, cost, and individual psychiatric history. BZDs may also be effective in treating panic disorder. They may be used to provide more immediate relief on a short-term basis. The onset of clinical effectiveness of BZDs is very rapid, within hours, compared to that of antidepressants. BZDs have a distinct advantage when treating patients who are severely symptomatic and functionally impaired. The principal disadvantage of BZDs is the risk of tolerance and misuse, with long-term use complicated by significant comorbidity of alcohol abuse and panic disorder. The goal is to use a BZD at the lowest dose and for the shortest amount of time possible, with the intention of discontinuing it when the antidepressant medication becomes clinically effective. A list of common medications used for the treatment of panic disorder is provided in Table 3.2. Only generally accepted maintenance dosage ranges, for oral formulations, are used, and patients are started on lower doses to minimize adverse reactions. The maintenance dosages reflected here are indicative of total daily dosages, and depending on the medication, may be given in divided doses. This table is not meant to be exhaustive or inflexible. Patients must receive a personalized treatment plan based on individual characteristics. In terms of psychotherapy, cognitive behavioral therapy, CBT, is another effective treatment option for panic disorder. CBT educates patients and helps them better understand the core features of this disorder. By challenging cognitive distortions and associated behaviors, CBT may improve emotional regulation and assist with developing effective coping strategies. For Ms. H, who has not taken medications regularly before but has a history of utilizing counseling, CBT would be a good option to consider. Table 3.1. Medical conditions associated with panic attacks. Cardiovascular, hypertension, arrhythmia, angina, myocardial infarction, mitral valve prolapse, hypovolemia, endocrine, hyperthyroidism, hyperparathyroidism, adrenal insufficiency, hypercortisolemia, hypoglycemia, neoplastic, pheochromocytoma, carcinoid tumor, insulinoma, pulmonary, hyperventilation, asthma, chronic obstructive pulmonary disease, pulmonary embolism, pneumothorax, hypoxia, neurological, migraine, traumatic brain injury, seizure disorder, transient ischemic attack, cerebrovascular accident, multiple sclerosis, vertigo, encephalitis, other, anaphylaxis, menopause, porphyria, systemic lupus erythematosus. Table 3.2. Pharmacotherapy for panic disorder. Medication class. Selective serotonin reuptake inhibitors. Citalopram. Usual dosage range. Milligrams per day. 20 to 40. Escitalopram. Usual dosage range. Milligrams per day. 10 to 20. Fluoxetine. Food and Drug Administration approved for treatment of panic disorder. Usual dosage range. Milligrams per day. 20 to 80. Paroxetine. Food and Drug Administration approved for treatment of panic disorder. Usual dosage range. Milligrams per day. 10 to 60. Sertraline. Food and Drug Administration approved for treatment of panic disorder. Usual dosage range. Milligrams per day. 50 to 200. Medication class. Serotonin norepinephrine reuptake inhibitors. Desvenlafaxine. Usual dosage range. Milligrams per day. 50 to 100. Venlafaxine. Food and Drug Administration approved for treatment of panic disorder. Usual dosage range. Milligrams per day. 75 to 225. Duloxetine. Usual dosage range. Milligrams per day. 30 to 120. Medication class. Tricyclic antidepressants. Clomipramine. Usual dosage range. Milligrams per day. 100 to 200. Imipramine. Usual dosage range. Milligrams per day. 50 to 150. Medication class. Monoamine oxidase inhibitors. Isocarboxazid. Usual dosage range. Milligrams per day. 40 to 60. Phenelzine. Usual dosage range. Milligrams per day. 45 to 75. Tranylcypromine. Usual dosage range. Milligrams per day. 30 to 50. Medication class. Benzodiazepines. Alprazolam. Food and Drug Administration approved for treatment of panic disorder. Usual dosage range. Milligrams per day. 1 to 3. Clonazepam. Food and Drug Administration approved for treatment of panic disorder. Usual dosage range. Milligrams per day. 0.5 to 2. Diazepam. Usual dosage range. Milligrams per day. 4 to 40. Lorazepam. Usual dosage range. Milligrams per day. 2 to 6. Key points to remember. Panic attacks can occur in the context of any anxiety disorders, other psychiatric conditions, and medical illnesses. Anticipatory anxiety is a learned response that is the hallmark feature of panic disorder. Anticipatory anxiety consists of persistent worry and avoidance behaviors due to the fear of having another panic attack. 4. Fearing the outside world. Understanding agoraphobia. Gaith Shukri, MD, and Adriana M. Cortez, MD. Ms. S. is a 22-year-old woman that for the past 2 years has been experiencing intense fear and anxiety when using public transportation and when she is in a crowded public space such as a shopping mall. She fears these situations because she dwells on the fact that if she becomes panicked, she would not be able to seek immediate help. Whenever her boyfriend takes her out on a date, she must preemptively investigate the venue and make sure there are multiple exits. On many occasions, she cancels his great plans due to her fear that she may not be able to escape the venue. At a conference 2 years ago, she experienced an episode of intense fear that was triggered by lightheadedness and an upset stomach. Since then, she has avoided all in-person school events despite her interest in being socially involved and prefers teleconferences. She lives with her mother because she gets how I am. Leaving her home often requires that her mother accompany her. What do I do now? Agoraphobia is defined as marked fear or anxiety and/or avoidance of situations that may be difficult to leave or obtain help if severe panic-like symptoms occur. Typically, individuals with agoraphobia have more than one situation that they avoid. These can include the use of public transportation, open spaces, enclosed spaces, standing in line, being in a large crowd, and being outside of the home alone. These situations almost always provoke fear that is out of proportion to the actual danger posed by the situations. In the previous case, Miss S has been avoiding public transportation in crowded venues due to her fear of having a panic attack. Typically, agoraphobic patients will attempt to adapt their daily activities by avoiding potentially threatening situations and creating scenarios that reinforce the feeling of safety. Examples include mapping a secure zone locally within their neighborhood, exploring escape routes, and having trusted companions accompany them to the feared locations. Ms. S searches for exits at future events and has her mother accompany her outside the house. These conditioned behaviors can lead to ever-increasing social isolation, as well as an inability to venture out of familiar areas. Over time and without treatment, agoraphobia can lead to severe disabilities, such as loss of job and independence. At its most severe, patients can become housebound for years and suffer poor quality of life. Agoraphobia is present in approximately 1.7% of adolescents and adults worldwide. Women are twice as likely as men to have agoraphobia. Agoraphobia may occur in childhood, but the incidence peaks in late adolescence and early adulthood as seen in Ms. S. In 2/3 of all cases of agoraphobia, the initial onset is before age 35, with 21 years as the mean age of onset. The course of the condition is typically chronic and persistent, with complete remission being rare unless the agoraphobia is treated early in the course of the disorder. Like many anxiety disorders, agoraphobia affects individuals with high levels of neuroticism and highly sensitive to perceived anxiety symptoms. Stressful events that trigger anxious symptoms may lead to the onset of agoraphobia. The presence of panic disorder and other phobias is also a risk factor for the development of agoraphobia. A family history of anxiety disorders is associated with the earlier age of onset of agoraphobia, and a family history of panic disorder is particularly associated with agoraphobia, as described in the case of Ms. S. Differentiating agoraphobia from situational-specific phobia can be challenging, as these conditions share symptom characteristics such as avoidance of a variety of situations. The core difference is the focus of the fear. In specific phobia, there may be multiple feared situations or objects leading to the avoidant behavior. In agoraphobia, the fear is always the same: fear of having a panic attack in a situation where help or escape is unavailable. For example, in specific phobia and in agoraphobia, the individual may fear and avoid being in an elevator. The focus of the fear, however, is different. In specific phobia, the fear can be due to being trapped in an enclosed space. In social anxiety disorder, fear occurs in social situations. The distress, however, is provoked primarily by the belief that individuals who are present in these situations are constantly evaluating and judging multiple aspects of the afflicted individual. Avoidance is limited to social situations. In the case of Ms. S., she is able to socialize without difficulty as long as it is in the comfort of her own home. Panic disorder is the persistent worry about having a panic attack after having recurrent unexpected panic attacks and engaging in maladaptive behaviors due to that fear. Individuals with panic disorder can go on to develop agoraphobia. Most patients who have agoraphobia have concomitant panic disorder. In a minority of cases, agoraphobia can be diagnosed independently and irrespective of the presence of a panic disorder or other anxiety conditions. More typically, those who have agoraphobia alone are more likely to have an excessive fear of having an illness and a preoccupation with minor physical complaints of body functions. In the case of Ms. S., She has never had a panic attack, and she developed intense fear in a public setting after developing minor physical complaints. In acute stress disorder and post-traumatic stress disorder, the trigger is a severely traumatic event that can often place individuals in fear for their life and safety. The anxiety and/or avoidance are confined to the fear of re-experiencing the traumatic situation, versus an agoraphobia, where the distress is triggered by the fear of experiencing severe anxiety in a situation where escape may not be feasible. Separation anxiety disorder typically occurs in childhood before the age of 18. Like agoraphobia, patients suffering from separation anxiety disorder avoid situations that produce fear. However, in separation anxiety disorder, the driving force is the fear of being separated from their primary caregivers. Children will typically worry about significant harm occurring to their loved one when they are not together. In the evaluation of agoraphobia, areas that should be explored include the focus of the individual's fear, the type of avoided situations, and the compensatory behaviors utilized to minimize anxiety and fear. This detailed history gathering is essential for two reasons. It helps differentiate agoraphobia from other anxiety disorders, and it helps guide the proper treatment for a successful outcome. Assessing for other psychiatric conditions is also essential, as comorbidities are common. As in most anxiety disorders, it is also important to have a thorough medical history to rule out medical causes that may manifest in similar presentation and symptomatology. In addition to a basic diagnostic workup, urine toxicology may be warranted because of its comorbidity with substance use. Assessment of the severity of the condition by addressing the level of distress and impairment in the individual's function is necessary to guide proper management and treatment choices. There are a number of assessment scales to aid the clinician in diagnosis. The American Psychiatric Association offers a 10-item severity measure for agoraphobia scale as a tool to assess the severity of symptoms of agoraphobia that is useful to enhance medical decision-making and monitor treatment progress. About 90% of individuals with agoraphobia also have other psychiatric disorders. Most commonly, patients have other anxiety disorders, such as panic disorder or generalized anxiety disorder, as well as post-traumatic stress disorder, clinical depression, and addiction. Whereas other anxiety disorders usually precede the onset of agoraphobia, depressive disorders and substance use disorders typically occur secondary to agoraphobia. Approximately 15% of individuals with agoraphobia report suicidal thoughts or behavior. Thus, a suicide risk assessment should always be part of the evaluation. Individuals with comorbid agoraphobia and major depressive disorder tend to have a more treatment-resistant course than individuals with agoraphobia alone. Regardless, it is of the utmost importance that patients with significant anxiety disorders, including agoraphobia, be recognized and treated early in the course of the illness to improve outcomes. Treatment. Although agoraphobia is differentiated from panic disorder in the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, text revision, the treatment algorithm remains similar for both conditions. Individuals are typically treated with a combination of psychotherapy and pharmacotherapy. Cognitive behavioral therapy, CBT, has been shown to alleviate the target symptoms and improve quality of life. Obtaining a detailed history of the type of avoided situations and avoidant behavior helps guide the individualized behavior modification needed to improve functionality. Strategies commonly utilized include breathing and relaxation exercises and gradual exposure to the feared situations to overcome avoidance. In Ms. S's case, treatment would focus on a reduction in worry, fear, and the physical aspects of anxiety, while gradually exposing her to situations outside her home that she consistently avoids, such as public transportation, attending meetings in person, and crowded venues. Medication management in agoraphobia is used to target anxiety symptoms and other physical and neurovegetative symptoms that arise. It is necessary to use the medications in conjunction with CBT to successfully treat the conditioned avoidant behavior. There are several effective options for medication management. Selective serotonin reuptake inhibitors and serotonin norepinephrine reuptake inhibitors are considered first-line therapy given their tolerability and safety profile. Tricyclic antidepressants, monoamine oxidase inhibitors, and benzodiazepines are also considered effective in the treatment of agoraphobia. As with other anxiety disorders, these regimens are typically not considered first-line due to safety concerns, side effects, and in the case of benzodiazepines, the possibility of tolerance and misuse. Key points to remember. If not recognized and treated early, agoraphobia can lead to crippling dysfunction and poor quality of life. In the evaluation of agoraphobia, areas that should be explored include the focus of the individual's fear, the type of avoided situations, and the compensatory behaviors utilized to minimize anxiety and fear. It is necessary to use the medications in conjunction with CBT to successfully treat the conditioned avoidant behavior. 5. The chronic worrier. Jacob Rosewater, MD, and D. Jeffrey Newport, MD, MS, MDiv. Ms. E is a 34-year-old woman who complains of difficulty sleeping since her teenage son tested positive for COVID a few days earlier. This is the first person in her life to test positive for COVID. "I've been so worried about him that I can't fall asleep," she says. She adds that she has had trouble sleeping on and off for several years, causing her to miss multiple deadlines at work due to fatigue and difficulty concentrating. She also describes frequently arguing with coworkers. "I can't help but think that something is wrong with me," she says. "I am exhausted, tense, and sore all over." She worries about multiple issues including her finances, work, and the well-being of other family members. She acknowledges she has difficulty controlling these thoughts. She has never been prescribed any medications. She does not endorse any history of depressive symptoms or suicidal or homicidal thoughts. She may drink a glass of wine on social occasions, but has never used illicit drugs. What do I do now? Anxiety can be a normal part of day-to-day life. People commonly worry about things such as their health, loved ones, or finances. However, there comes a point when constantly feeling worried or nervous becomes detrimental to one's well-being. It can be challenging to distinguish normal worry over situational stressors from an anxiety disorder. Generalized anxiety disorder, GAD, is among the most common mental disorders, with 6% to 9% of people experiencing GAD during their lifetimes. In any given year, up to 6.8 million adults, or 3.1% of the U.S. population, are affected by GAD, with women 2 to 3 times more likely to have the disorder. GAD tends to arise gradually and may occur at any age, though there are 2 peak periods of vulnerability to the onset of GAD. These occur during late adolescence through the early 20s and later between the ages of 30 and 50. Some studies suggest there may be a third peak of onset, or so-called late-life GAD. 90% of those with GAD also have at least one co-occurring psychiatric disorder, most often major depressive disorder. Ms. E, the patient in this scenario, comes to the clinic with a chief complaint of insomnia, distressed over the state of her son's health following a positive COVID test. However, in observing the patient's behavior and considering other information she shares, one must consider if there is more underlying her distress. She describes an extended pattern of being unable to control her excessive worry, coupled with fatigue, difficulty concentrating, muscle tension, and sleep disturbance. Per the Diagnostic and Statistical Manual of Mental Health Disorders, 5th edition, text revision, criteria, a patient with uncontrollable excessive anxiety or worry that is present more days than not for at least 6 months, and who experiences 3 or more of the following symptoms: restlessness, easy fatigability, difficulty concentrating, irritability, muscle tension, and sleep disturbance, qualifies for a GAD diagnosis. Her symptoms should not be better explained by a medical illness, a substance, or another mental disorder. The Generalized Anxiety Disorder 7-Item Questionnaire, GAD-7, Figure 5.1, an efficient validated tool for GAD screening, can be used to assess GAD severity and monitor changes in symptom severity over time. Scores on the GAD-7 range from minimal anxiety, 0 to 4, mild anxiety, 5 to 9, and moderate anxiety, 10 to 14, to severe anxiety, greater than or equal to 15, with scores of 10 or higher generally recognized as identifying GAD. One must also consider whether the anxiety response of Ms. E to the situational stressor she is facing may be expected, appropriate, and non-pathological, that is, normal. The key distinction is that normal anxiety is not pervasive and uncontrollable and does not cause severe distress or functional impairment. However, Ms. E has shared that her anxious symptoms have caused her to miss deadlines at work and argue with coworkers. In addition, GAD is characterized by the persistence of anxiety in a variety of contexts. She has already alluded to the fact that her struggles with insomnia have been present for several years. Upon further questioning, one would quickly learn that she has struggled with worry most of the time for far longer than the requisite 6-month threshold. Once convinced that the patient's symptoms are in fact pathological, it is important to work through the differential diagnoses, screening for disorders that overlap or otherwise resemble GAD in some way. Adjustment disorder, characterized by the emergence of anxiety or other emotions and behaviors in response to a readily identifiable stressor, is high on the differential diagnosis list for this patient, as she attributes her current worry and trouble sleeping to her son's recent COVID diagnosis. Indeed, if this were the lone instance in which she had experienced such stressor-triggered anxiety, adjustment disorder would be the appropriate diagnosis. However, upon further questioning, it emerges that she has struggled with anxiety over time in response to a wide array of stressors, leading to the conclusion that her son's COVID diagnosis has exacerbated a pre-existing anxiety disorder rather than triggering a new adjustment disorder. The assessment continues with exploring other anxiety disorders, particularly panic disorder and social anxiety disorder, SAD. She does not appear to have recurring unexpected panic attacks, although panic attacks are experienced by some with GAD. These abrupt, unexplained surges of intense discomfort or fear are infrequent in GAD in comparison to panic disorder. SAD can contribute to interpersonal difficulties at work, such as those described by this patient. However, whereas those with GAD worry about an array of concerns, including their evaluation by others, the fear experienced by individuals with SAD is limited to fear of embarrassment in social encounters, where they must perform or be evaluated by others. Obsessive-compulsive disorder, OCD, also warrants consideration, as the worry of GAD must be distinguished from the obsessions of OCD. The key distinction is that the focus of worry in GAD is upon currently unfolding or upcoming problems, such as this patient's concern with her son's COVID diagnosis. The obsessions of OCD are unwanted and intrusive thoughts, urges, and images that reflect discomfort in not performing ritualistic tasks or following rigid rules. It is important to explore past traumas, including but not limited to childhood maltreatment, serious accidents, illnesses or injuries, or other forms of violence. Anxiety naturally occurs in post-traumatic stress disorder, PTSD, and can thus resemble GAD. However, the anxious distress of PTSD is invariably triggered by a cue linked in some way to a past trauma. For example, had this patient been previously traumatized by the death of a loved one due to COVID or a similar infectious disease, then her current anxiety could indeed be a manifestation of PTSD. However, she does not report any such traumatic experience in her past. Somatic symptom and illness anxiety disorders are certainly worth considering in a patient with vague physical complaints and a preoccupation with a serious illness such as COVID. However, the patient has not had a pattern of frequent encounters with healthcare professionals, nor does she seem excessively concerned about her own health, as would be expected with such disorders. Finally, worry and generalized anxiety is commonly associated with major depressive disorder, bipolar disorder, and psychotic disorders. In fact, anxiety is a very common mental condition to co-occur with bipolar disorder. If heightened anxiety is experienced solely in the context of a mood or psychotic disorder, then a diagnosis of GAD is not warranted. In addition, certain symptoms of GAD, including restlessness, sleep disturbance, and irritability, may resemble those of hypomania or even mania. Consequently, it is possible to mistake GAD for hypomania/mania, or vice versa. It may help to clarify whether the patient has ever experienced a period of several days during which she needed very little sleep. This decreased need for sleep is specific to mania and can be distinguished from insomnia accompanied by excessive fatigue after a sleepless night. Having determined that the patient's symptoms are most consistent with GAD, it is necessary to determine whether her symptoms are being caused by a medical illness, a medication, or an illicit substance. Anxiety can be caused by many medical conditions, including endocrine disorders such as hyperthyroidism, hyperparathyroidism, hypoglycemia, and pheochromocytomas, complex partial seizures, central nervous system tumors, multiple sclerosis, strokes and transient ischemic attacks, and menopause. Gastrointestinal disorders such as peptic ulcer disease and carcinoid can produce anxiety, as can cardiovascular and pulmonary disorders, though the latter two are more often associated with panic attacks. A careful medical history combined with physical examination and focused laboratory testing can help determine whether a medical illness underlies the symptoms of anxiety. Numerous medicines and illicit drugs can produce anxiety resembling GAD. This can be especially true if a patient is taking too much of a prescribed medication. This keyed-up state can be caused by central nervous system stimulants, such as cocaine, methamphetamine, caffeine, over-the-counter herbal stimulants such as ephedra, and prescription psychostimulants such as methylphenidate, modafinil, and amphetamines. In rare instances, thyroid hormone supplementation with thyroxine or triiodothyronine can cause anxiety. Systemic treatment with steroids can cause many psychiatric symptoms, including anxiety. Acute withdrawal from central nervous system depressants such as alcohol, barbiturates, and benzodiazepines, BZDs, can also cause anxiety, and if left untreated, the withdrawal can rapidly escalate to panic attacks, seizures, and delirium. Mild opioid withdrawal can also produce symptoms resembling GAD. GAD-7. Over the last 2 weeks, how often have you been bothered by the following problems? Rate each of the following on a scale of 0 to 3, with 0 being none at all, 1 being several days, 2 being more than half the days, and 3 being nearly every day. 1. Feeling nervous, anxious, or on edge. 2. Not being able to stop or control worrying. 3. Worrying too much about different things. 4. Trouble relaxing. 5. Being so restless that it is hard to sit still. 6. Becoming easily annoyed or irritable. 7. Feeling afraid as if something awful might happen. Figure 5.1, Generalized Anxiety Disorder 7-Item Questionnaire, GAD-7. Etiology. While the exact cause of GAD is unknown, evidence suggests that it is some combination of biological factors, family background, and life experiences, particularly stressful ones. Genetic factors appear to predispose individuals to developing GAD, which shares common heritability with major depression and the personality trait of neuroticism. In addition, childhood trauma and recent stressful life events appear to interact with genetic vulnerability to increase the likelihood of GAD emerging. Neurotransmitter disturbances, evidenced by elevated levels of norepinephrine and serotonin metabolites, as well as elevated inflammatory biomarker levels, are found in those with GAD. Additionally, GAD is associated with differences in the brain's structure and function. Decreases in the brain's white matter volume and the size of the hippocampus, a key structure in the brain's emotional regulation network, have been seen in those with GAD. Studies of brain function indicate that in GAD, emotional dysregulation may be due to diminished activity within certain higher cortical brain regions and poor connections between these higher regions and the amygdala, a structure in the more primitive midbrain that processes fearful stimuli. Finally, processing of emotional information, personality factors, and cognitive origins of worry may all play a role in GAD development. For example, individuals with GAD may be more likely to interpret ambiguous material in a negative way, rendering them more timid in novel situations. They may in turn develop the habit of worrying as an attempt to solve problems or avoid normal fear responses, making it difficult for them to tolerate uncertainty. Treatment. Once a patient has been diagnosed with GAD, the next step is to determine whether treatment is needed. Patients with a mild form of GAD, whose symptoms interfere little with daily functioning, may initially not seek any treatment. It is important to check in regularly with these patients to monitor any changes in symptom severity or difficulties with daily functioning. The mainstays of treatment for GAD are antidepressants and psychotherapy, namely cognitive behavioral therapy, CBT. Treatment plans must be individualized to the patient, and the patient ideally should be actively involved in treatment selection. While the combination of psychotherapy and medications may be more beneficial than either alone, some individuals may have a strong preference to start with just one treatment modality. For example, some patients may be concerned about possible medication side effects and prefer to start with psychotherapy. Conversely, some patients worry about the time commitment of attending psychotherapy. In fact, patients with severe symptoms may at first be effectively unable to engage and participate in CBT. Thus, these patients should start treatment with medication, and once anxiety symptoms improve, they may better tolerate psychotherapy. The first-line pharmacotherapy for GAD is a class of antidepressant medications called serotonergic reuptake inhibitors, SRIs, which include selective serotonin reuptake inhibitors and serotonin norepinephrine reuptake inhibitors. Although buspirone has a Food and Drug Administration indication for treating GAD, it is not recommended as a first-line treatment due to its ineffectiveness for depression, which is frequently experienced by those with GAD. When treating anxiety, SRI should be started at a low dose for at least 1 week to minimize initial side effects. In fact, although SRIs effectively treat GAD, starting an SRI at too high a dose may actually worsen anxiety in the near term. One common issue contributing to medication noncompliance is that early side effects lead to discontinuation before a medication has had adequate time to alleviate anxiety. After this initial low-dose startup, the dose is increased to the therapeutic range. For those with an inadequate SRI treatment, the next best step is to add psychotherapy. Among the psychotherapy alternatives, CBT has by far the most extensive evidence to support its effectiveness. Acceptance and commitment therapy also have evidence supporting its use for GAD. The recommended duration of the course of CBT depends on many factors, such as the patient's symptom severity, co-occurring psychiatric disorders, and treatment resistance. GAD patients typically complete 10 to 15 psychotherapy sessions, although they may be encouraged to continue practicing CBT skills to prevent relapse. For patients who still have responded poorly to the combination of SRI with CBT, Medication changes are recommended next. First, they should switch the SRI with a different SRI. If switching medications remains unhelpful, then augmentation is the next step. Buspirone is the preferred augmentation strategy when treating GAD. A common prescribing error with buspirone is recommending patients to use it as needed. Like antidepressants, buspirone requires regularly scheduled dosing over several weeks to produce any treatment benefit. The use of BZDs has a controversial history due to their potential risk for abuse or misuse. But in select individuals with severe or treatment-resistant GAD, they have been proven as effective in reducing anxiety and other associated symptoms. If using a BZD when treating GAD, it is preferable to utilize a longer-acting BZD on a scheduled once-daily or twice-daily basis. As-needed use of BZD should be avoided when treating GAD, as doing so increases the reliance upon the BZD and thereby interferes with the progress of CBT. Ideally, when treating GAD, BZD should be a short-term measure used to hasten relief from the most severe symptoms of GAD. BZD therapy is complicated by its many potential adverse effects and the risk of withdrawal upon discontinuation. Side effects include psychomotor impairment, forgetfulness, and possible rebound anxiety after a short-term treatment. Patients taking BZD should be educated on the risks of adverse effects, interaction with other medications and substances, including alcohol, dependence, and withdrawal. In addition to medications and CBT, medically stable patients are recommended to engage in exercise and mindfulness-based practices such as yoga, which have been shown to aid in reducing GAD symptoms. High-intensity exercise appears to be more effective than low-intensity exercise, in combination with first-line GAD treatment for patients who can tolerate it. The recommended length of antidepressant use in a patient with GAD fully responding to treatment is at least 12 months. If the patient experiences a return of symptoms after treatment has been stopped, the treatment may be resumed and extended. Long-term maintenance treatment for GAD is recommended if symptoms have returned after more than 2 attempts to discontinue medication. Key points to remember. GAD is one of the most common mental disorders. GAD may not always present with obvious excessive worrying, but rather other symptoms such as irritability, difficulty concentrating, sleep disturbances, muscle tension, restlessness, and/or fatigue. The GAD-7 is a valid and efficient tool for screening for GAD and quantifying changes in symptom severity over time. It is important to rule out all medical or substance-induced causes of anxiety symptoms before making a diagnosis of GAD. First-line treatment of GAD is a combination of an SRI antidepressant and CBT, although patients often prefer to try one or the other alone first. 6. Anxious in the spotlight. Social anxiety disorder, or simply avoidant. Vishnu Tiwari, MD, and Elisa Diaz, PsyD. Mr. C is a 28-year-old graduate student who presents to the outpatient clinic complaining of anxiety. Mr. C has always had problems fitting into large groups. He states that since joining a new research group in the past year, his feelings of anxiety in social situations have significantly intensified. He remembers being shy throughout school. He recalls severe difficulties with public speaking, which did not improve after he took a semester of oratory in college. Lately, Mr. C has been receiving more invitations to hang out with his colleagues. He becomes anxious in anticipation of the dinner or bar crawl that he is invited to. When he occasionally makes it to these gatherings, he becomes sweaty and flushed when spoken to, stammering, worrying that he will be seen as boring or awkward. After these events, he finds himself overthinking every word and interaction for days at a time. He is worried that he will not be able to make friends or develop relationships. What do I do now? Social anxiety disorder is a problem for millions of people around the world. As the name suggests, it is a common anxiety disorder marked by intense or marked fear that emerges in response to social situations. Individuals with social anxiety, as described in the case of Mr. C, fear negative evaluation in group settings and endure social interaction with extreme distress. Often, they avoid social settings in an attempt to prevent this anxiety. Public speaking, attending parties, being observed eating food, and going to public restrooms are common triggers for patients with this condition. Social anxiety disorder is highly pervasive and distressing to its sufferers and can cause great functional impairment in multiple social and occupational domains. Social anxiety disorder remains misunderstood and even overlooked by medical professionals. As such, a review of its features and management is important. Social anxiety disorder is characterized by severe anxiety that individuals experience in social situations. This anxiety is often disproportionate to the actual situation and persists for a duration of at least 6 months. Furthermore, it is commonly accompanied by a fear of negative judgment or evaluation by others in social settings. The majority of social situations are associated with fear and anxiety. The anxiety that is experienced by the individual is out of proportion to the situations and causes great distress. Social anxiety often develops in patients at a young age, with the median age of onset being 13 years in the United States. The disorder may develop following exposure to a traumatic social situation, such as being humiliated publicly, or may develop slowly and organically out of a long-standing pattern of social reticence and shyness at a young age, as in the case of Mr. C. Social anxiety disorder is highly prevalent, occurring in as many as 8% of adults in any given year, and 13% of adults over their lifespan. The disorder appears to be more common in women compared to men, with a near 2-to-1 distribution. Yet, in spite of how common the disorder is, it is relatively underrepresented as a reason for psychiatric consultation. Rather than initially presenting to psychiatrists or mental health professionals, patients with social anxiety disorder often first present to family or general physicians. Patients with social anxiety who find themselves seeking a psychiatric referral tend to have a number of other psychiatric comorbidities that may be recognized first. Importantly, social anxiety disorder is highly comorbid with other anxiety and mood disorders, as well as substance use problems. When social anxiety disorder is comorbid with major depression, there is a higher rate of suicide attempts than with major depression alone. Like other phobic disorders, it is highly prevalent with alcohol abuse. This pattern of alcohol use can be due to self-medication for management of anxiety or shared genetic vulnerabilities to alcohol use, or both. The disorder is particularly comorbid in geriatric patients with mood disorders. In adolescents, the disorder tends to be comorbid with autism spectrum disorder and selective mutism. In women, major depressive disorder is more comorbid with social anxiety. In men, social anxiety disorder tends to be more comorbid with conditions that have overt behavioral problems, such as antisocial personality disorder and oppositional defiant disorder. Research has identified a number of candidate genes associated with introversion, a personality trait strongly linked to the development of social anxiety disorder. On a neuroanatomical level, imaging studies of individuals with social anxiety disorder demonstrate signal abnormalities in the corticolimbic and corticostriatal circuits. While genetic and biological factors may influence susceptibility to developing social anxiety disorder, it is believed that behavioral influences strongly modify this risk. Bullying and peer victimization in children are associated with increased rates of social anxiety disorder. Adverse childhood experiences, such as neglect, are also associated with later development of social anxiety disorder in adults. It is also highly possible that some of the increased risk of developing social anxiety disorder that clusters in families can be explained by learning theory, with children learning maladaptive coping habits from affected adults. Though it may seem self-evident, the diagnosis of social anxiety disorder can be quite complicated. It requires careful differentiation from other anxiety disorders, temperamental traits, and even personality disorders. Social anxiety may be comorbid with these conditions that bear consideration by providers during evaluation of patients with anxiety in social situations. One such condition is temperamental shyness. Many individuals are less inclined toward social interaction than their peers. Temperamental shyness alone is usually not associated with significant functional impairment and does not constitute a disorder. It is important to know that only a small minority of individuals who are temperamentally shy meet criteria for social anxiety disorder. The social avoidance in the disorder is ego-dystonic rather than ego-syntonic. That is, individuals with social anxiety disorder have full knowledge that their fears are out of proportion to the situation and in direct conflict with their desire to participate in social activities. Individuals like Mr. C desperately want to attend social events and speak in public without distress or constant second-guessing. A predominantly anxious personality subtype, known as avoidant personality disorder, shares many of the same features as social anxiety disorder. Individuals with avoidant personality disorder have a persistent pattern of avoiding interpersonal activities, exhibit rejection sensitivity, frequently view themselves as socially inept, and are averse to taking social risks. Unlike social anxiety disorder, however, avoidant personality disorder is marked by a much broader pattern of social avoidance and a more totalizing, global sense of negative self-worth and aversion to interpersonal interaction that begins in early childhood. Individuals with avoidant personality disorder can create a long-standing social fear aimed at avoiding interactions with others in a large number of situations. For example, these individuals may work from home or work in careers that avoid interacting with others and may avoid shopping at the same store twice. They may have difficulty having close friends outside of their immediate family and have a paucity of long-term intimate relationships. Additionally, they may have a tendency to rationalize their fears and avoidance. Nonetheless, individuals with avoidant personality disorder can go on to develop acute episodes that meet criteria for social anxiety disorder. In the case of Mr. C, although he has a long pattern of avoidance in select social situations, they are not all-encompassing, and he recognizes that his irrational thoughts are often unfounded. Occasionally, social anxiety disorder needs to be distinguished from higher-functioning forms of autism spectrum disorder. Unlike individuals with autism, individuals with social anxiety have the capability of maintaining normal interpersonal relationships and often have many friends. Individuals like Mr. C with social anxiety disorder may have panic attacks triggered by social situations. In panic disorder, panic attacks may occur without a discrete trigger, but in social anxiety disorder, the specific trigger is often due to the fear of a negative social evaluation. Treatment. In clinical settings, social anxiety disorder is common among patients presenting for evaluation of anxiety symptoms. There are validated instruments available that can be used to screen for social anxiety disorder in ambulatory settings. The Mini Social Phobia Inventory is a brief 3-question scale with good sensitivity and specificity. The Leibowitz Social Anxiety Scale is a longer, patient self-reported questionnaire. It assesses numerous situations that can socially lead to fear and anxiety. Additionally, patients with social anxiety disorder also tend to be reluctant to discuss their symptoms with family physicians and even psychiatrists. As such, empathetic communication and simple screening questions, do you find yourself avoiding social activities more than usual, can be effective ways to screen for the presence of social anxiety disorder. Social anxiety disorder is often chronic, and patients live with this disorder for many years prior to seeking treatment. Those who seek help often do so because of an intolerable situation that has negatively affected their lives, or a comorbid condition such as depression or substance use disorder that is worsening functional impairment. It may require time and effort for patients to decide what course of intervention fits their needs, if any at all. Patients who meet criteria for social anxiety disorder and warrant treatment could benefit from interventions that can significantly improve symptoms and increase quality of life. Both psychotherapy techniques rooted in cognitive behavioral therapy, CBT, and pharmacotherapy are effective options for treatment. While there is limited head-to-head evidence comparing pharmacotherapy and CBT, the available information suggests that they are equally effective. Evidence suggests that pharmacotherapy tends to produce remission of symptoms slightly faster than CBT, but the effects of CBT seem to last longer. In choosing a treatment modality, providers should attend to patient preference and prior response to treatment, and if either option has been effective in the past. Factors that favor pharmacotherapy include intense aversion to anxiety-provoking stimuli that are frequently part of desensitization procedures in behavioral therapy. Patients who prefer not to use medication may find psychotherapy a more appropriate starting point. Combining CBT and medication management options, interestingly, is not shown to have any advantage in treating social anxiety over using either option alone. Psychotherapy. Prior to the use of pharmacotherapy, desensitization techniques based on learning theory were used to treat social anxiety. Desensitization techniques are based on the observation that prolonged exposure to anxiety-provoking stimuli, which increases anxiety in the short term, actually leads to reductions in anxiety in the long term. The behavioral piece of CBT features techniques based on the principle of desensitization, such as exposure and response prevention, which entails exposing patients to increasingly more stressful social situations until their anxiety habituates. The technical details of exposure regimens can vary, but patients may create hierarchies of stressful social situations and begin exposing themselves and graduate to higher levels with practice. Other behavioral techniques integrated into CBT regimens involve attention modification exercises and reduction of avoidance routines in social situations. Cognitive elements of CBT involve identifying and modifying maladaptive cognitions that are involved in social avoidance. Other psychotherapeutic modalities that may work with other anxiety conditions, such as mindfulness-based therapy, short-term psychodynamic therapy, supportive therapy, and interpersonal therapy, appear to be less effective in treating social anxiety. Pharmacotherapy. Selective serotonin reuptake inhibitors, SSRIs, are the first-line choice for treatment of patients with social anxiety disorder due to their efficacy as well as their tolerability. SSRIs can take weeks to achieve their intended therapeutic effect. Side effects may include diarrhea, fatigue, headache, and increased anxiety, especially in the initial weeks of treatment, and sexual side effects in the long term. SSRI-associated anxiety can be mitigated by cautious dosing or careful use of benzodiazepines during the initial treatment phase. In individuals who do not respond to SSRIs, selective serotonin norepinephrine reuptake inhibitors, such as venlafaxine or duloxetine, are reasonable treatment choices. The appropriate duration of treatment with serotonergic medications for social anxiety disorder is not known, but it is reasonable to continue medication for at least 3 to 6 months following remission of symptoms, before considering down titration or discontinuation of medication. Benzodiazepines such as clonazepam are also effective, but are more sedating and contraindicated in patients with a history of substance use disorder. Patients with the performance subtype of social anxiety disorder may sometimes benefit from beta blockers such as propranolol, which reduce symptoms of sympathetic activation, such as tachycardia and diaphoresis. Propranolol should be taken prior to the feared performance. Benzodiazepines may also be used for performance anxiety, but are more sedating. Interestingly, the anticonvulsant pregabalin has shown some efficacy in treating symptoms of social anxiety relative to placebo in some randomized control trials, and may be an efficacious treatment option. Key points to remember. Social anxiety disorder is a highly prevalent, chronic, and disabling anxiety disorder that is often underreported by patients. Social anxiety disorder is characterized by the presence of disproportionate anxiety in social situations, which causes significant impairment in patients and occurs for at least 6 months. Social anxiety disorder can be treated with either psychotherapy or pharmacotherapy. Common psychotherapeutic approaches involve CBT and exposure and response prevention paradigms. 7. When Fear Takes Flight. Bashaline Joseph, D.O., and Marissa Echenique, M.A.M.S., PsyD. Mr. M is a 40-year-old veteran who presents to the clinic complaining of the inability to travel by plane. His best friend is celebrating a bachelor's party in Las Vegas in 2 months' time, and Mr. M is severely distressed about the thought of a 5-hour flight. Mr. M avoids flying whenever possible. On the rare occasion he agrees to fly, he consumes significant amounts of alcohol, both prior to and during the flight. He says he drinks to dampen the severe anxiety he experiences when he thinks about flying or is about to get on a plane. His symptoms include heart palpitations, sweaty palms, nausea, and an overall feeling like I am having a heart attack. Mr. M has a job where he does not need to travel. However, whenever the need arises to visit family and friends across the country, he will drive, despite his need to spend precious vacation days in the car. He tells family that he loves to drive, and this is not a burden to him. The fear of flying began years previously, when, during a flight, the plane had a technical malfunction and made an emergency landing. Additionally, he expresses an irrational fear of snakes that dates back to childhood. This, however, does not interfere with his life, as he finds it easy to avoid snakes. What do I do now? Specific phobia is one of the most common psychiatric disorders in the population. The core feature is fear of or anxiety to a specific situation or object that is so intense that it causes severe distress that leads to impairment. A significant majority of the U.S. population develops unreasonable or intense fears of simple objects, living things, or situations. Despite the abundance of individuals with fears, most do not meet the criteria for a specific phobia disorder diagnosis. To qualify as a disorder, the severity of fear, both in anticipating or in exposure to the situation or object, is intense. Additionally, it leads to dysfunction in their lives. Individuals with specific phobias experience intense and immediate anxiety when exposed to their feared stimuli, or even when anticipating encountering them. This anxiety is often disproportionate to the actual threat posed by the phobic object or situation. A hallmark of specific phobias is the adoption of avoidance strategies. Individuals will go to great lengths to avoid their feared stimuli, which can significantly impact their daily functioning. For instance, as in the case of Mr. M, someone with a fear of flying might refuse to travel or endure extreme distress during flights. Specific phobias can encompass a wide array of fear triggers, including heights, particular animals, or exposure to blood. Prominent examples include arachnophobia, the dread of spiders, acrophobia, anxiety related to heights, claustrophobia, fear of confined spaces, and aviophobia, a terror of flying. Specific phobias can substantially disrupt daily functioning, as individuals often go to great lengths to avoid their feared stimuli, which can in turn impose limitations on their activities and quality of life. Most individuals who suffer from the disorder do not seek out clinical care. Instead, they may simply avoid the object or situation. Unfortunately, in the case of Mr. M, he has a fear of flying. He has taken strides to avoid flying. He now seeks care because this avoidant behavior is affecting his quality of life, and has led him to misuse alcohol. Specific phobias can occur at any time of life. Sometimes they occur in early childhood, as in the case of Mr. M, where he developed a fear of snakes as a young child. They also can occur during adulthood and later in life. Specific phobias are more prevalent in women during childbearing age. If untreated, this disorder tends to persist throughout life. Specific phobias are commonly associated with other anxiety disorders, depressive disorder, and substance use disorder. Many factors influence the development of major phobias, including biological, psychological, and social and environmental factors. Phobias may be triggered by exposure to an object or event that is perceived as traumatic. Other individuals may be unable to recall a traumatic event. Specific phobia often runs in families. Genetic factors may interplay with the afflicted family member's experience with the dreaded phobic stimuli. Treatment. Specific phobias are rarely diagnosed or treated due to ease of avoiding the phobic stimuli. About 10% of people with specific phobias seek treatment. Individuals with phobias related to flying, closed spaces, or heights are most likely to seek treatment since they typically cause significant impairment or distress in daily functioning and lifestyle. Mr. M has an extreme fear of flying, which results in extreme distress. Even the thought of flying 2 months from now causes intense anticipatory anxiety, leading him to seek care. The fear is so intense that he avoids traveling by airplane for work or pleasure. Table 7.1 details the advantages and disadvantages of select treatments for a specific phobia disorder. The treatment of choice is cognitive behavioral therapy, CBT. This treatment modality involves both cognitive and behavioral approaches that aim to change distressing maladaptive thoughts and behaviors. Graded exposure is uniquely suited for a specific phobia. It consists of repeated, gradual, and systematic confrontation of the feared stimulus to facilitate fear reduction through extinction and inhibitory learning. There are different types of exposure therapy. During in vivo exposure, the feared stimulus is confronted in real-world situations in a safe and controlled manner. Guided imagery exposure can also be used. However, it is routinely combined with in vivo exposure. In guided imagery exposure, the individual confronts the stimulus using his or her imagination. This type of exposure is often used with flying or storm phobia due to difficulties in recreating such experience in real life. Virtual reality exposure is promising. However, its availability is limited primarily due to cost. Other CBT strategies used to target specific phobias include techniques associated with managing anxiety symptoms. These include diaphragmatic breathing, breathing retraining, progressive muscle relaxation, or guided imagery relaxation to reduce symptoms associated with states of arousal. When used to confront the phobic stimulus, such techniques over time assist with decreasing somatic symptoms, such as increased heart rate, difficulty breathing, dizziness, nausea, and vomiting. Mr. M would benefit from using these strategies during takeoff, landing, or turbulence. Medication is not a first-line treatment for specific phobia. Medications may be beneficial if CBT with exposure is not available, or the patient is unable to tolerate any type of exposure. In the previous patient scenario, Mr. M rarely flies, and he presented to the clinic 2 months prior to his flight. In this case, a benzodiazepine with a rapid onset of action, such as lorazepam or alprazolam, can be used for the sudden relief of symptoms. The benzodiazepine can be taken prior to boarding the plane. Its fast onset of action and its short half-life make it ideal for a 5-hour flight. Side effects include sedation, impaired psychomotor performance, fatigue, cognitive impairment, vertigo, and abuse potential. It is important to warn patients to avoid consuming alcohol and the drug together due to exacerbation of sedation, confusion, and impaired coordination. Table 7.1 Advantages and disadvantages of treatment options. Cognitive therapy. Advantages: helps address cognitions or possible faulty thinking contributing to the phobia. Disadvantages: may take longer than other treatment options to feel relief or improvement. Behavior therapy. Advantages: improvement could be seen quickly. Disadvantages: potential re-traumatization or heightened anxiety if readiness level and intervention are not appropriate. Benzodiazepines. Advantages: provide immediate relief due to quick onset of action at the time of exposure. Disadvantages: potential for abuse and undesirable side effects, not a permanent solution. Key points to remember. Specific phobias are a common psychiatric condition in the community. Specific phobias are long-lasting, may cause intense physical and psychological reactions, and can affect a person's ability to function normally at work, at school, or in social settings. Specific phobias are chronic in nature and may persist over many years, and in most cases, individuals do not seek clinical care. Specific phobias are associated with multiple psychiatric conditions. The treatment of choice for specific phobias is exposure therapy. 8. When fear collides. Panic attacks within the spectrum of anxiety disorders. Firas Alkarbouche, MD, and Lujain Alhaji, MD. Ms. A is a 30-year-old female with generalized anxiety disorder, GAD, that improved after a course of cognitive behavioral therapy, CBT, during college. She presents with the acute onset of palpitations, shortness of breath, clammy hands, trembling, nausea, and sweating. She has never experienced these symptoms before and is concerned she might be having a heart attack. Her symptoms started as she began to give a presentation at her workplace. She reported feeling anxious leading up to the presentation and was worried about embarrassing herself by stumbling on her words and being negatively judged. She describes herself as a chronic worrier who tends to ruminate, with anxiety making her feel blank, tense, and restless, and interrupting her sleep. She has struggled to establish new relationships at work, wishing she was more comfortable around people. What do I do now? Reaching the correct diagnosis after a patient experiences a panic attack can help tailor the right treatment approach. While patients will naturally become distressed about the sudden and severe somatic symptoms that are the nature of panic attacks, there are clues to refining the diagnosis and guiding the proper management. Like in many psychiatric disorders, gathering a thorough medical and psychiatric history, clarifying the timeline of the symptoms, identifying triggers, and assessing for comorbidities are valuable in determining a potential underlying diagnosis. Ms. A presents with a panic attack, evident by the sudden onset of intense anxiety associated with chest tightness, shortness of breath, clammy hands, trembling, and sweating, without an identifiable medical cause. After medical conditions are ruled out by obtaining a thorough history, physical examination, and laboratory testing, Ms. A's symptoms are found to be an acute panic attack triggered by anticipatory anxiety related to public speaking. She exhibits avoidance of certain social circumstances, but could not avoid this upcoming presentation. She is disturbed by the possible negative evaluation of her coworkers, as opposed to being disturbed by fear of future panic attacks. She reports having excessive and generalized worries that are difficult to control, enough to disturb her sleep and concentration. These symptoms are severe enough to have caused a significant disturbance in her functioning. Her presentation highly suggests an underlying social anxiety disorder, SAD, with a comorbid GAD. Panic attacks, a type of fear response, can mark the severity of an underlying diagnosis and can occur in conditions such as GAD or SAD, but also can be associated with non-anxiety conditions such as mood disorders and substance use disorders. Panic attacks are characterized by the sudden onset of intense and overwhelming periods of fear or discomfort. To meet the diagnostic criteria for a panic attack, according to the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, text revision, an individual must experience at least 4 of the following symptoms: a racing heart or palpitations, sweating, trembling or shaking, shortness of breath, or a feeling of choking, chest pain or discomfort, nausea or abdominal distress, feeling dizzy, lightheaded or faint, derealization or depersonalization, feeling detached from oneself or one's surroundings, fear of losing control or going crazy, and fear of dying. These symptoms typically peak within minutes and can lead to a strong urge to escape or seek help. Panic attacks can occur in various situations, often without warning, and can be a significant source of distress and impairment for those who experience them. Expected panic attacks are triggered in response to a feared stimulus, whereas unexpected panic attacks occur out of the blue. Panic attacks are quite common. According to the National Comorbidity Survey, 1/3 of the population experiences isolated panic attacks at one point during their lifetime. The 12-month prevalence of panic attacks is approximately 6.4% to 11.2%. Up to 10% of the general population experiencing panic attacks do not develop a psychiatric condition. However, some will develop psychopathologies, such as anxiety disorders, mood disorders, or substance use disorders. Persons who experience panic attacks have a higher rate of functional impairment, healthcare services utilization, inpatient and outpatient costs, and other psychiatric psychopathology, including mood, anxiety, and substance use disorders. In that light, a panic attack is considered a symptom instead of an independent mental health disorder. In panic disorder, PD, panic attacks are unexpected, leading patients to fear having future panic attacks. This paroxysmal nature may lead patients with PD to develop agoraphobia, avoiding situations where they feel escape is harrowing, such as traveling alone, shopping in crowded places, or in extreme cases, the simple act of leaving home. Individuals with SAD and GAD may have panic attacks, but they are almost always triggered. An anxiety-inducing feared social situation could lead to panic attacks with SAD. These situations may include interacting with others in a social gathering, eating in front of others, or public speaking, and may produce panic-like symptoms, which lead to fear and avoidance of these situations. Physical symptoms of blushing, gastrointestinal distress, and urinary urgency may occur with SAD. Those with SAD panic attacks may experience a more severe form of social anxiety. They are more likely to avoid social situations and work performances because they fear being scrutinized by others. They are also more likely to use substances to cope with their symptoms. Patients with SAD will attribute their panic attacks to feared social events, whereas those with PD initially report that they were unprovoked. Panic attacks in SAD can indicate more severe psychopathology, increased functional impairment, and a higher risk of psychiatric comorbidities. In GAD, panic attacks occur because of severe, uncontrollable, and escalating catastrophic worries, and can be an indication of the severity of GAD. Somatic symptoms such as fatigue and muscle tension can occur in GAD. These symptoms are not typical in panic attacks and tend to be less severe and more chronic in nature. Anxiety in GAD involves worry about multiple areas in the patient's life, such as relationships, school or job performance, finances, family, and health or well-being. Patients with GAD do not grapple as much with anticipatory anxiety about the next panic attack and are less inclined to develop behavioral avoidance. Panic attacks that occur in the context of GAD tend to have an insidious onset and can present with a longer duration, compared to patients with PD who acutely focus on the physical symptoms of panic attacks. Patients with GAD tend to focus on vague and chronic somatic symptoms. When a panic attack occurs, patients with GAD will shift their focus to their generalized worries, compared to patients with SAD, who will focus on poor social performance, scrutiny, and negative judgment. Regardless, both GAD and SAD are highly comorbid with PD and can exhibit co-occurring traits such as increased baseline level of physiological arousal with fear, greater sensitivity to somatic symptoms, and harm avoidance. Treatment. The primary goal of managing panic attacks in SAD and GAD is to reduce their frequency and intensity and to ultimately reach remission. This can be achieved by accurately diagnosing and treating the underlying condition. A combination of lifestyle changes, pharmacotherapy, and psychotherapy is most effective. It is vital to address other comorbid conditions such as co-occurring anxiety disorders, depressive disorders, substance use disorders, and medical issues. While symptom overlap can exist in comorbid psychiatric conditions, it is helpful to establish which has the most impact on the patient's functioning. Addressing panic attacks early in treatment is crucial, as frequent and severe panic attacks may interfere with functionality and treatment adherence. In the case of Ms. A, the panic attack brought her to the emergency department, but it is the underlying GAD and SAD that requires careful consideration and proper treatment. Panic attacks in GAD and SAD can be a treatment target for both pharmacological and psychotherapeutic interventions. However, lifestyle modifications can also help with symptom relief and more chronic somatic presentations. Lifestyle modifications such as smoking cessation, engagement in regular physical activity, improving sleep habits, and reducing or eliminating the use of stimulants such as caffeine, alcohol, and tobacco can help alleviate panic symptoms and other comorbid symptoms in both SAD and GAD. Various medications can be used to treat panic attacks in SAD and GAD. Serotonin reuptake inhibitors, SRIs, are first-line treatments for SAD and GAD, but treatment response is not immediate. Benzodiazepines such as lorazepam and alprazolam can be used short-term for a speedy resolution of anticipatory anxiety or panic attack symptoms in SAD. Long-term use of benzodiazepines carries risks such as tolerance and misuse or abuse. Hence, it is worth considering the risks versus benefits when prescribing them. Indeed, treating panic attacks in the context of PD differs from other conditions due to the need for bridging therapy. In contrast to patients with GAD and SAD, patients with PD are more likely to require benzodiazepine management to help manage panic attacks on an as-needed basis as SRI treatment takes effect. Beta blockers such as propranolol can alleviate panic symptoms in GAD and may be taken as needed to help patients with panic symptoms in performance-only SAD. Buspirone, a 5-HT1A agonist, has been demonstrated to improve anxiety in GAD. Limited evidence indicates hydroxyzine may offer fast-acting resolution of panic attacks in SAD and GAD. Maintaining pharmacological treatment for at least 6 months may prevent relapse of panic attack symptoms in SAD and GAD for those who respond to treatment. CBT is the most effective treatment for both SAD and GAD. CBT can focus on psychoeducation, restructuring cognitive distortions, identifying the unique triggers for each condition, and monitoring the frequency and intensity of panic attacks and exposure to triggers that can help extinguish the panic response over time. Behavioral approaches can also be used, such as teaching patients PMR, breathing exercises, systematic desensitization, and guided imagery. Exposure therapy, whether in vivo, imaginary, or via technology, may help the patient better understand the physical symptoms of anticipatory anxiety and panic symptoms related to SAD. Mindfulness-based stress reduction and acceptance and commitment therapy have also shown efficacy in reducing panic symptoms and improving quality of life. Key points to remember. Panic attacks can occur with any mental health condition. In panic disorder, panic attacks are typically sudden and unprovoked. In SAD, panic attacks are triggered by the anticipation of or exposure to a feared social situation. In GAD, panic attacks are insidious, prolonged, and triggered by severe, uncontrollable, catastrophic worries. For the proper management of panic attacks, it is essential to consider the underlying conditions and the context in which they occur. 9. Beneath the surface. Uncovering medical causes of anxiety. Maria Hajikiriakou, MD. and Maria Rueda Lara, MD. Ms. R is a 45-year-old woman who presents to an outpatient facility with an attack of rapid breathing and acute worry. She describes a 1-week history of similar attacks, occurring intermittently, and including the sensation of chest tightness, palpitations, feelings of not being able to breathe well, and an intense, overwhelming fear of dying. She explains that she is actively undergoing treatment with tamoxifen for breast cancer. She reports that her recent cancer diagnosis, its treatment, and its strain on her family and finances have been causing her increasing worry lately. However, she has never experienced such attacks in her life. She denies any recent alcohol or illicit substance use, but does report a 10-pack-year history of smoking, which she discontinued upon learning of her cancer diagnosis. Initial physical examination reveals tachycardia, 115 beats per minute, reduced oxygen saturation, 92%, and tachypnea. What do I do now? In the case of Ms. R, these episodes may appear to be isolated acute panic attacks, which typically involve the acute onset of physical symptoms such as palpitations, chest pain, shortness of breath, or hyperventilation, trembling, sweating, nausea, lightheadedness, numbness or tingling, and chills or hot flashes. Patients may interpret these overwhelming symptoms as losing control, dying, or being detached from oneself or reality. However, before anchoring to an initial and primary diagnosis of anxiety, it is important to consider the larger clinical picture and pursue any red flags in the patient's history and on examination. The history of cancer, active treatment with chemotherapy, and history of smoking need to be accounted for as these increase the risk for other medical conditions. Additionally, abnormalities on examination and vital signs, including tachycardia and the reduced oxygen saturation, should trigger further examination and testing. Ultimately, further testing in the case of Ms. R would reveal a pulmonary embolism. Ms. R had an underlying medical reason, the pulmonary embolism, triggering her somatic and anxiety-provoking symptoms, including palpitations, shortness of breath, and chest pain. Even so, this does not completely exclude her experience of anxiety and worry, even if isolated anxiety was not the true underlying cause of all her symptoms. To characterize Ms. R's experience of severe anxiety as secondary to the pulmonary embolism, one may include a diagnosis of anxiety disorder due to another medical condition as part of her differential diagnosis. For this diagnosis, treating the underlying medical cause of her symptoms should ameliorate the patient's experience of anxiety. However, for some, the lingering effects of more long-term somatic symptoms of their medical conditions may further perpetuate ongoing anxiety. Whether acute or persistent, use of pharmacotherapy and psychotherapy may be beneficial in targeting the patient's anxiety-related symptoms. To diagnose anxiety disorder due to another medical condition, the cause of the anxiety must be a direct pathophysiological consequence of a medical disorder. In medical settings, it is not uncommon for anxiety or panic attacks to be the initial presentation of the underlying medical condition. However, an individual may also develop intense fear and preoccupation related to the somatic symptoms or physical effects that they experience and are associated with the medical condition. There are a variety of medical conditions that can directly cause such anxiety and panic, some of which are listed in Table 9.1. Identifying and recognizing signs that are atypical in primary anxiety disorders can help to key in on a diagnosis of anxiety disorder due to another medical condition. These include a lack of personal or family history of psychiatric disorders, onset of anxiety later in life such as middle age, lack of recent psychosocial stressors, an active history of serious medical conditions, and active substance abuse. Other signs and symptoms on initial history and examination that may lead to diagnosis of anxiety attributable to a medical condition include acute physical symptoms such as tremor, sweating, and vomiting, atypical physical symptoms for anxiety such as dizziness, syncope, cognitive impairment, and focal neurological changes or symptoms, and persistent abnormalities in vital signs such as tachycardia, hypertension, and reduction in oxygen saturation, as clearly evidenced in Ms. R's case. Any of the above should trigger a thorough medical history and physical examination, including a neurological examination. Any need for further studies, laboratory testing, and imaging studies is determined according to findings on examination, history, and the patient's presentation. Table 9.1. Medical conditions that can cause anxiety. Common physical signs and symptoms. Endocrine disease. Hyperthyroidism. Sweating, fatigue, persistent tachycardia, heat intolerance, weight loss, and muscle weakness. Hypothyroidism. Excessive fatigue, weight gain, dry skin, brittle hair and nails, sensitivity to cold. Pheochromocytoma. Tachycardia, hypertension, palpitations, headache, sweating, pallor or flushing, abdominal pain, nausea and vomiting. Hypoglycemia. Lightheadedness, sweating, change in mental status, generalized weakness. Cushing syndrome, high levels of cortisol or glucocorticoids. Truncal obesity and striae, hypertension, hyperglycemia, muscle weakness, skin atrophy and bruising. Acromegaly, excess of growth hormone. Headache, cranial nerve palsies, acral enlargement, hypertension. Polycystic ovarian syndrome. Amenorrhea or oligomenorrhea. Truncal obesity or weight gain, alopecia. Hirsutism, hypertension. Hyperprolactinemia. Galactorrhea, menstrual irregularities, reduced libido. Carcinoid syndrome. Flushing, watery non-bloody diarrhea, wheezing and bronchospasms, purplish rash. Metabolic disturbance. Hyperparathyroidism with moderate hypercalcemia. Anorexia, thirst, frequent urination, weakness, constipation, joint pain. Hypoparathyroidism with hypoglycemia. Paresthesia, muscle cramps and spasms, facial grimacing. Hypophosphatemia. Tachypnea, change in mental status, generalized weakness. Hypomagnesemia. Tremors, muscle spasms, carpal spasms, Trousseau sign, facial twitching, Vostek sign, nausea and vomiting. Cardiovascular disease. Heart failure, palpitations, acute heart decompensation. Mitral valve prolapse. Palpitations or intermittent fluttering sensation. Automatic implantable cardioverter defibrillators associated with device discharges. Supraventricular tachycardia, palpitations. Cardiac arrhythmias, palpitations, chest pain. Coronary artery disease, relating to acute coronary event or myocardial infarction. Respiratory illness, hyperventilation or hypercapnia. Tachypnea, lightheadedness. Chronic obstructive pulmonary disease, airflow limitation, difficulty breathing. Asthma, presence of physical trigger that causes difficulty breathing, chest tightness, cough, wheezing. Pulmonary embolism. Tachycardia, palpitations, chest pain, shortness of breath, cough, low oxygen blood levels. Sarcoidosis, dry cough, shortness of breath, weight loss, other hormonal imbalances with central nervous system involvement. Hypoxia, difficulty breathing, lightheadedness, reduction in oxygen saturation on examination. COVID-19, shortness of breath, flu-like symptoms, malaise, muscle soreness, loss of taste or smell, fever. Neurological illness, Parkinson's disease. Anxiety may be associated with changes in dopaminergic density, associated with other signs of Parkinson's disease, including bradykinesia, bradiphrenia, shuffling gait. Epilepsy. Complex partial seizures may involve panic symptoms, including fear, derealization, depersonalization, dizziness, and paresthesia. Stroke. Tendency to misinterpret somatic symptoms, checking and reassurance-seeking behaviors may be associated with post-traumatic symptoms. Multiple sclerosis. Weakness and fatigue, vision changes, numbness and tingling, bowel and bladder dysfunction, neurological symptoms separated by time and space, magnetic resonance imaging brain findings, vestibular dysfunction, dizziness, history of falls, ocular findings on examination, encephalitis, change in mental status, fever, headache, neck stiffness, sensitivity to light and sound, akathisia, uncontrollable restlessness, head trauma, traumatic history, abnormal head imaging, cognitive dysfunction. Oncological. Related to physical consequences, for example, nausea, vomiting, of chemotherapy. Related to physical consequences of specific cancer type and location, for example, hypoxia related to lung cancer, effective brain lesion on particular area of the brain. Cancer-related pain. Other. Pellagra. Diarrhea, dermatitis, cognitive changes. Systemic lupus erythematosus. Fever, fatigue, joint pain, skin lesions, butterfly-shaped rash. Arthritis. Joint pain, restricted movement of joints. Anaphylaxis. Difficulty breathing, skin rash, lightheadedness, pallor. Acute porphyria. Severe abdominal pain, red or brown urine, changes in mental status. Wilson disease, copper accumulation. Involuntary movements, speech disturbance, increase in liver enzymes, Kaiser-Fleischer rings. Treatment. Treating the underlying medical condition should resolve the patient's experience of anxiety. However, for acute distressing anxiety with its associated somatic symptoms, such as nausea and vomiting and palpitations, and in an effort to alleviate patient suffering as the medical condition is being treated, short-term medications for anxiety may be used. This may include benzodiazepines, such as lorazepam, which can be helpful in cases of palpitations and can also aid with nausea in patients receiving chemotherapy. Benzodiazepine should be used with caution in patients with respiratory illness or hypoxemia. Depending on the severity of respiratory compromise, benzodiazepines can potentially contribute to respiratory depression. Other conditions in which benzodiazepines are not recommended include patients with hypotension, cognitive impairment, high risk of falls, history of substance abuse, and age above 65 years. Alternate medications for use in the short term can include hydroxyzine, low-dose second-generation antipsychotics, and buspirone, which is particularly helpful in patients with respiratory illness and when benzodiazepine use is contraindicated. Although these medications are not Food and Drug Administration approved for the treatment of acute anxiety, limited data support their tolerance and efficacy. In the case of Ms. R., an appropriate short-term medication to help with anxiety on an as-needed basis could have been hydroxyzine. In this case, it would be important to avoid a benzodiazepine to minimize any potential worsening of respiratory distress or hypoxia. Depending on the clinical picture and ongoing treatment of the underlying medical condition, there may be persistent symptoms of anxiety. In this case presentation, despite addressing the pulmonary embolism, the physical experience of this diagnosis may contribute to ongoing anxiety and worry, as exacerbated by the patient's cancer-related stressors. First-line treatment for more chronic anxiety in the case of Ms. R. would include those medications used for other primary anxiety disorders, such as serotonin reuptake inhibitors, SRIs, and/or mirtazapine. Careful consideration of cytochrome P450 effects, hepatorenal function, drug-to-drug interactions, and complications related to active medical conditions must be made when selecting an appropriate therapeutic agent. For example, in the case of Ms. R, one must be careful to avoid medications for anxiety that inhibit the cytochrome P450 2D6 enzyme, such as some of the SRIs, including paroxetine and fluoxetine, as they can decrease the efficacy of tamoxifen. Although tricyclic antidepressants and monoamine oxidase inhibitors are part of the armamentarium to treat anxiety, these medications are not usually prescribed in medically complex cases due to their side effect profile and drug-to-drug interactions. Supportive, cognitive behavioral, mindfulness-based, art, music, hypnosis, and interpersonal psychotherapies can also benefit Ms. R, either alone or with concurrent use of pharmacotherapy. Overall, the treatment of her anxiety should be tailored according to her medical conditions, psychosocial factors, and personal preference. Key points to remember. To diagnose anxiety disorder due to another medical condition, the cause of the anxiety must be a direct pathophysiological consequence of a medical disorder. Identifying and recognizing signs that are atypical in primary anxiety disorders can help to key in on a diagnosis of anxiety disorder due to another medical condition. Anxiety caused by another medical condition typically resolves with the treatment of the underlying medical condition. Pharmacotherapy and psychotherapy can alleviate acute anxiety while the patient is being medically treated, and can improve any persistent or more chronic symptoms of anxiety that are caused by the medical condition. 10. The Crossroads of Addiction and Anxiety. David M. Martinez Garza, MD, and Ihsan M. Saloom, MD, MPH, DLFAPA. Mr. Z is a 35-year-old man who presents to the outpatient clinic complaining of constant worry, irritability, and restlessness. He states he has difficulty sleeping, often feels fatigued, and cannot concentrate at work. He is fearful he will get fired. Last night, he had an episode in which he had shortness of breath and palpitations and thought he was having a heart attack. 2 months ago, he underwent medically supervised withdrawal, detox, after he overdosed with prescription opioids and alcohol. This was his first psychiatric hospitalization. He developed an addiction to opioids and alcohol following a car accident 1 year ago, in which he was severely injured. His current medications include an oral prescription of naltrexone and ibuprofen. Prior to this, he had never seen a psychiatrist. He reports significant cravings, and he is very worried he will relapse. He asks if there is something he can take for anxiety. What do I do now? The psychotropic effects of many substances can cause anxiety symptoms. The Diagnostic and Statistical Manual of Mental Disorders, 5th edition, text revision, defines substance-induced anxiety disorder as panic attacks or anxiety that develops during or proximal to substance intoxication or withdrawal, or following exposure to a medication. Most drugs that stimulate the noradrenergic or dopaminergic circuits, such as cocaine, amphetamines, and cannabis, are most likely to cause anxiety during the acute phases of intoxication. Withdrawal from drugs that are depressants of the central nervous system, such as alcohol, benzodiazepines, and opioids, will cause a hyperadrenergic state, which can lead to anxiety symptoms as well. Depending on the drug's half-life, the majority of these symptoms should resolve within days or weeks after removing the causal agent. However, in clinical practice, this is hardly the case, and it is often challenging to tease out if symptoms of anxiety are directly caused by a substance or are an independent anxiety disorder in addition to the co-occurring substance use disorder, SUD. For example, Mr. Z's alcohol withdrawal symptoms include debilitating anxiety and panic. Alcohol and opioid withdrawal symptoms typically last for 7 to 10 days. Many patients like Mr. Z will experience longer-lasting symptoms of dysphoria, restlessness, anxiety, insomnia, and fatigue, which can last for months. This is referred to as protracted withdrawal syndrome. This syndrome is believed to be secondary to neuroplastic changes due to chronic substance abuse. Prolonged exposure to other substances such as stimulants, cannabis, and hallucinogens may also promote aberrant changes in the brain that can directly cause or predispose patients to developing a chronic anxiety disorder. When faced with this predicament, the key diagnostic pearl to differentiate between anxiety due to a substance and an independent anxiety disorder is the persistence of anxiety beyond a reasonable period of sobriety. Clinical wisdom would dictate waiting a month before making such a distinction, although some diagnostic criteria recommend waiting for at least 6 months, such as with heavy cannabis use. Each case must be assessed individually, taking into consideration the nature of the substance in place and the history of abuse or misuse. This could mean 1 week for an episode of cocaine binging, or up to many months in the case of long-term daily use of benzodiazepines or alcohol. Of note, substances with very short half-lives, such as nicotine and caffeine, may produce withdrawal symptoms, including anxiety, within hours. Another approach used to differentiate between these two conditions is to ascertain if the symptoms of anxiety preceded the SUD, or if symptoms were present in the absence of active substance use. This can be challenging, as it will depend on the patient's ability to objectively recall periods of sobriety. Given the nature of substance use, the vast majority of patients may be unable to recall a reliable period of sustained sobriety to reach a conclusion. Therefore, prospective longitudinal follow-up is preferred. The prevalence of comorbid anxiety in SUDs is particularly high with a complex, multi-layered, and bidirectional relationship. The unicausal model, where one disorder causes the other, has many limitations. Recent evidence suggests that regardless of what came first, the presence of an SUD is a high-risk factor for the co-occurrence of an anxiety disorder. Patients with SUD have higher levels of symptom severity and treatment resistance, meaning that early diagnosis and treatment is key for better outcomes. By the same token, the presence of anxiety symptoms is another high-risk factor for SUD and relapse. Research suggests that patients with an anxiety disorder progress faster from recreational substance use to dependence versus those without an anxiety disorder. Current neuroscientific theories propose a model in which both disorders stem from shared neurobiological vulnerabilities. Treatment. Ultimately, whether anxiety symptoms are the product of an independent anxiety disorder or induced by a substance, the anxiety must be treated. In most cases, deferring treatment while the causality is clarified is not recommended. Treatment should never be delayed solely based on diagnostic motives. When both conditions are co-occurring, it is imperative to treat them early and in an integrated fashion. To not do so may result in higher rates of relapse and cause potential harm to the patient. When both conditions co-occur, the first step in treatment requires withdrawal from the substance. The concomitant use of substances makes it extremely difficult for patients to learn how to manage and sometimes tolerate their anxiety symptoms without self-medicating. Depending on the severity of the addiction and the type of substance involved, a medically supervised withdrawal may be required. This includes proper medical management of withdrawal symptoms, including anxiety. In acute presentations such as cocaine intoxication or alcohol withdrawal, short-term benzodiazepine use should suffice for anxiety symptom management in a medically supervised setting. In more chronic presentations, such as protracted withdrawal, like in the case of Mr. Z, or long-standing anxiety with multiple relapses, attention should be given to the long-term management of anxiety symptoms, as well as relapse prevention. Benzodiazepines and sedative hypnotics should not be used for the long-term management of patients with co-occurring anxiety and SUD. Other psychiatric conditions need to be recognized and treated. These may include depression, bipolar disorder, or trauma-related disorders. Medical comorbidities such as chronic pain cannot be ignored to have a successful outcome. If a decision is made to start a patient on a long-term psychopharmacologic agent for anxiety, a serotonin reuptake inhibitor is generally indicated as first line. The decision of which medication to start should be guided by an individual assessment of every patient. Other agents, especially those targeting multiple pathways that address anxiety, insomnia, pain, and cravings, could be considered. Examples include gabapentin, mirtazapine, and topiramate. Additionally, one of the hallmark features of treating comorbid SUD and anxiety disorders is to acquire a repertoire of skills to manage ongoing and reoccurring anxiety symptoms without the aid of substances. Anxiety triggers such as psychosocial stressors and re-experienced trauma from the past need to be addressed. Psychotherapy, in particular cognitive behavioral therapy, can be beneficial to alleviate symptoms, acquire healthy coping strategies, and prevent relapse. There is a wealth of evidence-based psychotherapeutic options for all SUDs. Interventions based on motivational enhancement, integrated therapy, contingency management, and relapse prevention skills have proven effective. Depending on patients' needs, this can be offered at different levels of care, ranging from outpatient to partial hospitalization programs and residential facilities. Beyond the biological effects of alcohol and drugs, there are other social and psychological processes that are key components of SUD. For example, patients may have negative cognitions associated with sobriety that perpetuate the anxiety symptoms and their ability to overcome them. Furthermore, the social readjustment required in the long term can lead to psychological cravings and a higher rate of relapse. Therefore, all patients with anxiety symptoms in the context of SUD require not only possible first-line pharmacological treatment for anxiety disorders, but also management of the anxiety from multiple perspectives. At the community level, interventions can be delivered at the individual or group level. Examples of these interventions include recovery coach support, a community reinforcement approach, and family and couples therapy. Self-help groups such as self-management and recovery training, and 12-step groups such as Alcoholics and Narcotics Anonymous are easily accessible in most communities. Finally, it is imperative to offer maintenance treatment for the co-occurring SUD following the acute treatment of withdrawal. This generally involves a combination of medication management, along with the non-pharmacological interventions mentioned previously. The goal of medication management is to prevent relapse, particularly in patients who have not responded to psychotherapeutic interventions alone. Food and Drug Administration, FDA-approved medications for the treatment of alcohol use disorder include naltrexone and acamprosate, which help to decrease cravings, and disulfiram, which is indicated for those patients who are motivated to maintain sobriety. Medications used for opioid use disorder include methadone, buprenorphine, naltrexone, and naloxone. Medications for tobacco use disorder include nicotine replacement therapy, bupropion, and varenicline. There are no FDA-approved medications for the treatment of cannabis, stimulant, or hallucinogen use disorders. Off-label use of medications such as gabapentin, topiramate, and baclofen can be helpful, in part because they may target anxiety symptoms. Mr. Z was referred to an outpatient SUD clinic where he is started on buprenorphine/naloxone for opioid use disorder and pain, as well as gabapentin for alcohol cravings and anxiety. Mr. Z is also sent to individual psychotherapy, where he has been working on processing the trauma of sexual abuse as a child. He now attends a relapse prevention outpatient group, where he has been learning coping skills to deal with cravings and the urge to use drugs and alcohol during periods of stress and anxiety. At a 1-year follow-up, Mr. Z continues to be abstinent, no longer endorses cravings, and is back to baseline functioning at work. His pain is well managed, and he no longer endorses anxiety symptoms. Key points to remember: alcohol and substances of abuse, can cause anxiety symptoms during intoxication or withdrawal. Anxiety and withdrawal symptoms may be present for weeks to months after cessation. It may be challenging to tease out substance-induced anxiety from an independent anxiety with comorbid SUD. While a substance can induce anxiety, anxiety can also lead to an SUD, and both are risk factors for developing each other. Regardless of etiology, treatment should be offered in an integrated fashion, simultaneously addressing both anxiety symptoms and SUD. 11. Washing away worries. Understanding the complexities of OCD. Elizabeth Deckler, MD, and Barbara Coffey, MD, MS. Mr. V is a 19-year-old man with a tic disorder as a child. He recently failed his physics final. He was referred for attention deficit hyperactivity disorder, ADHD. His mother believes that his poor grades may be due to undiagnosed ADHD. He reports some issues with attention, but they are always in the context of frequent ruminations. When Mr. V was asked why he failed his exam, he tells you that he did not have time to study. He spends several hours a day washing his hands and cleaning the surfaces of his room to protect himself from bacterial meningitis, a disease he heard could be spread in college dormitories. Despite being vaccinated against the condition, he still believes he could contract the disease. When he thinks about bacterial meningitis, he is overcome with anxiety. He has found that the only way to relieve his anxiety in the short term is to research it extensively online. He has never been so incapacitated by an obsession before this one. What do I do now? Obsessive-compulsive disorder, OCD, is a disorder involving distressing obsessions and resulting compulsions aimed at relieving the anxiety caused by the obsession. Traditionally, OCD was classified within the anxiety disorders due to the distress and anxiety the obsessions produced. OCD is now regarded as its own separate category, given its unique symptom profile and biological underpinnings. Patients with OCD can have obsessional thoughts, images, urges, or impulses that are intrusive and distressing. Additionally, they may engage in compulsive acts that are repetitive and excessive. The compulsive behaviors are often performed as a way to alleviate the distress generated by obsessions. Both symptoms are present in most patients with OCD. However, only one symptom is necessary for the diagnosis. Due to the distressing and irrational nature of the obsessions, patients with OCD may not readily disclose them to others due to the shame associated with these thoughts. Similar to the anxiety disorders, patients with OCD over time may not only begin to exhibit compulsive acts to neutralize the obsessional thinking, but also develop avoidance behaviors that may affect their ability to function. For example, a patient who experiences obsessional thoughts and images of harming others may avoid social situations. In addition, compulsive behaviors can be so time-consuming that they interfere with the patient's daily functioning. In the case of Mr. V, his compulsive hand-washing and cleaning became so severe and frequent that he was unable to complete his day-to-day tasks. It is important to note that many individuals experience occasional intrusive thoughts and repetitive behaviors, but it is the severity and duration that helps differentiate these from the disorder. It is not uncommon for certain symptom themes to occur within the context of OCD: fear of contamination, fear of harm to self or others, and other culturally unacceptable thoughts such as religious obsessions may be present. Compulsive behaviors can be ritualistic, including frequent checking, counting, or need for symmetry. These patterns of thoughts and behaviors are important to identify, as they may be targets of treatment. OCD is a relatively common psychiatric condition. An estimated 1.5% of women and 1% of men suffer from OCD worldwide. And in the United States, about 2.3% of the population meets Diagnostic and Statistical Manual of Mental Disorders criteria for diagnosable OCD during their lifetime. OCD typically begins in adolescence, as in the case of Mr. V, and onset after the age of 30 is considered late-onset OCD. The earlier a patient experiences the onset of OCD, the the more severe the condition is expected to be. Patients who experience their first symptoms of OCD after the age of 30 usually display a milder disease course compared to younger onset patients. The disorder is more pervasive in younger adults and older adults. The reason for this difference has not been formally established, but some theories include increased overall survival of people who do not suffer from a mental disorder and the improved psychiatric resiliency of older patients. Women suffer from OCD at 1.6 times the rate of men. The reason for this difference is largely unknown. However, some researchers believe there may be a link between OCD and hormonal changes. This theory is substantiated by research showing that pregnancy and the postpartum period are uniquely vulnerable times for women to develop OCD. Interestingly, studies have demonstrated that 25% of women suffering from OCD can attribute its onset to a recent major reproductive change, such as menarche. Women with diagnosed OCD have also described worsening of their OCD symptoms surrounding reproductive events such as pregnancy, the perinatal period, and menopause. OCD is often comorbid with other psychiatric conditions. Research has shown that OCD frequently co-occurs with mood disorders, impulse control disorders, anxiety disorders, and substance use disorders. Comorbid symptoms such as panic attacks, excessive worry, or difficulty discarding objects can be present, and other anxiety disorders may co-occur. Providers should be cognizant of likely comorbidity in their patients with OCD and treat them accordingly. In the case of Mr. V, his use of alcohol and marijuana to self-medicate may also require treatment. Patients with OCD frequently report a history of a tic disorder at some point in their lifetime. They also found that patients who reported a lifetime history of a tic disorder were more likely to be male and suffer from comorbid anxiety disorders, skin picking, and impulse control disorders. They were also more likely to display more severe hoarding and sexual, religious, and aggressive OCD-related behaviors or obsessions. Treatment. Prescribers are encouraged to treat their patients for OCD, as well as any comorbid disorders, with as few medications as possible to limit detrimental polypharmacy. The first-line psychopharmacologic treatment of OCD includes utilizing one of the 4 Food and Drug Administration, FDA-approved selective serotonin reuptake inhibitors, SSRIs. SSRIs are first-line due to their relatively tolerable side effect profile and demonstrated efficacy. They are also helpful in patients with comorbid psychiatric conditions. They include fluvoxamine, paroxetine, sertraline, and fluoxetine. Like all SSRIs, the 4 medications approved for OCD contain black box warnings for increased suicidality among younger patients. This class of medications most commonly can cause gastrointestinal side effects, such as nausea, and gastrointestinal upset, neurological side effects such as headache and dizziness, and sexual dysfunction in both men and women. Despite their widespread use, citalopram and escitalopram are not FDA approved for the treatment of OCD. Both SSRIs and selective serotonin norepinephrine reuptake inhibitors are believed to be efficacious in general, given their similar mechanism of action. Similar to the treatment of other anxiety disorders, SSRIs should be started at a low dose to minimize the potential for side effects. In clinical practice, higher doses of medications need to be used to achieve symptom reduction. It is recommended that an appropriate trial of medication is significantly longer than a trial for clinical depression and can be up to 12 weeks. Fluvoxamine is commonly known as the SSRI specifically indicated for OCD, particularly due to its unique agonist action at the sigma-1 receptor. Unlike other SSRIs, fluvoxamine is only approved by the FDA for the treatment of OCD, and therefore may have limitations when treating other psychiatric comorbidities. Doses above 100 milligrams per day should be given in 2 divided doses. If twice-daily dosing is difficult for some patients, an extended-release formulation is available. Studies have established 150 milligrams per day as the minimum dose necessary for the effective treatment of OCD. but if patients demonstrate improvement with lower doses, the lowest efficacious dose should be used. An important note about fluvoxamine is its interaction with other medications, resulting from its numerous hepatic enzyme inhibitions. Caution should be taken when prescribing fluvoxamine to patients taking other medications, and the potential interaction should always be assessed. Due to its inhibition of cytochrome P450, CYP, 1A2, fluvoxamine blocks the clearance of caffeine and may increase its effect. Paroxetine is an SSRI approved by the FDA for the treatment of OCD and other psychiatric conditions. The half-life of paroxetine is 21 hours, so it can be taken once daily. Unfortunately, weight gain and discontinuation syndrome were frequently found among patients taking paroxetine, and it has therefore become a less commonly prescribed medication. Paroxetine is a strong inhibitor of CYP 2D6 and 3A4, and attention should be given to potential drug-to-drug interactions. Sertraline, an additional FDA-approved treatment for OCD, weakly blocks the reuptake of dopamine and norepinephrine at the neuronal synapse. Due to its 26-hour half-life, sertraline can be given once daily. Sertraline has significantly less potential for drug-to-drug interactions. Fluoxetine should be given once daily in the morning due to its potential for causing activation. In patients who suffer from obsessions related to taking medications, fluoxetine can be given in a once-weekly dose. Providers should be aware of fluoxetine's potential for increasing anxiety during the initial dosing of the medication, as well as its potent inhibition of CYP 2D6 and 3A4. Clomipramine is a tricyclic antidepressant approved by the FDA for the treatment of OCD. Similar to fluvoxamine, this is the only FDA indication that it carries. Despite clomipramine's efficacy, it is considered a second-line agent due to its unfavorable side effect profile. In studies submitted to the FDA, approximately 20% of patients taking clomipramine suffered from tachycardia or orthostatic hypotension. A small but significant percentage of patients developed electrocardiogram changes, prompting the FDA to caution the medication's use in patients with pre-existing cardiovascular disorders. Additionally, the medication can be lethal in overdose, necessitating further caution in a patient population frequently suffering from comorbid mood disorders. With caution, however, clomipramine can be a powerful tool in the treatment of OCD. Non-pharmacological treatment options for OCD include exposure and response prevention therapy, ERP, and cognitive behavioral therapy, CBT. It is recommended that prior to starting these treatment modalities, the patient should be educated about this condition, its course, and how treatment can decrease distress and functional impairment. ERP involves a therapist invoking the stimulus that would typically lead to obsessions and compulsions in the patient, and developing alternative coping mechanisms. To perform this type of therapy, it is essential to identify the common themes and triggers in each individual patient. The coping mechanisms designed to stop compulsive behaviors include aversion and thought stopping. ERP has shown improved efficacy over CBT and is the psychotherapeutic treatment of choice in OCD. OCD that is refractory to medication and psychotherapy can be a debilitating chronic condition for patients. Fortunately, there is hope with regard to future directions in OCD treatments. In 2009, the FDA granted a humanitarian device exemption to deep brain stimulation for the treatment of refractory OCD. Since then, other interventional treatments such as laser ablation and bilateral cingulotomy have been trialed in select patients and found to be effective. To this date, however, no surgical interventions for OCD have obtained full FDA approval. In addition to surgical interventions, novel pharmacological treatments are being investigated. Preliminary studies on glutamatergic agents have shown promise in the treatment of OCD. After a thorough medical and psychiatric evaluation, Mr. V is diagnosed with OCD. You start him on 50 milligrams of fluvoxamine at bedtime and titrate up to 100 milligrams twice a day. After 8 weeks of treatment, which include ERP and addiction counseling, he experiences tremendous relief in his symptoms and stops alcohol and marijuana consumption. Key points to remember. OCD is characterized by obsessions and compulsions. Obsessions are recurrent images, thoughts, or urges that are difficult to control and cause distress and anxiety. Compulsions are physical or mental acts that the patient feels compelled to perform to relieve anxiety or distress. First-line treatments include SSRIs and ERP. 12. Worry or obsession. Distinguishing obsessions from everyday worries. Moyad R. Copley, MD, Reem Ezzedine, MD, and Musa Botros, MD. Ms. S. is a 34-year-old female who presents to the obstetrics clinic for a postpartum checkup 6 weeks after an uncomplicated vaginal delivery. The patient states that she and her newborn daughter have both been doing well and are in good physical condition. She complains, however, of increasing distress brought on by spending a considerable amount of time worrying about her baby's health. A few days after delivery, she started experiencing persistent and distressing thoughts that something terrible would happen to her baby. As a result, she feels compelled to check on her baby multiple times throughout the day and closely monitor her while she is asleep to ensure that she is still breathing. She also calls her husband every few minutes to make sure that the baby is fine. Her repetitive, intrusive thoughts and frequent checking behaviors have been so time-consuming that they have interfered with her sleep and her ability to focus on other daily activities. In addition, the patient reports feeling easily irritable and more fatigued than usual, but she denies any signs or symptoms of depression. What do I do now? It is not uncommon for clinicians facing a similar case to Ms. S. to find themselves questioning, is the patient experiencing normal worry, or is it something else? Select perinatal patients may be at risk for several psychiatric conditions, including clinical depression and perinatal psychosis. However, in this case, Ms. S. is not exhibiting significant depressive symptoms, hallucinations, or delusions. Ms. S.'s symptoms are highly suggestive of an anxiety disorder. Generalized anxiety disorder, GAD, and obsessive-compulsive disorder, OCD, can manifest with similar symptoms, posing a challenge in achieving an accurate diagnosis. It is necessary to parse out the nuances that differentiate the two conditions, as the treatment approach for each condition is unique. At the root of both conditions are distressing thoughts that are repetitive, unwelcome, and time-consuming. More importantly, these thoughts cause distress to patients and impair their functioning and impede their participation in social, occupational, and other day-to-day activities. It is also important to acknowledge the fact that it is possible to have a dual diagnosis of GAD and OCD. In some studies, GAD was comorbid with OCD in over 33% of the patients under study. When compared to patients diagnosed with OCD alone, those with both disorders exhibited greater clinical severity. In GAD, distressing thoughts are often described as worry and are commonly centered around daily life problems such as job responsibilities, academic performance, finances, relationships, and the health of oneself or others. While it may be reasonable and appropriate to think about such real-life matters, the worry in GAD is excessive and disproportionate to the actual risk associated with these concerns. On the other hand, in OCD, the distressing thoughts are intrusive and persistent and characterized as obsessions. In addition, obsessions may present as distressing urges or images. Common obsessions include fears of contamination, aggressive obsessions of deliberately or accidentally harming oneself or others, doubt obsessions, an overwhelming fixation on symmetry, somatic obsessions, or intrusive thoughts about topics regarded as untouchable or taboo by some communities and cultures, such as sex or religion. Patients often present with mixed obsessions that include several of these themes. These obsessions are often accompanied by a profound sense of dread and the urge to perform specific compulsions. Individuals try to suppress their obsessions by engaging in compulsive behaviors or mental acts, which reinforces the cycle of obsessions and compulsions. Compulsions are either repetitive behaviors, such as repeated checking, washing and cleaning, ordering, and arranging things in a particular or symmetrical way, or mental acts, such as praying, counting, or silently repeating particular words, images, or numbers. The presence of compulsions is the primary distinctive feature of OCD that sets it apart from GAD. Unlike in OCD, worry in GAD is not typically followed by repetitive behavior or mental acts, but is associated with excessive rumination about one's own worries and concerns. On the contrary, patients with OCD experience a strong impulse to perform such rituals to suppress or relieve the distress that accompanies their obsessions. Sometimes, these repetitive behaviors and mental acts are performed in an attempt to prevent some fearful situations, such as a driver repetitively reciting a phrase while driving to prevent an accident. Nevertheless, these compulsions provide only temporary relief, if any at all. Another key difference between GAD and OCD is the presence of physical symptoms. These can include restlessness, irritability, fatigue, and muscle tension. While these symptoms feature prominently in GAD and constitute one of its diagnostic criteria, their presence is not required to diagnose OCD. One anecdotal point of distinction between the two is the tenacity or stickiness of the obsession. Obsessional thoughts tend to be constant and severe and often preoccupy an individual's every thought, feeling, and action. A person with GAD tends to jump from one worrisome thought to the next, culminating in a general feeling of being overwhelmed. A person with OCD, however, is more likely to fixate and obsess on a particular idea, thought, or theme, or a select few, and devote excessive attention to it. Finally, a major difference between GAD and OCD is whether the content of the worrying thoughts and the actual beliefs of the afflicted are congruent or dissonant. While in OCD, the worrying thoughts are often dissonant with what the person truly regards as rational and true, the thoughts that characterize GAD come from the pathological fixation on the worst possible scenario in a set of realizable and viable scenarios. When assessing for the presence of obsessions, compulsions, or excessive worry, specific questions may be asked that can help identify these symptoms. Table 12.1. These questions can aid in achieving a more accurate diagnosis of OCD and GAD. Table 12.2 presents additional distinctions that aid in differentiating between OCD and GAD. OCD symptoms typically begin to emerge during childhood, adolescence, or early adulthood, with varying ages of onset. The median age of onset is 19 years, more often observed at a later age in females. On the other hand, GAD tends to initiate during late adolescence or early adulthood, with a median age of onset at 30 years. In females, the onset is earlier. Notably, OCD is 1.6 times more prevalent in females, while GAD is nearly twice as common among females. A significant number of individuals dealing with OCD also grapple with depression. Comorbidities extend to include other anxiety disorders such as social anxiety and specific phobias, along with tic disorders like Tourette's syndrome. Common additional conditions accompanying GAD include depression, other anxiety disorders, and substance use disorders. Additionally, GAD is frequently found among patients dealing with chronic physical illnesses. Table 12.1. Differentiating between obsessions, compulsions, and excessive worry. Obsessions. Have you ever been bothered by recurrent intrusive thoughts that seem to be inappropriate or irrational but difficult to contain? For instance, a constant irrational fear of harming yourself or others, or an unshakable preoccupation with dirt, germs, or getting contaminated? Compulsions. Have you ever been overrun by a strong urge to perform certain rituals or behaviors repetitively to the extent that you cannot resist performing them? Some of these rituals include excessive hand washing, counting, checking locks or the stove, or doing things in certain numbers or order. Excessive worry. Do you consider yourself a worrier, or have other people told you that you are? Do you excessively and repeatedly worry about different matters and aspects in your life? Table 12.2. Distinguishing characteristics of obsessive-compulsive disorder, OCD, versus generalized anxiety disorder, GAD. Age of onset. OCD. Childhood and early adolescence, median age of 19, older age of onset in females. GAD. Late adolescence and adulthood, median age of 30, earlier age of onset in females. Gender differences. OCD. 1.6 times more common in females. GAD. Almost twice as common in females. Prevalence in the U.S. OCD. About 2%. GAD. About 7%. Comorbidities. OCD. Depressive disorders, personality disorders, anxiety disorders, tic disorders. GAD. Anxiety disorders, depressive disorders, post-traumatic stress disorder, substance use disorders, chronic physical illness. Heritability. OCD. 40 to 50%. GAD. 30 to 40%. Characteristics. OCD. Obsessions and/or compulsions. GAD. Excessive worry. Content. OCD. Irrational themes, images, or urges. GAD. Exaggerated worries about a variety of daily activities or problems. Response. OCD. Compulsive and ritualistic behavior. GAD. Excessive ruminations about their worry. Presence of physical symptoms. OCD. Not required. GAD. Required. Cognitive behavioral therapy, CBT approach. OCD. Exposure and response prevention. GAD. Standard CBT. Selective serotonin reuptake inhibitor medications. OCD. Higher target doses with quicker titration. GAD. Slower titration. Treatment. Treatment approaches for both conditions may include psychotherapy, pharmacological intervention, or both. The psychotherapy approach best suited for the treatment of OCD is exposure and response prevention, ERP, a form of cognitive behavioral therapy, CBT. During ERP, patients with OCD are repeatedly exposed to thoughts and situations that usually provoke their fear and anxiety in an effort to eventually desensitize them. The aim of ERP is to ultimately reduce the anxiety that accompanies their obsessions and reduce the frequency of both the obsessions and compulsions. On the other hand, standard CBT with cognitive restructuring is recommended for patients with GAD. In cognitive restructuring, the focus is on challenging the basis of the anxiety-invoking thoughts. From a pharmacologic standpoint, the first-line treatment for both conditions consists of serotonergic medications, namely selective serotonin reuptake inhibitors, SSRIs. In the treatment of OCD, experts recommend treating with higher doses and up-titrating more rapidly. Ms. S. described her thoughts as intrusive, irrational, excessive, and distressing. She recognized that they were followed by certain acts and behaviors to neutralize the associated anxiety. She was not preoccupied by other worrying thoughts that would otherwise hint at the generalized patterns seen in GAD. She was diagnosed with OCD and started on sertraline, an SSRI safe for breastfeeding. The dose of sertraline was rapidly titrated to 200 milligrams by mouth daily. Additionally, she started ERP. She noticed gradual and significant improvement over the course of treatment, with a decrease in the frequency of her obsessions and an enhanced ability to control her compulsions. She was able to function in her day-to-day life. Key points to remember. GAD and OCD tend to be chronic conditions, with symptoms persisting over time if left untreated. OCD can be distinguished from GAD by the presence of compulsions and by the irrational nature of their thoughts. In GAD, The anxiety is more generalized and pervasive. Individuals with GAD experience excessive worry about a variety of life circumstances. The psychotherapy approach best suited for the treatment of OCD is ERP, a form of CBT. Even though SSRIs are the first-line pharmacologic treatment for both conditions, OCD treatment requires a higher target dose and a more rapid up-titration. 13. Every mirror reflects a different flaw. Kendall Stewart, MD, Reem Ezzedine, MD, and Elizabeth Crocco, MD. Ms. G is a 24-year-old female who presents to a dermatology clinic for the 8th time in 6 months. She initially presented for a third opinion regarding her horrible facial scarring. Ms. G suffered from acne in her teens, for which she was bullied at school. With appropriate treatment, however, her skin cleared of any significant marks on her face. Despite this, she continued to pursue various dermatologic treatments, including chemical peels and laser skin resurfacing, whenever she observed a major breakout. She did not walk at her college graduation because everyone would notice and mock her skin, and she now often misses her graduate-level classes because she cannot bring herself to leave her home, looking so hideous. Ms. G is noted to be wearing a thick layer of foundation and frequently checks her appearance in the mirror. Despite being repeatedly reassured that her skin looks normal, she resists and pleads with a dermatologist to consider a skin graft, as she believes this will be the only solution. What do I do now? Body dysmorphic disorder, BDD, is characterized by a patient's excessive preoccupation with one or more perceived physical defects that are not apparent or are only minimally noticeable to others. Some common areas of concern are listed in Table 13.1. Ms. G's concern about the blemishes on her skin represents one of the most common perceived physical defects among patients with BDD. But patients may perceive severe imperfections in any area of the body, and often have more than one area of concern. Patients with BDD experience a high level of anxiety because of their perceived defects and engage in compulsive compensatory behaviors in an attempt to relieve this distress, as detailed in Table 13.2. In the case of Ms. G, the application of makeup and the repetitive mirror checking are examples of compensatory behaviors that further hint at a possible underlying diagnosis of BDD. The symptoms of BDD cause patients significant distress and impairment in many areas of functioning, including academic, social, professional, and financial domains. Patients with BDD frequently lack insight into the nature of their symptoms and may also hold delusional beliefs, including ideas of reference. For example, patients with BDD may believe that others find their defects equally noticeable or are commenting on or ridiculing these defects. Ms. G's belief that others are scrutinizing her skin prevented her from attending her graduation and may now hinder her academic and career pursuits if not appropriately addressed. The etiology of BDD is not completely understood, but may involve genetics, differences in visual and emotional processing, neurocognitive dysfunction, or a history of traumatic childhood events including teasing, neglect, or abuse. BDD is a relatively common condition, affecting approximately 2% to 3% of the general population, with a higher prevalence among adolescents and college/university students. Its prevalence is comparable in females and males, or may be slightly higher in females. Like Ms. G, many patients with BDD seek medical treatment for their perceived defects, and therefore, BDD is highly prevalent among patients seeking cosmetic procedures. It is seen in roughly 1 in 10 dermatology outpatients, 1 in 8 patients seeking general cosmetic surgery, and 1 in 5 patients seeking rhinoplasty. It is frequently comorbid with other psychiatric disorders, including major depression, anxiety disorders, and substance use disorders. Despite that, BDD often goes undiagnosed, even in the setting where a patient is receiving treatment for a comorbid psychiatric condition. Because BDD is highly prevalent, particularly among patients seeking cosmetic treatment, clinicians should be alert for signs of dysmorphia during clinical evaluation. Several standardized and validated tools exist to screen for BDD and can be integrated into clinical encounters. One such screening tool is the Self-Report Body Dysmorphic Questionnaire. When assessing a patient who screens positive for or is suspected of having BDD, it is important for clinicians to be sensitive to the distress that these symptoms produce and understand the lack of insight that might accompany them. Direct confrontation of the patient's belief may result in damage to the therapeutic alliance, but confirming the patient's clearly false beliefs about their appearance could be just as damaging. It can be helpful to focus on expressing empathy toward the patient's experience. "I can see that these concerns cause you a lot of anxiety," rather than on indulging or refuting the patient's delusional thoughts or trying to minimize the patient's concerns. It should be noted that BDD is not diagnosed in patients who experience concern about their appearance in a manner that is culturally normative or that is consistent with actual and obvious differences in appearance that could be realistically perceived as disfiguring. If Ms. G had highly noticeable scars on her face that a reasonable person could perceive as disfiguring, BDD would not be an appropriate diagnosis. The diagnosis of BDD is reserved for patients whose concern is based on absent or minor perceived defects in appearance that cause clinically significant distress or functional impairment. It is also important to understand the nuances that distinguish BDD from other clinical entities that involve anxieties about appearance and/or repetitive behaviors, such as eating disorders or gender dysphoria. Patients who present with an eating disorder such as anorexia nervosa or bulimia nervosa experience excessive distress and preoccupation with their appearance and adopt compensatory behaviors aimed at mitigating the distress. However, if a patient's distress stems from a concern about body weight and/or shape only and is accompanied by compensatory behaviors, such as food restriction, purging, or other such behaviors, then a diagnosis of an eating disorder should be made instead. By the same token, patients who experience gender dysphoria and have anxiety regarding their physical appearance may experience significant distress. However, if the primary subject of concern is the discordance between the patient's sexual characteristics and their gender identity, then a diagnosis of gender dysphoria is made. Additionally, modification of secondary sexual characteristics to align with a patient's gender identity has been found to alleviate symptoms of distress in patients with gender dysphoria, unlike in patients with BDD, where symptom improvement following medical intervention is rare. Patients with BDD often experience symptoms consistent with major depression, with the concern about their appearance culminating in sleep disturbance, withdrawal from formerly enjoyable activities, a sense of hopelessness or helplessness, low motivation, impaired concentration, restlessness, and even suicidal thoughts. Patients who meet the criteria for both BDD and major depressive disorder should be diagnosed with both. It is critical to assess patients with signs of BDD for co-occurring mood symptoms, especially suicidality, as suicidal ideation and suicide attempts are very common in patients with BDD. Because BDD involves a fixed false belief, it can be conflated with other psychotic disorders such as schizophrenia, schizoaffective disorder, or delusional disorder. While the perceived defects that preoccupy patients with BDD are highly overvalued and at times delusional, the absence of co-occurring hallucinations or thought disorganization rules out schizophrenia and schizoaffective disorder in patients like Ms. G. Patients with BDD may also meet the criteria for delusional disorder, including the presence of a fixed false belief for 1 month or longer, without accompanying psychotic symptoms. When a patient's delusional belief is focused on a perceived physical defect alone, BDD is the more appropriate diagnosis. As Ms. G's symptoms have worsened over time, she has begun to withdraw significantly from social situations due to her anxiety about her appearance. Avoidance of social situation is commonly seen in BDD, with a small proportion of patients becoming housebound. However, this feature can also be seen in social anxiety disorder, agoraphobia, and avoidant personality disorder. Patients with social anxiety will avoid social situations because they fear that they will be judged by others, but they tend to be more concerned about their actions and behaviors being judged rather than their appearance. Likewise, patients with agoraphobia avoid crowded, enclosed, or wide-open spaces because of the anxiety that those environments produce. But their anxiety does not stem from a concern about the way that they look. Patients suffering from avoidant personality disorder experience inhibition in many areas of their life due to fear of being rejected and view themselves as socially inept or inferior rather than physically disfigured. Careful exploration of a patient's avoidance symptoms and underlying motivations can distinguish among these different disorders. BDD shares many features with obsessive-compulsive disorder, OCD, including recurrent obsessional thoughts and repetitive behaviors to reduce the anxiety that those thoughts produce. In OCD, however, obsessional intrusive thoughts are not confined to the patient's physical appearance, and compulsive behaviors may or not be related to the obsessional thoughts. Patients with OCD are also more likely to have insight into the fact that their concerns are inconsistent with reality, whereas BDD is often characterized by poor to no insight into the illness. Patients with BDD whose concerns involve hair or skin can sometimes develop hair pulling or skin picking as one of their repetitive compensatory behaviors. This should be distinguished from trichotillomania, hair pulling disorder, or excoriation, skin picking disorder, whereby compulsions occur in isolation from perceived defects and are not intended to correct any imagined imperfections in appearance. Some patients will repetitively seek medical care due to unfounded concerns about their bodily function rather than their bodily appearance. Patients who have excessive anxiety that they have a serious physical illness, despite clinical evidence to the contrary, may be suffering from illness-anxiety disorder. Patients who deliberately induce physical illness in themselves without any secondary gain are diagnosed with factitious disorder. While Ms. G has sought out excessive medical services due to her distress about her skin, her concerns are regarding her appearance rather than the worry that her scars indicate a severe underlying condition, and it does not appear that she has taken any steps to deliberately injure her skin for the purposes of receiving medical attention. Table 13.1. Common perceived defects in body dysmorphic disorder. Skin: blemishes, scars, wrinkles. Nose: size, shape. Hair: too much or too little. Chest or breasts: size, symmetry. Muscles: size, tone, definition. Table 13.2. Common compensatory behaviors in body dysmorphic disorder. Comparing physical appearance to others. Camouflaging perceived defect with makeup or clothing. Checking physical appearance frequently in mirror. Picking at skin or plucking hair. Seeking reassurance about appearance from others. Treatment. Treatment for BDD is often intensive and should be carried out by specialists in mental health care. Patients who screen positive for BDD in a non-psychiatric clinical setting should be promptly referred to a mental health clinician for further assessment and treatment. When caring for a patient with BDD, the patient's degree of insight regarding BDD beliefs should be assessed, as the lack of insight can represent a major obstacle to treatment. Ms. G lacks any insight into the fact that the cause of her distress is psychological rather than physical, and so presenting a course of treatment that includes psychotherapy and psychotropic medications, rather than dermatologic procedures, could provoke reactions ranging from incredulousness to despair or hostility. It can be helpful to formulate the patient's pathology in terms of the distress and impairment that dysmorphia causes, rather than directly confronting the patient's delusional beliefs. Inquiring about and exploring the negative ways that a patient's beliefs and behaviors have impacted their function and quality of life can help to identify areas that may be amenable to psychological and/or psychiatric treatment. For example, a clinician might approach the topic with Ms. G in the following manner: "It sounds like your anxiety about your skin has kept you from enjoying special moments in your life, like your graduation, and the anxiety is now keeping you from pursuing your education. Have you ever thought about talking to someone about that anxiety or learning strategies to help you feel less self-conscious? Would you be interested in pursuing treatment that might make it easier for you to make it to class so you can continue in graduate school? Patients often remain insistent on receiving medical or cosmetic treatments for their perceived defects. If they are not satisfied with their current medical care, they often will seek the opinion of numerous physicians. Such treatments are highly unlikely to be effective and may even lead to unintended side effects or complications and even worsen the patient's current distress. Successful treatment of BDD often involves medication, psychotherapy, or a combination of both. For mild BDD symptoms without severe depression or risk of suicide, monotherapy with either medication or psychotherapy is reasonable. For patients with more severe impairment or comorbidity, combination of medication and therapy is considered first-line treatment. Pharmacotherapy for BDD generally consists of serotonergic agents, and selective serotonin reuptake inhibitors, SSRIs, are considered first-line due to their tolerability and superior safety profile. Similar to OCD, treatment goals include significant reduction in obsessive thoughts, compulsive behaviors, and clinical distress. While some patients may notice improvement in their symptoms at typical dosages, it is often necessary to go beyond the usual maximum antidepressant/anti-anxiety dosage to achieve optimal clinical effect. For some patients whose symptoms are refractory to treatment within the maximal tolerated dose of one SSRI, switching to other serotonergic agents, such as serotonin norepinephrine reuptake inhibitors or augmentation, may provide benefit. For patients who do not respond despite augmentation, discontinuation of the SSRI and switching to monotherapy with the tricyclic antidepressant clomipramine is considered a reasonable next step. Because of the risks associated with taking tricyclic antidepressants, monitoring of electrocardiography is necessary prior to initiation and during titration. Cognitive behavioral therapy, CBT, is considered the standard modality for psychotherapeutic treatment of BDD, with specific interventions designed to restructure the patient's negative thoughts about their appearance, prevent repetitive compensatory behaviors, and address motivation for treatment. Because CBT for BDD involves a high level of effort on behalf of the patient, including completing homework assignments and confronting avoided situations, patients with severe symptoms may be unable to engage with CBT when they first present for treatment. For such patients, motivational interviewing can help to enhance adherence to the therapeutic process, and supportive psychotherapy can form a bridge until sufficient rapport has been established or until medications have begun to reduce a patient's symptoms to the point where they are able to engage in targeted therapy. When referring a patient with BDD for treatment, it is also imperative to assess for immediate risk of danger and self-harm, particularly the risk of suicide. When asked, Ms. G confided that she has been feeling increasingly hopeless about her appearance and has started thinking about ways to end her life if she were unable to get a skin graft because she could not bear to go on living the way she was. If a patient is at imminent risk of harming themselves or anyone else, they should be immediately transferred to an emergency department or inpatient setting for psychiatric evaluation and stabilization. Once a patient's acute suicidal ideation has been stabilized, treatment of the underlying dysmorphic thoughts can begin. Response to treatment for BDD is typically gradual, with symptoms resolving slowly over a course of months once a patient receives appropriate treatment. For patients who achieve remission of their BDD symptoms with pharmacotherapy, treatment should be continued for at least 3 to 4 years to prevent relapse. Key points to remember. BDD is common among patients seeking cosmetic procedures, but is often underdiagnosed. Patients with BDD typically lack insight into the overvalued nature of their beliefs. Care must be taken when addressing the patient's beliefs and formulating an effective care plan. In most cases, cosmetic procedures or surgeries do not provide relief to patients with BDD and might even worsen their distress. Treatment of BDD involves antidepressant medications, targeted CBT psychotherapy, or a combination of the two. Patients with BDD should be referred to a mental health clinician. 14. I can't bear to part with any of it. Michelle Zaidlin, MD, and Dolores Perdomo, PhD. Ms. F is an 83-year-old female who presents with concerns of having memory loss and increased anxiety. She describes in the past attending therapy due to life stressors, such as her husband's addiction and recent loss of family members. She has difficulties managing her finances and is several years behind on her taxes. She struggles keeping her home organized, with piles of papers all over that she never gets around to throwing out. Currently, her home needs electrical and plumbing repairs, but she can't decide on anyone to come fix the problem. She also finds herself reading things repeatedly because she forgets what she has read and making to-do lists but being unable to accomplish many of the items. For many years, she has had problems with family members over these long-standing tendencies and feels ashamed to have anyone come to the house. She frequently argues with her daughter, stating, "I can't throw away papers because they are all important." What do I do now? Hoarding disorder, HD, is characterized by a persistent need to save possessions, regardless of value, and substantial distress parting with or discarding items. This causes compromise of living spaces due to accumulation of possessions and impairment in daily functioning. Current data suggests that between 2% and 5% of the population experience clinically significant symptoms of hoarding. Onset of hoarding symptoms typically occurs in childhood, adolescence, or early adulthood. Onset in later adulthood is rare and may be indicative of another medical or neuropsychiatric condition. In the case of Ms. F, although the patient presents for care for the first time in her life, the hoarding behaviors have been present for many years but have not been disclosed due to shame. A diagnosis of HD can only be made once other mental disorders or medical conditions have been ruled out as the primary driving factor. Different comorbidities and time of onset are outlined in Table 14.1. Mental disorders associated with hoarding behaviors include anxiety disorders, attention deficit hyperactivity disorder, ADHD, clinical depression, obsessive-compulsive disorder, OCD, and psychotic disorders. In anxiety disorders, feeling easily overwhelmed when facing a task can cause overthinking and ultimately the avoidance of tasks such as cleaning and organizing. ADHD may also present with hoarding symptoms due to difficulty with task initiation and completion caused by inattentiveness and easy distractibility. Severe clinical depression can present with poor concentration, low energy, and a lack of motivation, which can lead to hoarding behaviors. In patients with OCD, hoarding behaviors may be secondary to the inability to discard objects due to superstitious thoughts or fear of contamination. In patients with psychosis, hoarding may be a direct consequence of delusional thinking or avolition. In older adults, the presentation of hoarding symptoms may be indicative of an underlying neurodegenerative disease. The hoarding behaviors can be attributed to the cognitive decline in multiple cognitive domains, such as executive functioning, working memory, and sustained attention. This can present with symptoms such as collecting items, hiding belongings, and engaging in repetitive behaviors. In the case of Ms. F, a neurodegenerative disorder was ruled out. Genetic and medical conditions associated with hoarding behaviors include Prader-Willi syndrome and traumatic brain injury. Table 14.1. Comorbidities associated with hoarding behaviors. Onset in childhood, adolescence, or early adulthood. Depressive disorders, anxiety disorders, post-traumatic stress disorder, brain lesions, for example, prefrontal and cingulate cortices. Obsessive-compulsive disorder, autism spectrum disorder, attention deficit hyperactivity disorder, schizophrenia, anorexia nervosa. Onset in later adulthood, depressive disorders, anxiety disorders, post-traumatic stress disorder, brain lesions, for example, prefrontal and cingulate cortices, mild cognitive impairment, dementia, executive dysfunction. Clinical manifestations of hoarding disorder. In people with HD, hoarding behavior typically stems from irrational beliefs about the hoarded objects. They place significant importance on having the object regardless of its value, and disposing of the item causes severe distress. People with HD often feel ashamed, guilty, and judged, and they fear losing control of their independence, as in the case of Ms. F. They develop a strong attachment to their belongings, even to seemingly worthless or unusable items, which for them carry an important sentimental value. At first, the behavior may be perceived as a preference for collecting items such as mugs or dolls, or signs of being messy, disorganized, or untidy. However, this soon turns into a preoccupation for purchasing or not throwing away items, growing into a cluttered, unsanitary, and unsafe living environment. Their accumulated clutter can block access to different parts of the house or doorways, increasing the risk of accidents and injuries. Hoarding can also lead to unsanitary conditions, posing serious health problems for the person and those who live with or near them. In the case of animal hoarding, this can stretch to pets living in inhumane conditions, confined to small spaces, without proper feeding, grooming, or veterinary care. People who exhibit hoarding behaviors often begin to have problems with their significant others, family, friends, and neighbors. Those who live in proximity to the hoarder may feel frustrated, angry, and stressed by the problems the hoarding behavior is causing, and the unwillingness of the person to clean up after themselves. Hoarding behavior can lead to social isolation, as individuals may avoid having visitors or inviting people into their homes due to shame or embarrassment about the clutter. Some individuals with HD may lack insight into the severity of their problem, while others are aware of their hoarding behavior and the associated distress. In the case of Ms. F., she believes that years of accumulated documents and correspondences hold significant importance and fears that throwing them away may get her in trouble. She also feels that cleaning her house is an impossible task due to the hoarded material. She is so overwhelmed she does not know where to start, yet she is unable to trust others to help. She feels that others will judge her, throw away her belongings without any regard for her feelings, and force her to live in a nursing home facility. The consequences of hoarding are further described in Table 14.2. Table 14.2. Consequences of hoarding. Increased risk of accidental injuries, fire hazards or falls. Unsanitary conditions. Respiratory problems from poor air quality caused by dust and decay. Health risks caused by mildew or mold. Vermin infestations. Animal hoarding. Inability to access surfaces or appliances. Plumbing and sewage problems. Poor nutrition and food contamination. Poor grooming and hygiene. Contamination of medications. Social isolation and shame allowing others into the home. Increased risk of eviction and homelessness. Treatment. It is important to understand that HD is a complex mental health condition that goes beyond cleaning out clutter or getting organized. Treatment is often complex and multifaceted. It involves medical and psychiatric evaluation and requires professional therapeutic intervention to target information processing difficulties, irrational beliefs about objects, and the emotional aspects and practical challenges of the hoarding behavior. Pharmacological treatment. At present, there are no Food and Drug Administration, FDA, medications approved for HD. However, as hoarding symptoms are associated with anxiety, obsessive, and avoidance behaviors, serotonin reuptake inhibitors, SRIs, are used as first-line agents. Particularly, agents that are FDA approved for the treatment of OCD, including sertraline, fluvoxamine, fluoxetine, and paroxetine, have shown benefit in patients with HD. Additional trials are currently examining the use of stimulant medications, which are used in the treatment of ADHD for hoarding behaviors. Patients with ADHD benefit from improved attention and concentration when treated with these medications. While these symptoms may not be at the root of a primary HD, this presentation is often seen with hoarding behaviors. Psychological treatment. Cognitive behavioral therapy, CBT, is the most used therapeutic modality for treatment of HD, including specialized approaches such as group CBT or augmented CBT with skill-building strategies, internet support, and contingency management for HD. While some studies have shown progress in reaching certain treatment goals, few have established prolonged improvement in HD symptoms or clinical changes. Some evidence has suggested that incorporating home-based behavioral treatment may improve clinical outcomes for patients. Most researchers agree that HD is a complex psychiatric condition, and more evidence-based, multidisciplinary approaches are needed to effectively treat HD. In therapy, treatment begins by reviewing the client's specific HD symptoms, perceptions, and interference with daily functioning, and evaluates for safety concerns. It is important that the therapist provides empathy and demonstrates support. For patients like Ms. F., listening and using the same language as the person when talking about their possessions helps show respect and understanding and ultimately builds trust. The ideal opportunity to educate the patient about HD is as the therapist gathers details about how the hoarding behavior unfolded. Together, the patient and therapist begin to identify factors such as life stressors, traumatic events, and psychological vulnerabilities that contribute to beliefs and behaviors seen in HD. Hoarding is also associated with difficulties in information processing, which can include problems with attention, planning and organizing, decision-making, problem-solving, and finding and coordinating resources. The patient can then identify in which of these domains they face the most challenges. With the therapist, small, realistic, and attainable goals that lead to sustainable changes can be put in place. In the case of Ms. F., helping her develop problem-solving skills can help her define the problem and contributing factors, generate possible solutions, evaluate which one is most feasible, break it down into manageable steps, and assess how well the solution worked. Emphasis should also be placed on safety when developing an action plan. Home visits may be necessary to fully evaluate the severity of the hoarding, the associated risks, and the ability to take care of themselves and their families. Support beyond the therapeutic process must also be part of the recovery and relapse prevention phase. Expanding the patient's support network is critical to keeping them engaged and motivated to continue to make changes. This includes, when possible, including the family as part of treatment and allowing them to gain better insight into the struggles and limitations of their loved one. Connecting the patient and family to community programs, support groups, and large-scale organizations dedicated to HD can help the patient to stay motivated and engaged in their recovery process. Examples of community resources and support services are provided in Table 14.3. Table 14.3. Community resources and support services for hoarding disorder. International OCD Foundation. Clutterers Anonymous. The Clutter Movement Family Support Group. Key points to remember. HD is a complex mental health condition that goes beyond cleaning out clutter or getting organized. Treatment is often complex and multifaceted. Onset of hoarding symptoms typically occurs in childhood, adolescence, or early adulthood. When hoarding symptoms occur in later adulthood, they may be indicative of another medical or neuropsychiatric condition. 15. It's a constant struggle between reason and the urge to pull. Lowai Alrojala, MD, and Suchitra Joshi, MD. T is a 14-year-old female with alopecia along the crown of her scalp that has been worsening for the past few months. Upon questioning by the psychiatrist, T reluctantly reported experiencing a strong urge to pull her hair out. She said that she would hide in her room and would pull hair from the crown of her scalp as well as from the back of her neck. After pulling the hair, she would experience a sense of relief and would then examine it carefully, looking for the perfect hair. If she was unsatisfied with the shape of the hair, she would bite off the root and swallow it. If she found the perfect hair, she would store it in a shoebox in her room. She would wear headbands and scarves to hide the bald spots. She also said that she was terrified of being caught engaging in this irrational behavior. What do I do now? TTM is characterized by recurrent, irresistible urges to pull out one's own hair, resulting in hair loss. These episodes of hair pulling can take place in various areas of the body, including the scalp, eyebrows, or eyelashes. Despite repeated efforts to decrease or stop hair pulling behaviors, individuals with TTM often find it difficult to do so. This hair pulling behavior is accompanied by significant distress, shame, or embarrassment, and it can impair various aspects of the individual's daily life, including social interactions, work, and personal well-being. TTM, or hair pulling disorder, is part of the obsessive-compulsive related disorders. This is based on current research showing similar genetic, neurocognitive, and symptomatologic presentation between TTM and obsessive-compulsive disorder, OCD. A recent meta-analysis reported a pooled prevalence within several community samples of 1% for TTM and almost 8% for any hair-pulling behavior. A higher prevalence was found in females than in males, but was not found to be statistically significant. Clinical samples show a much higher prevalence in women at a ratio of almost 4-to-1. Women who suffer from TTM are more likely to seek clinical intervention, most likely due to increased levels of distress and dysfunction. TTM can cause significant psychological distress and has been shown to be associated with multiple other psychiatric comorbidities. One of the recent largest studies conducted in a representative community sample showed the prevalence of other co-occurring disorders to be extensive, with more than half of those individuals with TTM suffering from another anxiety disorder. Other comorbid conditions include clinical depression, attention deficit hyperactivity disorder, post-traumatic stress disorder, and OCD, skin picking disorder, and comorbid alcohol or drug abuse. Despite no clear pathophysiological causes, many theories currently exist to try and explain this phenomenon associated with hair pulling. Behavioral theorists propose that the disorder may develop in response to stress as a method of tension/stress reduction. TTM is often associated with emotional and psychological triggers, such as stress, anxiety, boredom, or frustration. Hair pulling may provide a sense of relief or comfort for individuals dealing with these emotions, leading to a repetitive cycle of unwanted behavior. Based on the principles of conditioning and habit formation, the act of hair pulling may begin as a response to a specific trigger and continue through a reward system. Others that favored the modeling theory suggest that the disorder may be initiated through observational learning. In some cases, stressful life events, trauma, or a history of abuse may contribute to the onset or exacerbation of TTM. Despite multiple studies showing familial patterns in TTM, no gene has been clearly identified. Nonetheless, research has shown an association with multiple genes that are implicated in obsessive-compulsive disorders and Tourette syndrome, and it is widely believed that TTM has some neurobiological underpinning. The hair pulling in TTM commonly starts at or shortly after puberty, as in the case of T. TTM is typically a chronic condition that may become relapsing and remitting over the course of months and even years. In some females, the hair pulling may intensify during the premenstrual phase. The hair pulling most often includes the scalp, as in the case of T, but may also include the eyelids and eyebrows, as well as axillary, facial, pubic, and perirectal hair. The hands are most commonly used for hair pulling, thumb and index finger, but tools may be used by some patients as well. Hair follicles removed may be chosen at random, or may be chosen based on length, location, or sensation. T pulls her hair repeatedly, searching for the perfect follicle. Hair pulling may extend for short periods of time, or may last for hours. The hair pulling may be automatic, with the patient's attention engaged elsewhere, or it may be focused, whereby the patient is preoccupied by the hair pulling act itself. Most patients engage in both forms of automatic and focused hair pulling. Even though many with TTM experience hair loss, the loss may not be as pronounced in individuals that experience hair pulling in multiple locations. Furthermore, many may attempt to hide the hair loss with specific hairstyles or fashion accessories, like in the case of T. It should be noted that the disorder requires that the hair pulling causes significant impairment and distress in functioning. This impairment appears in the form of missing days from work or school, and increased social isolation, in the setting of feelings of embarrassment and shame. In the case of T, she is more socially withdrawn and struggling at school. TTM is a clinical diagnosis. However, if an underlying dermatological disorder is suspected, dermoscopy may be done, which usually shows broken hairs with variable shaft lengths, decreased hair density, and short vellus hair. Histopathology classically shows an elevated percentage of catagen follicles, pigment casts, and traumatized hair follicles, and no change in follicle number or signs of inflammation. Several scales and measures have been established to aid in the assessment of possible TTM cases, including clinician rating scales. Two such scales are National Institute of Mental Health, NIMH, Trichotillomania Symptom Severity Scale, and the NIMH Trichotillomania Impairment Scale. The NIMH scales combined form the NIMH Trichotillomania Scale, which has shown good inter-rater reliability and convergent validity in adults. Patient rating scales have been developed as well, including the Massachusetts General Hospital Hair Pulling Scale. This scale is a short form that consists of 7 items and helps track symptom changes. Other scales include the Trichotillomania Scale for children, which has both a parent and child version and consists of 15 items. A detailed history, physical examination, and lab work should be conducted to rule out other etiologies or disorders. It should be noted that hair removal for cosmetic purposes precludes the diagnosis. Similar is the case for individuals who may bite or twist their hair without removal. Multiple psychiatric disorders may present with comorbid hair pulling. Psychosis may present with command auditory hallucinations and delusions that may lead to the individual engaging in hair pulling, making the screening for delusions and hallucinations integral in ruling out a primary psychotic disorder. If the hair removal is being done in response to obsessions with symmetry, a diagnosis of OCD should be explored. In the spectrum of OCD, body dysmorphia may present with hair removal that is self-perceived to be defective or flawed. A urine toxicology screen may also be necessary to rule out hair pulling that is a result of substance use. Several dermatological disorders may present with hair loss like that seen in TTM that are not associated with hair pulling. A dermatology consultation, coupled with dermoscopy, proves valuable in cases where differentiation between primary dermatological disorders like traction alopecia, tinea capitis, or other skin-related conditions in TTM is necessary. Treatment. Very few cases of TTM remit without intervention. Nonetheless, even with intervention, studies in pediatric populations report that only 50% of those treated improve. The literature on available treatments is often lacking and sometimes contradictory. Currently, no Food and Drug Administration, FDA-approved medications exist for the treatment of TTM, with management relying on results from multiple studies conducted in adult and pediatric populations, utilizing both pharmacological and non-pharmacological interventions. It is essential to obtain collateral information from individuals who reside or spend long hours with the patients. Patients may be reluctant to report their behaviors as well as the degree to which these behaviors interfere with their day-to-day functioning. Once in treatment, patients are also encouraged to journal their hair pulling behavior and its triggers. Pre- and post-treatment photos, when available, allow for a more objective measurement of treatment results. In children and adolescents, psychotherapy is strongly recommended as a first-line treatment of TTM. Habit reversal therapy, HRT, is one form of cognitive behavioral therapy that has shown promise in addressing the core symptoms of TTM. HRT consists of weekly sessions that address core aspects of awareness, stimulus control, social support, competing responses, and relaxation. HRT sessions can be modified based on the developmental stage and age of the child and require the child to be actively involved in treatment by performing assignments at home to train on the skills taught during the sessions. Pharmacotherapy should be considered in patients who fail an adequate trial of psychotherapy, those whose symptoms are severe, limiting their involvement in therapy, or those with psychiatric comorbidities. Pharmacotherapies are more limited in the treatment of pediatric TTM due to the paucity of evidence. One of the few randomized control trials that assess the effectiveness of N-acetylcysteine, NAC, in the treatment of TTM showed no significant difference between the treatment and control groups. Nonetheless, positive effects in adults in multiple case reports and case series in pediatric populations warrant further investigation into the effectiveness of NAC in children and adolescents, and a possible medication trial given the favorable side effect profile of NAC. Other uncontrolled studies exist that show positive effects using clomipramine and olanzapine in managing TTM symptoms, with medication side effects limiting the use of these medications. Antidepressants such as fluoxetine and sertraline have been shown to be effective in treating comorbid depression and anxiety, with no effect on TTM symptoms. Some evidence may exist for the use of aripiprazole in the management of TTM. In adults, behavioral therapy with HRT has shown consistent large positive effect sizes in multiple studies, which was further validated in meta-analyses. Other psychotherapies that have shown good effect include acceptance and commitment therapy and novel computerized training methods. Similar to children, no FDA-approved medication exists for the treatment of TTM in adults. The dearth of studies limits treatment choices and informed decisions, with some studies showing conflicting evidence. A recent meta-analysis has shown positive results with regard to hair pulling with clomipramine, olanzapine, and NAC. Interestingly, the selective serotonin reuptake inhibitors, fluoxetine and sertraline, showed no effect on hair pulling or TTM-associated depression or anxiety. A recent randomized double-blind placebo-controlled study in adults has shown promising results with the use of memantine for the treatment of body-focused repetitive behavior disorders such as TTM. Despite the relative ease of reaching a diagnosis of TTM, this condition remains underdiagnosed and undertreated. If left untreated or partially resolved, TTM can lead to significant suffering to both patients and caregivers. Psychotherapy remains the treatment of choice for TTM, with HRT showing the best results. It is imperative that the patient be referred to a specialist who is well-versed in HRT, as not all psychotherapies are created equal, and the choice of psychotherapeutic approach may impact treatment outcomes. Furthermore, validated scales and other objective measures should be used to allow for a thorough evaluation of treatment effectiveness. If HRT is deemed to be ineffective or leads to partial improvement in symptoms, pharmacotherapy may be added as an adjunct. Nonetheless, providers need to educate patients and/or caregivers on the paucity of data and current limitations of treatment. Pharmacological treatment should be considered for patients with significant symptomatology and psychiatric comorbidity after taking into consideration the risks and benefits of each agent. Key points to remember. TTM is characterized by recurrent pulling out of one's hair, with attempts to decrease the behavior and causing significant dysfunction and distress. TTM often begins in childhood and adolescence and may persist into adulthood if left untreated. Psychotherapy remains the first-line treatment for TTM, with psychotropics playing a possible role in alleviating the symptoms. further research is needed to explore possible pharmacological treatments for TTM. 16. The smell of gasoline brings back those horrible memories. Scott Leary, MD, and Rosie E. Curiel Sid, PsyD. Ms. R is a 34-year-old female who presents 1 week after a motor vehicle accident in which her leg was trapped under the wreckage. She was subsequently evaluated in the emergency department and discharged with pain medications and outpatient follow-up without any major injuries. She endorses minimal pain, but is distressed due to an anxiety attack that occurred a few days after the accident while driving to work. Since then, she has avoided driving as the smell of gasoline causes her to experience flashbacks of the accident. She reports multiple episodes of zoning out and losing track of time, difficulty concentrating, and disturbed sleep with accident-related nightmares. Since the accident, she reports feeling depressed, on edge, unusually short-tempered, easily startled, and emotionally distant from her friends, husband, and family. What do I do now? Acute stress disorder, ASD, emerges from real or threatened exposure to death, severe injury, or sexual trauma. This exposure must either be experienced directly, be witnessed, or have occurred to a significant person in the individual's life. Symptoms occur in temporal proximity to the traumatic incident, typically anywhere between 3 days and 1 month after the exposure. Clinically significant functional impairment or distress must be present to meet the threshold of diagnosis. If symptoms last for longer than 1 month, ASD would be classified as post-traumatic stress disorder, PTSD, a disorder marked by greater chronicity than ASD. According to the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, text revision, DSM-5-TR, there are 5 categories to classify the various symptoms that occur in ASD. These include intrusive thoughts, negative mood, dissociation, avoidance, and arousal. At least 9 symptoms must be present to diagnose ASD. Importantly, the symptoms must not be attributable to medications, substance use, medical conditions such as traumatic brain injury, or brief psychotic disorder. Intrusive symptoms include distressing memories of the event or flashbacks, dreams, dissociative reactions, and psychological or physiological reactions to cues that serve as reminders of the traumatic event. Negative mood symptoms may include a reduced ability to experience a sense of pleasure or satisfaction, positive mood, or an emotional disconnection from others. Dissociative symptoms include an altered sense of one's reality and surroundings, such as the sensation of time slowing down and seeing oneself from another's perspective. In more severe cases, a person may be unable to remember important aspects of the trauma due to dissociative amnesia. Avoidance symptoms include efforts to avoid memories, feelings, thoughts, and external reminders such as activities, situations, or objects that remind an individual of their trauma. Arousal symptoms include problems with concentration and sleep, irritability, anger, hypervigilance, and an exaggerated startle response. Ms. R meets criteria for ASD, as evidenced by flashbacks of the accident, depressed mood, a sensation of zoning out, avoidance of driving, trouble concentrating, insomnia, emotional distancing, increased irritability, and an exaggerated startle response. It is estimated that 20% to 90% of the population at large has been exposed to at least one extremely stressful event in their lifetime. This broad estimate of prevalence suggests a dearth of epidemiological data, likely because ASD can only be diagnosed within 1 month of exposure to a traumatic event. Individuals who are diagnosed with ASD are 24 times more likely to die from suicide as compared to those without ASD. This underscores the potential severity of distress that a person with ASD may experience during the initial period following the trauma exposure, and the importance of monitoring patients for ASD during the subacute phase following the trauma. Moreover, The all-cause mortality is doubled for patients with a diagnosis of a traumatic stress disorder as compared to those without. ASD was first introduced in 1994 as a diagnosis in the DSM-4 to predict the likelihood of developing PTSD and to begin treatment proactively for patients in the days and weeks immediately following a traumatic incident. In the previous DSM-4, dissociative symptoms were required to make a diagnosis of ASD. However, a diagnosis of ASD was found to have a weak predictive value for subsequent development of PTSD in both children and adults. As a result, the value of early diagnosis of ASD as a predictor of longer-term symptoms and functional impairment has been reconceptualized to focus on identifying individuals with severe stress reactions that require clinical intervention rather than attempting to predict future psychopathology. In the DSM-5, published in 2013, dissociative symptoms were no longer required to make a diagnosis of ASD, but were still included as part of the diagnostic criteria. Identifying ASD remains critically important because it is estimated that up to 70% of individuals who are diagnosed with ASD may subsequently meet criteria for PTSD, which is the more chronic condition. Notwithstanding, despite these adjustments in diagnostic criteria to detect ASD more readily, it is estimated that at least 1/3 of individuals are not identified. Research has demonstrated that individuals exposed to trauma tend to follow one of the following 4 trajectories over time: resilient, consistently showing few symptoms; worsening, initially mild with delayed worsening of symptoms; recovery, initially distressed with gradual symptom remission; and chronically distressed, consistently severe symptoms. As post-traumatic stress responses do not progress linearly and may change over time, an individual's initial reaction may not accurately predict their future ability to adapt. Individuals exposed to a traumatic event should be assessed. The assessment includes a comprehensive psychiatric evaluation, including screening for ASD symptoms, ASD symptom severity, degree of functional impairment, risk factors, and potential for suicidal thoughts and at-risk behaviors. Certain characteristics that are predictive factors for ASD and PTSD should be identified. A prior history of psychiatric disorders, female gender, and the severity and recurrence of trauma exposure are all factors that can predispose an individual to ASD. Ms. R's prior history of anxiety is important to explore, given that individuals with a history of exposure to trauma are at an elevated risk for developing chronic symptoms. Understanding how Ms. R is coping with the traumatic event is important because maladaptive coping behaviors such as substance abuse may need to be addressed. Adaptive versus maladaptive coping should be carefully monitored, especially among patients who have a history of drug or alcohol abuse. Given the increased risk of suicide following a traumatic event, our priority should be to screen for suicidality. A comprehensive suicidality screening requires an assessment of Ms. R's overall sense of safety and access to care in case of an emergency. A brief suicide symptom scale, such as the Columbia Suicide Severity Rating Scale, may be used to identify and quantify symptoms. Mobilizing Ms. R's current network of family and friends can also be beneficial during the acute stages of ASD, as they can provide emotional and practical support. A thorough evaluation will lead to a collaborative approach regarding what symptoms to target first and how. Treatment. Trauma survivors frequently exhibit intense distress symptoms during the initial days and weeks following a traumatic event. However, a significant majority of survivors tend to adapt, and these distressing symptoms often subside over time. For individuals exposed to a traumatic event, it is crucial to prioritize their safety and strive to meet their fundamental needs. Key intervention should encompass providing access to essentials, such as food, water, shelter, and healthcare, alongside efforts to enhance their safety and security. For those exposed to trauma, initial intervention should encompass both practical and emotional support. Although close monitoring is recommended, persons exposed to trauma will adapt and require no significant clinical intervention. The diagnosis of ASD has been suggested as a way to identify individuals who might benefit from early interventions or increased support. The treatment of choice for ASD is trauma-focused cognitive behavioral therapy, CBT, which allows patients to better understand their thoughts, feelings, and behaviors associated with the trauma and learn how to manage their symptoms. Trauma-focused CBT teaches patients adaptive skills such as identifying and resisting cognitive distortions and how to implement adaptive behaviors to cope with their stress. Another component of trauma-focused CBT includes exposure therapy, which mimics the process of fear extinction by progressively exposing patients to traumatic cues that may elicit traumatic memories, but in a controlled environment, with the goal of having a patient's fear reduced and avoidance decreased. Many patients who endure a traumatic event may also experience physiological hyperarousal, such as tachycardia, elevated blood pressure, and increased sweating. Working with Ms. R to help her regulate her autonomic nervous system through diaphragmatic breathing and other relaxation techniques that promote activation of the parasympathetic nervous system is an important first step. That will allow us to move into exposure techniques that can ultimately help her drive again while remaining at a mild to moderate level of physiological arousal. It is important for providers to be tactful in their history-taking as they are gathering information about recent traumatic incidents, because re-traumatization can and does occur if a healthcare provider preemptively debriefs about the details of the trauma before patients are prepared to share what transpired. Asking open-ended questions about the nature of the trauma and not moving beyond the headlines is usually acceptable when treating ASD symptoms. Effective trauma-focused CBT for ASD incorporates various strategies, including exposure-based and cognitive reframing strategies. The therapeutic modality of choice for Ms. R would be trauma-focused CBT. Trauma-focused CBT involves repeated exposure to the aspects of the trauma that are objectively safe but cause anxiety and result in avoidance, such as driving a vehicle in our example. Ms. R experienced panic symptoms approximately 1 week after the accident when driving a vehicle and has been avoiding driving since, a limitation that she appraises as problematic for her day-to-day functioning. An important aspect of trauma-focused CBT involves the identification of and challenging of any maladaptively stored cognitive appraisals, such as "I am not safe," by using techniques such as Socratic questioning and behavioral experiments. These allow Ms. R to better understand her thoughts, feelings, and behaviors associated with the traumatic incident. Because the initial sessions were dedicated to ensuring that Ms. R had the skill set to manage her physiological arousal, imagination is used to progressively expose her to being behind the wheel of a car again. Other sensations, such as the smell of gasoline, are introduced so that she can learn how to manage her symptoms when exposed to traumatic cues. The goal is fear reduction and decreased avoidance of driving. For those patients who possess stronger coping mechanisms, trauma reprocessing therapies such as eye movement desensitization and reprocessing can be a highly effective means of reducing distress associated with a traumatic incident and reprocessing maladaptive cognitive distortions that may have arisen in response to the trauma in a relatively short period of time. While several medications have shown efficacy in reducing mood symptoms in PTSD, there is a dearth of research assessing the efficacy of these medications in ASD specifically, likely due to the limitations of studying a disorder that is time-limited. Thus, there is currently no high-quality evidence to support pharmacological treatment for ASD. Due to the significant overlap in symptomatology with PTSD, clinicians can infer that those treatments proven effective for PTSD may also be useful in patients with ASD. There are symptoms that may improve with pharmacological treatment, but trauma-focused CBT remains the mainstay of treatment. In the case of Ms. R, who avoids driving and has flashbacks of the accident, a non-pharmacological approach is essential. She is also experiencing other symptoms, such as insomnia and panic attacks, that may be ameliorated with medication if non-pharmacological strategies are not effective. For Ms. R, cognitive behavioral therapy for insomnia could be a particularly crucial aspect of treatment, given her difficulty sleeping and recurring nightmares. While clinically, benzodiazepines are commonly prescribed and highly useful in patients with ASD, long-term benzodiazepine use should be avoided because of the significant risk of dependence, particularly in those with pre-existing substance use disorders. Beta blocker treatment after a traumatic event has been shown to reduce sympathetic symptoms of tachycardia and diaphoresis, but does not affect the incidence of PTSD. However, there is insufficient evidence to recommend beta blockers as an effective treatment. From a pharmacological standpoint, it is important to keep in mind that Ms. R prefers not to take medication. She is willing to consider pharmacological treatment to alleviate her symptoms due to her perceived level of distress. To that end, a collaborative conversation should occur to evaluate her willingness to engage in short-term versus long-term treatment and evaluate which symptoms are causing her the most distress and functional impairment. This is important because the treatment approach to target improved sleep, for example, is different, and it often can be treated more quickly than other symptoms, such as feeling more emotionally distant or having poor concentration. Selective serotonin reuptake inhibitors, SSRIs, have shown efficacy in the treatment of PTSD, but these medications may not be appropriate as in clinical trials, SSRIs have not been found to be efficacious for the treatment of ASD. In the case of Ms. R, given the length of time that SSRIs would need to be taken to take effect and the lack of efficacy, in the short term, other medications can be used to provide her with more rapid relief. If Ms. R's clinical presentation evolves to an episode of clinical depression, the use of an SSRI should be strongly considered. In PTSD, prazosin may reduce the sympathetic activation leading to trauma-induced nightmares. In the case of Ms. R, if the nightmares persist despite non-pharmacological interventions, its use may be helpful. While medications of the benzodiazepine and sedative classes are not recommended in the long term, they can be highly effective for short-term use as a rescue drug to quickly abate episodes of intense anxiety. Extended daily use of benzodiazepines is highly discouraged, as it may interfere with the process of adaptation. Key points to remember. Trauma survivors often experience intense distress initially, but most tend to adapt, and these symptoms usually diminish over time. The assessment of ASD involves the evaluation of symptoms that fall into 5 categories. They include symptoms of intrusion, negative mood, dissociation, avoidance, and arousal following a traumatic event. The assessment also includes evaluation of symptom severity, degree of functional impairment, risk factors, and potential for suicidal thoughts and at-risk behaviors. The treatment of choice for ASD is trauma-focused CBT. While medications of the benzodiazepine and sedative classes are not recommended in the long term, they can be highly effective for short-term use and management of acute anxiety and insomnia. 17. When Memories Keep Me Awake. Vishnu Tiwari, MD, and Maria Rueda Lara, MD. Ms. M was having a difficult time. She was T-boned at a busy intersection 6 weeks ago and soon began to notice changes in her mood and sleep. Ms. M described difficulties falling asleep due to intrusive images of the accident. She revealed that in addition to these memories, she would awaken from sleep 2 to 3 times a night with vivid nightmares about car accidents. Ms. M revealed that she would often feel on edge and tense throughout the day, and that she would frequently startle to loud noises. She continued to experience intrusive images of her totaled car and persistent nightmares. Ms. M also describes looking over my shoulder whenever she must cross intersections in her neighborhood. She has been unable to return to driving her car since the accident because when she drives, other vehicles and loud noises trigger intense fear and anxiety. Taking public transit is adding hours to her daily commute. Ms. M wants to know what you can do to help her feel like herself again. What do I do now? The association of trauma with emotional distress and behavioral changes is a well-known phenomenon, one that has been observed in society since the beginnings of civilization. The aftermath of the Vietnam War saw the formal inclusion of post-traumatic stress disorder, PTSD, in the Diagnostic and Statistical Manual of Mental Disorders, 3rd edition, DSM-3, in 1980. The disorder's diagnostic criteria have evolved since this time, especially in its definition of what constitutes a traumatic event. Nonetheless, PTSD as defined in the DSM-5 TR is a fairly common, highly comorbid psychiatric disorder that can cause substantial emotional distress and significantly affect quality of life. As such, a review of its core features is highly important for clinicians. PTSD represents the development of psychiatric symptoms following exposure to trauma. Conceptualizing trauma is crucial to understanding PTSD as a diagnostic construct. The DSM-5 TR defines an exposure as traumatic if it poses an immediate threat to life or limb and is accidental or unnatural in nature. In addition to the occurrence of a qualifying trauma, the diagnosis of PTSD requires a qualifying exposure. Individuals are generally exposed to trauma through direct experience, by either being a direct victim of trauma or witnessing a traumatic event. Other qualifying exposures include learning of trauma that has happened to close friends or family members and repeated exposure to adverse stimuli of the traumatic event. Epidemiologic studies have found that up to 20% of adults in the U.S. are exposed to trauma in a given year, and up to 50% of adults have at least one traumatic exposure in a decade. In decreasing order of prevalence, some examples of traumatic exposures include learning about the unnatural and accidental death of a family member or friend, witnessing a life-threatening injury, experiencing a motor vehicle accident, as in the case of Ms. M., and being the victim of a natural disaster. By and large, trauma is not a normally distributed phenomenon among populations. Factors that are associated with greater lifetime exposure to trauma include lack of education, lower socioeconomic status, risk-taking or impulsive temperaments, urban environments, and substance use. As such, providers might consider whether socioeconomic and racial realities predispose their patients to traumatic exposure. The prevalence of PTSD in the general population is estimated to be from 6% to 8%. PTSD epidemiology has been well studied in veterans returning from military interventions. Population-based studies from a variety of traumas, including natural disasters, shootings, and terrorist attacks, found that the rates of PTSD in exposed populations did not exceed more than a third of people exposed. That certain individuals develop PTSD when exposed to trauma implies that other risk factors beyond trauma exposure itself contribute to the development of the disorder. Factors that seem to be strongly associated with the development of PTSD following traumatic exposure include female gender and pre-existing psychopathology. Women such as Ms. M appear to be twice as likely as their male counterparts to develop PTSD, independent of prior psychiatric diagnoses, gender-related reporting biases, or higher prevalence of sexual assault. Clinical presentation. According to the DSM-5, PTSD requires the new development or worsening of existing psychiatric symptoms in 4 domains for a duration of at least 1 month. These domains include intrusion, avoidance, negative cognition and mood, and hyperarousal. Intrusion symptoms represent the unwanted re-experiencing an intense distress triggered by cues reminiscent of the traumatic exposure. In the case of Ms. M, repeated painful memories of the scene of the accident before sleeping represent an intrusive memory. These memories are experienced as emotionally upsetting, particularly vivid, and unwanted, rather than merely ruminative. In contrast to intrusive memories, flashbacks imply partial or whole derealization, in which patients may find themselves lost in the moment or reliving aspects of their traumatic exposure. At worst, They may develop brief but total situational disorientation. Moreover, Ms. M's nightmares represent another intrusion symptom. PTSD-related nightmares may contain images of the traumatic exposure itself, or thematically related images. Avoidance symptoms represent the deliberate efforts made by individuals to avoid distressing triggers or cues. Ms. M's avoidance of driving and reliance on public transport constitutes an example of avoiding tangible cues related to her trauma. Negative alterations in cognitions or mood encompass a range of emotional and cognitive symptoms that may be observed in trauma survivors. These include persistent negative emotions, such as sadness, guilt, and fear, as well as negative beliefs and distorted thoughts about oneself, others, or the world. Emotional numbing, reduced interest in activities, and feeling detached from others may also be present. Trauma survivors may develop a sense of pessimism about the future. Ms. M demonstrates characteristic symptoms including a persistent negative mood state, reported as irritability, and feeling ill at ease throughout the day, feelings of estrangement from her peers, and thought distortions about her ability to cope with the trauma. Changes in arousal or reactivity are typified by Ms. M's exaggerated startle response, difficulties with concentration, and problem sleeping. Her irritability and frequent fights with her family can also be seen as outbursts related to hyperarousal. While development of post-traumatic symptomatology usually occurs immediately following traumatic exposure, full diagnostic criteria can be met months to even years after exposure to trauma. When PTSD develops months or even years after the traumatic event, this condition is described as delayed onset PTSD in the DSM-4 and is currently described by the specifier with delayed expression in the DSM-5-TR, which requires full diagnostic symptomatology to be achieved after 6 months of the traumatic exposure. Of individuals who eventually develop PTSD, the large majority develop symptoms the same day as exposure to trauma, and nearly all develop symptoms within 1 month. It appears that intrusion and hyperarousal symptoms, such as Ms. M's initial flashbacks, nightmares, and exaggerated startle when presenting to her physician, are the first of the disorder to develop. The presence of avoidance and negative emotions, such as numbing at 1 week, appears highly predictive for the eventual development of PTSD. Longitudinal studies of PTSD seem to suggest that the disorder is chronic in course. On average, full diagnostic symptoms for the disorder can persist for 2 to 5 years. Studies of victims of natural disasters seem to suggest that the course is slightly more chronic in women compared to men. The chronicity of the disorder does not neatly map onto persisting functional impairment, with functional impairment seeming to resolve after 7 years after the onset of the disorder. The development of PTSD is often followed by substance abuse and suicidal behaviors. However, these complications may not represent consequences of trauma and may in fact represent consequences of pre-existing risk factors, such as personality traits and socioeconomic and demographic factors. Though highly comorbid with substance use disorders, PTSD does not seem to result in the development of new substance use disorders. Curiously, PTSD is also highly associated with subsequent development of obesity and cardiovascular disease, with rates of metabolic syndrome twice as high as in matched peers. This association might warrant primary care providers to consider screening patients like Ms. M earlier for markers of metabolic syndrome. PTSD is a highly comorbid and chronic psychiatric disorder. As such, it may be mistaken for other diagnoses. Psychiatric symptoms following trauma do not necessarily represent PTSD symptoms, and may in fact represent pre-existing psychiatric conditions or abnormalities in temperament or behavior, including mood disorders, anxiety disorders, neurotic temperament, and personality disorders. PTSD is temporally differentiated from ASD by duration. ASD has a duration that is typically no longer than 1 month and occurs shortly after the exposure. Symptoms following exposure to a stressor, such as loss of a job or divorce, are better subsumed by the diagnosis of an adjustment disorder. Adjustment disorders are diagnosed if the precipitating stressor is not a traumatic event as described in Criterion A in the DSM-5 TR. Although both diagnoses are possibilities in the case of Ms. M, the duration of her symptomatology and the nature of her trauma are more consistent with PTSD. Negative alterations in cognition or mood found in PTSD often appear in clinical depression, and intrusion symptoms and alterations in arousal are found in other anxiety disorders. Carefully determining whether these symptoms are directly linked to a traumatic event will help determine the psychiatric diagnosis. In some cases, patients may describe PTSD flashbacks as intrusive visions or images. These symptoms need to be differentiated from hallucinations characteristic of psychotic disorders and obsessional images seen in obsessive-compulsive disorder. As with all psychiatric diagnoses, PTSD requires that symptoms due to a medical condition be excluded prior to diagnosis. Traumatic brain injury, TBI, can present with symptoms similar to those in PTSD. Amnesia, sleeping difficulties, and abnormalities in arousal and reactivity. Moreover, both PTSD and TBI can emerge from the same types of traumatic exposures, such as assaults, motor vehicle accidents, and combat injury. However, re-experiencing and avoidance symptoms appear to be unique to PTSD, and memory problems found in PTSD emerge from dissociative amnesia rather than from problems encoding information. Screening for PTSD in the primary care setting. PTSD screening in all settings is recommended, especially in high-risk patients who have anxiety symptoms, sleep disturbances, or exposure to trauma. The Primary Care PTSD Screen, PC-PTSD, a validated tool containing 5 items, is widely recommended for screening and is summarized in Table 17.1. A score of 4 or higher is generally considered a positive screening result. Table 17.1. The Primary Care PTSD Screen, PC-PTSD. Initial screen. Have you ever experienced an event that was particularly horrible, frightening, or traumatic? If so, in the past month, have you 1. Had nightmares about the event or thought about it when you didn't want to? 2. Tried hard not to think of the event or went out of your way to avoid a reminder of it? 3. Been constantly on guard, watchful, or easily startled? 4. Felt numb or detached from people or events? 5. Felt guilty or blamed yourself or others for problems related to the event? For each question 1 through 5, if yes, score 1 point. If no, score 0 points. Treatment. 2 options for the treatment of PTSD are pharmacotherapy and trauma-focused psychotherapy. Both modalities are effective. However, there is currently no evidence indicating the superiority of either in treating PTSD. As PTSD is a highly comorbid disorder, close attention must be paid to possible co-presenting conditions such as depression, anxiety, substance use disorders, and personality disorders. Even once PTSD is diagnosed, commonly comorbid conditions should still be investigated and managed. Pharmacotherapy. Serotonin reuptake inhibitors, SRIs, are generally first-line treatment choices. Only 2 medications, sertraline and paroxetine, are approved by the Food and Drug Administration for the treatment of PTSD, but alternate agents appear to be reasonable choices for treatment. Medications such as venlafaxine and duloxetine also appear to be reasonable first-line alternatives. SRIs are further beneficial in patients with comorbid depression and anxiety. Other medications that act on monoamine neurotransmitters, such as tricyclic antidepressants and monoamine oxidase inhibitors, may be effective but are not recommended due to the substantial side effect burden associated with these drugs. Antipsychotic medication and mood stabilizers have also been studied and are not recommended for the treatment of PTSD symptoms due to their unfavorable risk-benefit profile. Patients such as Ms. M are frequently prescribed benzodiazepines due to their immediate anxiolytic and sedative effects. However, the long-term use of benzodiazepines is ineffective in the management of PTSD. These medications do not appear to improve symptoms and carry significant potential for dependence and abuse. Benzodiazepines also may impair the therapeutic effects of combined exposure therapy by impairing memory consolidation and minimizing habituation to arousal. The alpha-1 receptor antagonist prazosin initially demonstrated good evidence as an adjunct for the management of insomnia and nightmares in PTSD. However, a more recent large multi-site randomized controlled trial of prazosin in military veterans failed to differentiate it from placebo. Psychotherapy. Trauma-focused therapies, in particular cognitive behavioral therapy, CBT, and exposure therapy, ET, have the highest level of effectiveness for treating PTSD. CBT attempts to override maladaptive core beliefs. CBT may help alleviate PTSD symptomatology by encouraging patients to challenge dysfunctional thoughts about trauma. Additionally, CBT aims to modify behaviors by incorporating strategies such as social activation and proper sleep hygiene. ET is based on the theory of habituation and attempts to decrease anxiety related to traumatic situations. This exposure occurs through gradually exposing individuals to both imagined and real triggers. Therapists often assist patients in developing exposure hierarchy plans, enabling them to confront increasingly challenging situations until they develop tolerance to their stress response. For Ms. M, a plausible exposure hierarchy might begin with looking at images of car accidents and gradually exposing her to loud noises. She might then be exposed to the scene of her own accident, and if she can tolerate this exposure successfully, it may ultimately culminate in her regaining the ability to drive her own vehicle again. Other trauma-focused therapies include cognitive processing therapy, CPT, and eye movement desensitization and reprocessing therapy, EMDR. CPT is a form of cognitive therapy specifically developed for patients with trauma exposure. It involves psychoeducation and cognitive restructuring of maladaptive beliefs related to the trauma. EMDR, which involves imaginal exposure combined with external stimuli to elicit lateral eye movements, has been found to be effective for improving symptom control. It is possible that the benefits accrued from this modality are more related to exposure and cognitive facets of treatment rather than eye movement. Some individuals may not yet have sufficient psychological stability for trauma-focused therapy, but may nonetheless benefit from supportive psychotherapy or motivational interviewing. These techniques may help to prepare patients for future trauma-focused therapy and should inform all initial encounters with patients presenting with trauma-related symptoms. Key points to remember. PTSD is a psychiatric disorder characterized by the development of symptoms following exposure to a qualifying traumatic event. PTSD is highly comorbid and often chronic in course. In certain cases, PTSD can present with delayed expression, in which full diagnostic criteria are not achieved until at least 6 months after exposure to trauma. PTSD is best managed with trauma-focused psychotherapy and/or SRI medication. 18. Anxiety has taken away my ability to enjoy the simple things in life. Omar Munoz Abraham, MD. Zelda Espinel, MD, MPH, and Dante Durand, MD, MBA. Ms. P is a 63-year-old female who presents with anxiety. She started experiencing fatigue and pain in both hands 8 months ago, which led to a primary care consult with subsequent diagnosis of rheumatoid arthritis, RA. She was started on non-steroidal anti-inflammatory drugs, NSAIDs, but subsequently, She experienced worsening worry that she could no longer perform her job. She reports an intermittent history of having frequent feelings of anxiety with insomnia, generalized worries, and tension in the past. Currently, she notices loss of interest in her hobbies, intermittent insomnia, and feeling guilty about not having sought medical care earlier. She says that she is very anxious and constantly worries about her prognosis and future. She frequently thinks, "What if the doctor tells me my condition is worsening? What do I do now?" Anxiety and depression occur comorbidly and can commonly present in a number of different medical and psychiatric settings. Close to 50% of patients with a depressive disorder have significant anxiety symptoms that may meet criteria for a primary anxiety disorder. The same can be said for those individuals with anxiety disorders who present with comorbid depression. It is not uncommon for even seasoned clinicians to diagnose one condition but not the other. Patients may present complaining of anxiety, worry, and physical symptoms such as restlessness. These symptoms may be causing such significant distress that a concomitant episode of major depression may be overlooked. The patients themselves may be surprised when told they are clinically depressed because they are not sad, depressed, or crying frequently. In the case of Ms. P, she attributes the vast majority of her symptoms to her feelings of worry and anxiety. It takes a knowledgeable and skilled clinician to tease out the presenting symptoms to elucidate the diagnosis. In our case, although the patient did not report feelings of sadness, she reported persistent inability to experience pleasure, or anhedonia, which constitutes one of the gateway symptoms of depression. For other patients, the primary complaint may be symptoms of depression, such as persistent sadness, guilt, and hopelessness. Careful evaluation may reveal that the patient is also experiencing intense and excessive worry. If not recognized and addressed, these anxiety symptoms may perpetuate poor sleep, concentration difficulties, and feelings of pessimism. Their anxiety may be so intense that it can manifest as avoidant behavior and interfere with their day-to-day functioning. As in the case of Ms. P, her excessive worry and fear of receiving bad news from her physician has led to her avoidance of regular medical care. Without recognition and treatment of her anxiety symptoms, Ms. P can easily spiral into worsening depression and have worse medical and psychiatric outcomes. The comorbidity of anxiety and depression disorders appears to have a genetic basis. The greatest shared genetic risk is between major depressive disorder and generalized anxiety disorder. Patients with neurotic temperament are more at risk of developing anxiety and depressive symptoms. History of early childhood trauma and conflict, as well as ongoing psychosocial stressors, may also be triggers for comorbid anxiety and depression. In addition, it is important to note that the presence of anxiety and depression worsens the severity of depression and increases the risk of suicidal ideation. Obtaining the patient's history is a key element of the evaluation. In addition, collateral information from family members and reviewing the patient's medical history may be valuable sources of information. The chronology of symptom presentation is essential for the diagnosis. As in the case of Ms. P, symptoms of anxiety precede the onset of depression. Suicidal risk assessment should always be part of the evaluation. Psychosocial stressors that trigger and perpetuate mood and anxiety symptoms should be identified. It is also essential to evaluate the impact of these symptoms on the patient's ability to function and quality of life. In clinical care settings, depending on the initial presentation, clinicians often focus on the mood symptoms that are most distressing to the patient. It is essential in the evaluation to systematically explore both symptoms of depression and anxiety, regardless of the initial complaint for which the patient seeks treatment. Common self-administered screening tools, such as the 9-question Patient Health Questionnaire, which is a diagnostic tool used to evaluate symptoms of depression, and the Generalized Anxiety Disorder 7-item questionnaire, are readily available and easy to use. When depressed mood or anhedonia is the presenting symptom, patients like Ms. P may have an accompanying primary anxiety disorder. Ms. P endorses anxiety symptoms that precede the onset of depression and meet the criteria for generalized anxiety disorder, GAD. In this case, it is important to make the distinction between these two conditions, because although the depressive episode may improve with treatment, GAD may persist, and this condition will require additional tailored management. Treatment. A proper diagnosis and the recognition of both anxiety and depressive symptoms is essential. It is important to note that even with treatment, the presence of anxiety and depression can lead to worse outcomes and are a challenge due to high rates of treatment resistance. However, providing individualized treatment for both conditions can be efficacious and lead to better outcomes. The primary goal of treatment is to reduce the depressive and anxious symptoms using a multimodal approach that includes pharmacotherapy and psychotherapy. It is important to educate the patient, family, and/or care provider about the nature of their symptoms and the benefits of treatment to reduce distress and improve quality of life. Antidepressants are the first-line treatment to treat both depression and anxiety. The selective serotonin reuptake inhibitors, SSRIs, and serotonin norepinephrine reuptake inhibitors, SNRIs, are the most recommended due to their tolerability and side effect profile. Because of anxiety symptoms, it is essential that SSRIs and SNRIs are started at a low dose, and that the patient be educated that in the initial phase of treatment, these medications may increase anxiety prior to observing symptom improvement. This may be a real challenge to the patient, as the antidepressant must be slowly but consistently increased to a therapeutic dose until symptom remission is achieved. Sedative hypnotics, such as benzodiazepines in the short term, can assist with immediate relief of acute symptoms, such as anxiety and insomnia. The clinician should be aware that once these symptoms improve, the sedative hypnotic medication should be tapered down to discontinuation. The patient must be educated about this plan prior to initiation of treatment. In the elderly, these medications have been associated with cognitive impairment and increased risk of falls. Ultimately, a risk-benefit profile should be taken into account, and these medications should not be taken on a continuous basis for more than 3 months. In patients who have received an adequate trial with an SSRI or an SNRI at the maximum tolerated dose for a minimum of 6 weeks, symptom improvement should be observed. Unfortunately, patients with anxiety symptoms may have difficulty tolerating even the minimum effective dose to alleviate clinical depression. Switching antidepressants may be necessary to find the best tolerated pharmacotherapy for the patient. Partial response may require augmenting with an antidepressant from a different class, buspirone, or a low-dose atypical antipsychotic. In patients who have failed 2 or more adequate pharmacological trials, somatic therapies such as electroconvulsive therapy or transcranial magnetic stimulation may be warranted. Select psychotherapeutic modalities have been shown to be effective for the treatment of both anxiety and depressive disorders. Additionally, psychotherapy may be the preferred modality of treatment for some patients. For both conditions, cognitive behavioral therapy, CBT, can be useful in reducing symptoms. CBT provides multiple strategies such as education, coping skills training, decreasing maladaptive and distorted thoughts, and behavioral activation. Other therapy modalities such as interpersonal psychotherapy, IPT, focus on problem areas that lead to depression. Problem areas include grief, interpersonal disputes, role transition, and interpersonal deficits. This therapy focuses on addressing interpersonal relationships as the key factor in symptom evolution. It is important for the psychotherapist to focus on the more debilitating and clinically distressing condition. In the case of Ms. P, she clearly has significant depressive symptoms. However, it is her anxiety symptoms that have evolved into anticipatory anxiety, fear, and avoidant behavior that are most distressing and interfering with her day-to-day function. Psychotherapy for her should focus on cognitive restructuring, to decrease catastrophic thinking, relaxation techniques, and gradual exposure therapy to minimize avoidant behaviors. Overall, when depression and anxiety present together, the duration of treatment leading to symptom remission may be more prolonged than when treating either condition alone. Key points to remember. Anxiety and depression often co-occur, making diagnosis and treatment complex. Genetic factors, neurotic temperament, early trauma, and the presence of anxiety and depression contribute to the comorbidity, increasing the risk of severe symptoms and suicidal thoughts. Treatment should address both anxiety and depressive symptoms, utilizing antidepressants like SSRIs and SNRIs, as well as psychotherapeutic approaches such as CBT and IPT. Tailored treatment should focus on the most distressing condition, potentially prolonging the duration of therapy when managing comorbid depression and anxiety. 19. I really want help for my anxiety. It's taking over my life. But my drinking is not the problem. Lauren Celentano, MD, and Samir Sabag, MD. Ms. F. is a 56-year-old woman who presents with complaints of persistent worries. These worries are associated with short-lived episodes of anxiety characterized by palpitations, shortness of breath, and hot flashes. During the interview, the clinician noticed a scent of alcohol on Ms. F's breath. Ms. F's responses to questioning indicated potential issues with her drinking habits, as she admitted feeling the need to cut down on her drinking and being annoyed by her husband's criticisms about her alcohol consumption. She now reports drinking alcohol 2 to 3 times per week and half a bottle of hard liquor per occasion. Despite her alcohol use, she expresses her desire for treatment to address her anxiety, but does not recognize her drinking as a significant problem. What do I do now? The intersection of substance use with primary psychiatric conditions is a challenge to all clinicians. As learned from the case of Ms. F., this patient is quite possibly suffering from both. Alcohol use disorder, AUD, and anxiety disorders dominate psychiatric morbidity in the U.S. 90% of the population has been drinking at some point in their lifetime, with a 29% lifetime prevalence of AUD. The outlook for anxiety disorders is equally common, with up to 34% of the population suffering from an anxiety disorder throughout their lifetime, making it the most common psychiatric diagnosis in the U.S. It is important for the clinician to understand the features of both AUD and anxiety disorders. Features of AUD typically include heavy drinking, often associated with an inability to cut down, which can ultimately lead to physical, psychological, and functional impairment. Often, patients may underreport the amount and frequency of their alcohol use. Additionally, as in the case of Ms. F., patients may have limited insight into their lack of ability to control the amount of alcohol they consume, as well as the negative consequences of their drinking. Anxiety is manifested through a wide variety of emotional, physical, cognitive, and behavioral symptoms. When treating an individual who presents with anxiety symptoms, clinicians should have heightened awareness of social anxiety, generalized anxiety, and panic disorder, as these conditions commonly co-occur with AUD. For instance, individuals with generalized anxiety disorder, GAD, and comorbid substance use disorders constitute half the lifetime population of GAD. Individuals with social anxiety disorder showed higher alcohol dependence severity and more dependent symptoms compared to alcoholics without social phobia. Furthermore, patients with comorbid AUD and anxiety disorders experience more severe alcohol withdrawal symptoms. Additionally, this population is at a greater risk of relapse to active drinking following alcohol treatment. The interplay between anxiety disorders and AUD remains a debated topic, with evidence supporting both directions of causality. For example, consider the case of Ms. F., where it is unclear whether her anxiety disorder triggered increased substance use or if her alcohol consumption exacerbated her anxiety, Research has indicated that individuals diagnosed with anxiety disorders at the baseline assessment were 5 times more likely to develop alcohol dependence by year 7. This suggests that pre-existing anxiety could be a contributing factor to the onset of or progression to AUD. Conversely, these studies reveal that individuals diagnosed with AUD at the baseline assessment had a 4-fold increased risk for a new anxiety disorder within 7 years. This finding implies that excessive alcohol consumption might contribute to the development of an anxiety disorder. Thus, the relationship between anxiety and alcohol use is bidirectional and complex. Both conditions can exacerbate and perpetuate each other, making it difficult to determine a clear causal pathway. Due to this complexity, the presentation of co-occurring anxiety and AUD should be approached using a comprehensive analysis that uses a biological, psychological, and social model. An astute clinician must consider the evidence from various sources to identify and understand the complex comorbidity of anxiety and AUD. From a neurobiological standpoint, the high comorbidity between AUD and anxiety becomes apparent. Factors like trauma, chronic stress, and family history are associated with both conditions, making them relevant to the case of Ms. F. It is well established that chronic stress, as well as prolonged substance use, can lead to dysregulation of the neuroendocrine hypothalamic pituitary adrenal (HPA) axis. Moreover, the neuroadaptation secondary to both alcohol and chronic stress can affect the amygdala and the prefrontal cortex, worsening anxiogenic effects. Another explanation for the comorbidity between anxiety and AUDs is the tension reduction model. This model postulates that individuals use alcohol or other substances as a means of self-medicating to cope with distressing psychological symptoms, such as anxiety, as in the case of Ms. F. The tension reduction model suggests that individuals who repeatedly rely on alcohol to cope with anxiety are at a higher risk of developing AUDs over time. People engage in drinking to cope with negative emotions through 2 pathways: the direct and indirect syndromic pathways. The direct pathway involves using alcohol to cope with the acute symptoms of anxiety directly. For instance, when an individual experiences heightened anxiety in social situations, this may lead to increased drinking. In the indirect stress pathway, individuals turn to alcohol to numb themselves from overall negative emotions and stressors in their lives. For instance, someone dealing with chronic worry and anxiety may consume alcohol to escape from their constant feelings of unease and tension, as in the case of Ms. F. These pathways are believed to contribute to a faster transition from initial substance use to harmful use among individuals with anxiety disorders. Furthermore, it is hypothesized that drinking to cope eventually interferes with the normal adjustment to stressful stimuli, further exacerbating the negative impact of alcohol use in this population. Several studies reveal that individuals with anxiety who identify themselves as self-medicators or use drinking to cope, DTC, are 2.5 times more likely to develop a comorbid AUD. Individuals with anxiety disorders who do not resort to DTC are actually less likely to develop AUD compared to the general population. In fact, in most cases, they actively avoid alcohol as it increases their anxiety. DTC is common in individuals with co-occurring anxiety and AUDs. In clinical samples of individuals with comorbid AUD and anxiety, self-medication rates have been reported to range from 50% to 97%. Social phobia and GAD are the anxiety disorders for which patients are most likely to engage in DTC, at 14% respectively. Therefore, it is essential to target and address the needs of those individuals who identify themselves as self-medicators to effectively prevent and manage the development of comorbid AUDs, as in the case of Ms. F. An alternative explanation for the comorbidity between anxiety and AUD suggests that anxiety can largely arise because of heavy and prolonged alcohol consumption. Heavy alcohol consumption can give rise to a wide range of psychosocial issues, and anxiety may manifest in response to these challenges. The trajectory of AUD is marked by repeated intermittent episodes of excessive drinking and withdrawal, leading to changes in the nervous system that can either induce or worsen anxiety symptoms. Anxiety can also be a symptom of alcohol withdrawal. In the early phase of withdrawal, there is autonomic hyperreactivity that in turn may cause a host of symptoms, one of which is acute anxiety and potentially panic attacks. Clinicians must be aware that the anxiety associated with AUD can be due to protracted withdrawal and can last several weeks after cessation of alcohol consumption. For patients dealing with comorbid anxiety and AUD, an accurate evaluation, thorough assessment, and proper diagnosis are paramount. Distinguishing between an anxiety disorder and a substance-induced state is a crucial aspect of the psychiatric examination. In most cases, the co-occurring anxiety disorder is independent and not caused by substance use, as in the case of Ms. F. Diagnosing a primary anxiety disorder in the presence of AUD can be challenging for several reasons. Anxiety and substance use disorders often share similar symptoms, such as anxious mood, irritability, restlessness, increased heart rate, and difficulty concentrating. These overlapping symptoms can make it difficult to differentiate between the two conditions. When individuals with substance use disorder attempt to quit or reduce their substance intake, they may experience withdrawal symptoms, including anxiety. These withdrawal-related anxiety symptoms can be mistaken for a primary anxiety disorder. Substance use can temporarily alleviate anxiety symptoms, leading individuals to self-medicate. This masking effect may hinder the accurate identification of an underlying anxiety disorder. Differentiating between substance-induced anxiety and primary anxiety disorders poses a significant diagnostic challenge. To conduct a comprehensive evaluation, it is essential to establish a detailed retrospective timeline of the patient's symptoms, conduct interviews with collateral informants, such as family members or close friends, review the patient's medical records and any relevant laboratory data, and carefully observe the symptoms over an extended period of abstinence from substances. This thorough approach ensures a more accurate and precise diagnosis, enabling appropriate and effective treatment planning. In Ms. F's case, it would be important to involve her husband in the assessment process. This approach can be valuable, as Ms. F may not fully recognize the link between her anxiety and alcohol use, or she might be resistant to acknowledging the severity of her drinking habits. By obtaining information from her husband, the clinician can gain a more comprehensive understanding of her condition. The clinician should also inquire about the use of other substances, including illicit drugs, caffeine, nicotine, and over-the-counter medications. These substances have the potential to trigger anxiety symptoms, often resembling symptoms of panic disorder and drug withdrawal. In addition, clinical observation during a period of substance abstinence can help distinguish between substance-induced anxiety and primary anxiety disorders. The necessary duration of abstinence for precise diagnosis varies, depending on the specific substance involved. During the initial assessment, anxiety symptoms can be screened with a generalized anxiety disorder 7-item questionnaire. To confirm the specific anxiety disorder diagnosis, a more comprehensive evaluation with a standardized tool, like the anxiety disorder's interview schedule, can be used. For screening substance use disorders, the CAGE substance abuse screening tool can be employed, which includes questions about cutting down on drinking, feeling annoyed or guilty about drinking, and the presence of an eye-opener. Since Ms. F screened positive for the CAGE questionnaire, the clinician can proceed with the alcohol use disorders identification test, the most widely validated instrument that takes just a few minutes to complete. A score of 8 or more out of 40 is considered a positive screen, making it a valuable tool with sensitivity over 90% and specificity of 80%. To complete the assessment, several laboratory tests should be performed, both to rule out medical conditions and to reveal possible covert substance use. To exclude any medical causes of anxiety, one should obtain a complete blood count, a chemistry panel, and serum thyroid function tests. To evaluate for the extent of alcohol use, one might expect to see elevated gamma-glutamyltransferase, carbohydrate-deficient transferrin, mean corpuscular volume, aspirate aminotransferase, AST, and alanine aminotransferase, ALT. An AST to ALT ratio of 2:1 is suggestive of alcohol-induced liver disease. Pancytopenia and macrocytosis typically result from heavy and prolonged alcohol use. Although not commonly ordered, phosphatidylethanol is a specific biomarker for ethanol that can detect excessive alcohol intake within a 2-week time frame. Treatment. The current mainstay of treatment for co-occurring AUDs and anxiety disorders is to address both conditions concurrently. Addressing the AUD in isolation without simultaneously targeting the underlying anxiety-related disorder may increase the patient's vulnerability to relapse when encountering anxiety symptoms. On the other hand, focusing solely on treating the anxiety disorder without addressing and monitoring the AUD can result in ineffective or even detrimental treatment outcomes. In Ms. F's case, treating the anxiety alone poses a risk of the patient deciding to abruptly stop alcohol use, which could lead to seizures or delirium tremens. In addition, treating the anxiety symptoms alone without addressing the ongoing alcohol use will result in ineffective treatment. Pharmacological treatment for anxiety encompasses a wide variety of agents from different classes, such as serotonin reuptake inhibitors, SRIs, benzodiazepines, tricyclic antidepressants, the 5-HT1A partial agonist buspirone, and monoamine oxidase inhibitors. These medications have been extensively studied in well-controlled, randomized clinical trials, firmly establishing their efficacy for anxiety treatment. However, these trials often exclude individuals with AUDs. First-line therapy for anxiety disorders are SRIs due to their safety and tolerability. They are also preferred for patients with comorbid AUD, given their low risk of misuse and abuse. The use of benzodiazepines for treating anxiety-related disorders in patients with comorbid AUD is not recommended for several reasons. Benzodiazepines are known to carry a risk of abuse. Rapid-acting benzodiazepines, especially shorter-acting compounds like alprazolam that quickly cross the blood-brain barrier, have a higher potential for addiction. Patients with a history of AUD may be more susceptible to the rewarding properties of benzodiazepines, increasing the risk of misuse and dependence in this population. Additionally, benzodiazepines taken with alcohol have an addictive effect that is more likely to cause respiratory depression and increase the risk of fatal overdose. For AUDs, the treatment can be separated by phase and severity of the disease. Patients who are at risk for complications with sudden alcohol cessation and who have medical comorbidities require inpatient admission to a detoxification unit where the patient will be tapered from the alcohol safely. In the long term, abstinence will require outpatient or inpatient rehabilitation, depending on the severity of the alcohol use. The current Food and Drug Administration approved medications recommended for the treatment of AUD include naltrexone and acamprosate. Alcoholics Anonymous, AA, is a widely known support group that is shown to be a valuable as well as cost-effective measure at maintaining sobriety in select individuals with AUD. For individuals with comorbid anxiety disorders and AUD, however, a recommended approach is integrated cognitive behavioral therapy. This therapeutic modality emphasizes psychoeducation, coping skills training, behavior strategies, and relapse prevention techniques that may be more suitable than AA alone in these individuals with a dual diagnosis like Ms. F. In conclusion, individuals who are treated for only one of the two conditions are less likely to respond to treatment. They are also more likely to relapse. Conversely, individuals with AUD who receive treatment for anxiety are less likely to experience relapse. Importantly, when relapses do occur in individuals with both AUD and treated anxiety, they tend to drink less frequently and have fewer relapses compared to those whose anxiety is not addressed during treatment. Key points to remember. The co-occurrence of anxiety disorders and AUDs is a frequently encountered clinical scenario. Differentiating between substance-induced anxiety and primary anxiety disorders presents a significant diagnostic challenge. Therefore, a comprehensive evaluation is crucial to accurately discern the underlying cause of the anxiety symptoms. The recommended approach for treating co-occurring AUDs and anxiety disorders is to address both conditions simultaneously. 20. I'm really scared about the pending diagnosis. What if it's bad? Mario Velit, MD. Illuminita Luca, MD, PhD. Mr. A is a 58-year-old man with chronic obstructive pulmonary disease, COPD, coronary artery disease, CAD, and a recent myocardial infarction, who is now on home oxygen therapy. He is admitted to the inpatient unit due to worsening cough and shortness of breath. His dose of albuterol recently increased. Chest imaging demonstrates a small opacity in the left lobe. The news is causing Mr. A significant distress. He says he is expecting the worst. Mr. A worries about his pending diagnosis and has looming fears of cancer, causing frequent episodes of increased anxiety associated with palpitations and worsening shortness of breath. Sleep has become fragmented due to new worries that wake him up at night. Mr. A is afraid of loss of independence and what will happen to his wife and children if he dies. He says, "Doctor, I can't stop thinking, and I feel I am suffocating." You have been consulted to manage this patient's anxiety. What do I do now? Anxiety in the medically ill is common. It may represent an emotional reaction to an illness. Alternatively, a pre-existent anxiety condition, such as generalized anxiety disorder, GAD, or panic disorder, may be exacerbated by medical comorbidity. Furthermore, anxiety symptoms can be the direct expression of a known physiological condition, medical illness, or treatment regimen. For the clinician, distinguishing the cause is key to optimally managing the symptoms of anxiety. Reducing anxiety can result in overall benefits for the medical condition as well. Regardless of the etiology, anxiety in the medically ill is often triggered by uncertainty and the fear of the unknown. Novel or acute physical symptoms, as well as pending diagnostic results, commonly serve as events that can predict the onset or exacerbation of anxiety symptoms. Emotional symptoms may include apprehension, fear, and feelings of impending doom. Anxiety may also manifest as worry regarding illness, prognosis, and outcome. Physical symptoms such as diaphoresis, tachycardia, nausea, and dizziness can be difficult to differentiate from the manifestations of a medical illness. Overall, preoccupation with loss of functioning and independence, as well as existential matters including death and suffering, may be expressed. Anxiety symptoms can be present at different points during the course of a person's illness. Patients may worry about multiple issues related to their medical condition, including the uncertainty of their diagnosis and prognosis, the impact that an illness will have on their body, and fears that they will become dependent on others or that they will die. Mr. A expresses new anxiety symptoms and a looming fear of cancer. The uncertainty regarding his prognosis is a source of anxiety, and multiple worries about his medical condition are now interfering with his ability to sleep. it is important to further explore Mr. A's worries, as his clinician may provide reassurance and normalize these thoughts and feelings. Overall, symptoms of anxiety can be useful as a signal to take action and address unexplained symptoms. These symptoms do not usually meet the diagnostic criteria for an anxiety disorder. However, if the anxiety symptoms are persistent and severe, they can cause significant distress and impact daily activities. In fact, anxiety can interfere with the patient's medical care, as an individual may engage in avoidant behaviors and not pursue the recommended treatment. Patients with severe anxiety may refuse procedures or treatments and may even request to leave the hospital against medical advice. When evaluating a medically ill patient who presents with symptoms of anxiety, it is important to obtain a comprehensive medical and psychiatric history, including the physical examination, to distinguish medical versus psychiatric factors. Gathering collateral information from the family or the medical team provides clinicians with critical information that they may not otherwise be able to obtain from the patient's self-report. Finally, laboratory testing and imaging should also be reviewed to better elucidate the source of anxiety. In patients with medical illnesses who present with anxiety symptoms, it is important to assess whether the anxiety is due to a primary anxiety disorder. Some patients may have pre-existing anxiety that can be exacerbated during the course of a medical illness. For example, GAD is typically characterized by excessive worry for many months, along with a variety of somatic symptoms. Other patients may endorse paroxysmal anxiety or acute panic, with a sensation of imminent death, consistent with panic attacks. Differentiating pre-existing GAD from new-onset anxiety in the course of a medical condition is not trivial. Individuals with GAD typically have chronic symptoms that precede the onset of the medical condition. In patients who are medically ill, panic symptoms may be precipitated by fear of diagnosis, symptom burden, treatment regimen, prognosis, or existential concerns. It is not unusual for a newly diagnosed panic disorder to develop during the course of a newly diagnosed medical condition. Certain diagnoses, such as cancer, can be experienced as traumatic events. Increased anxiety and fear of recurrence can arise, as can avoidance and hypervigilance, leading to a post-traumatic stress disorder diagnosis. Phobic avoidance of specific medical devices and procedures can also occur in medically ill patients. Therefore, all medically ill patients should be screened for anxiety and depression. Certain medical illnesses manifest with anxiety symptoms. Anxiety due to a medical condition may vary in frequency depending on the etiology, but can be anywhere from 10% up to 40%, making the condition a regular cause for psychiatric consult in the medical setting. Anxiety due to a medical condition is diagnosed when a medical condition is the direct pathophysiological consequence of the anxiety symptoms. Medications are also known to directly induce anxiety symptoms. Beta-adrenergic drugs such as albuterol are commonly used to help dilate the airways and facilitate breathing, but can increase heart rate, induce nausea, and increase nervousness. Inhaled corticosteroids and other medications used in COPD, such as theophylline, are anxiogenic and can cause agitation and restlessness. In the case of Mr. A, the worsening anxiety and palpitations could also be attributed to an increased dose of albuterol. Becoming aware of the medications that may exacerbate anxiety in the medical setting can be useful to understand unexplained palpitations or increasing irritability in patients. Respiratory conditions typically present with shortness of breath, which was observed and linked to panic and anxiety disorder. The prevalence of anxiety disorders in COPD, for example, was found to be much higher than in the common population. COPD typically presents with productive cough and shortness of breath due to long-standing inflammation of the airways, leading to obstructed airflow. With severe COPD symptoms, individuals may become physically impaired and thus more dependent on caregivers, reduce their activities of daily living, become hopeless, and experience a decrease in the quality of life. In the case of our patient, Difficulty breathing due to COPD exacerbation manifests as anxiety and induces debilitating fears and excessive worries that interfere with sleep. While vital signs and shortness of breath can be controlled by medical therapy, the unexplained restlessness, apprehension, and sleeping difficulties may require a different approach. Treating anxiety may have the added benefit of improving the respiratory outcome through increasing adherence to complex medication regimens, participation in pulmonary rehabilitation, or even home oxygen compliance. Many other respiratory conditions present with symptoms experienced as acute anxiety. Asthma can cause episodes of wheezing, chest tightness, and shortness of breath. Pneumonia, a bacterial or viral inflammation of the lungs, causes cough, fatigue, shortness of breath, and chest pain, and may even require oxygen therapy. Pulmonary embolism manifests with tachycardia, palpitations, and/or acute shortness of breath. Patients complain of paroxysmal anxiety that resembles a panic attack. Addressing the underlying respiratory problem helps relieve anxiety symptoms in acute conditions. However, in chronic conditions, patients may benefit from specific interventions targeting anxiety. Heart disease, including heart failure, HF, and CAD, can increase the anxiety burden on individual patients. Patients with HF have higher rates of anxiety compared to the general population. Similarly, anxiety has been associated with deteriorating heart health and increased mortality in CAD. Anxiety disorders are linked to smoking, physical inactivity, and increased alcohol consumption, which can worsen cardiac outcomes. Therefore, addressing comorbid anxiety may have the benefit of increasing adherence to healthy behaviors, including physical activity and smoking cessation. Many of the symptoms of heart disease, including shortness of breath, syncope, chest pain, and palpitations, may overlap with anxiety or panic attacks. Differentiating between cardiac conditions and anxiety due to a medical condition can be challenging. Palpitations, or rapid heartbeats, can have many causes, but when associated with syncope, it is more likely to be due to a cardiac condition. Exacerbation of anxiety may also increase the heart rate. Chest pain due to decreased blood flow to the heart can present with sweating, weakness, and shortness of breath. Isolated shortness of breath due to hyperventilation and anxiety is usually indifferent of the individual's physical position. Lying down may exacerbate shortness of breath and congestive HF. When in doubt, a proper cardiac evaluation may help elucidate the cause if the suspicion is high for cardiac disease. Mr. A, who has a history of CAD, complains of palpitations. Once an acute cardiac event is ruled out, controlling the anxiety is important for a better outcome of his cardiac condition. Table 20.1. Medical conditions that cause anxiety. Systems, respiratory, disorders, chronic obstructive pulmonary disease, asthma, pneumonia, pneumothorax, pulmonary embolism. Systems, endocrine, disorders, hyper or hypothyroidism, hypoglycemia, hypercortisolism. Systems, cardiovascular, disorders, coronary artery disease, heart failure, arrhythmia, pulmonary embolism. Systems, neurological, disorders, seizure disorder, brain tumors, vertigo. Systems, gastrointestinal, disorders, irritable bowel syndrome, constipation, acute abdominal obstruction, peptic ulcer, gastroesophageal reflux disease. Systems, drug-related, disorders, anticholinergics, bronchodilators, antihypertensives, nicotine abuse, other substance abuse or withdrawal. Systems, other, disorders, cancer, vitamin B12 deficiency, porphyria, anemia. Treatment. For acute and highly intense anxiety or panic attacks, a short course of benzodiazepines can be useful, taking into consideration that elderly patients and patients with a history of substance abuse require caution. Benzodiazepines have limited utility in patients with respiratory disease due to their effect on decreasing respiratory drive. Patients with severe COPD, asthma, and obstructive sleep apnea are particularly at risk. Pharmacological treatment of anxiety disorders typically involves a selective serotonin reuptake inhibitor or a serotonin norepinephrine reuptake inhibitor. Short-term psychotherapy interventions for medically ill patients offer a time-limited approach to addressing the psychological and emotional challenges associated with a medical condition. These interventions aim to provide support, coping strategies, and symptom management within a relatively brief time frame, often due to the acute nature of the medical issue or the need to address immediate psychological distress. Such interventions include supportive therapy and cognitive behavioral therapy, CBT. Supportive therapy includes actively listening to the patient's concerns and normalizing concerns. By offering reassurance, explaining principles of treatment, and offering choices, healthcare providers may help alleviate the patient's worries. Mr. A expressed concern that he might have cancer. Although a full workup is warranted, the therapeutic approach would involve reassurance and engaging him in treatment decisions. CBT helps identify and correct the negative thoughts and false misperceptions about medical illness that cause distress and may interfere with treatment. Key points to remember. A comprehensive evaluation is necessary to distinguish between a pre-existent anxiety disorder and anxiety directly due to a medical condition. Many common respiratory, cardiovascular, and other medical conditions are associated with anxiety. Managing anxiety in the medically ill can improve the patient's ability to cope effectively with their condition. Short-term psychotherapeutic interventions for medically ill patients provide a time-limited strategy to address the psychological challenges related to their medical condition. 21. I find myself constantly worrying, and it's been keeping me up at night. Jafar A. Ashi, MD, and Caroline Cruz Ortiz, MD. Mr. P is a 30-year-old man who has been experiencing increasing levels of anxiety over the past several months and presents for a visit to his primary care physician. He finds himself constantly worrying about his work performance, his finances, his personal relationships, and everyday chores. As a result, he often feels tense, irritable, and overwhelmed with worrisome thoughts. Mr. P has also been experiencing sleeping difficulties. He struggles to fall asleep, and he lies awake worrying about multiple issues. Even after falling asleep, he experiences multiple awakenings and has difficulty falling back asleep. In the morning, he does not feel rested, and the lack of sleep has affected his ability to concentrate at work, and he is tired throughout the day. He does not report symptoms of depression. He reports that he wakes up in a fog and must drink 4 to 6 cups of coffee per day to be able to focus and be functional. He asks for help to sleep better, but he is ambivalent about taking medications. What do I do now? Insomnia is one of the most common conditions that is seen by primary care providers. It can be due to multiple etiologies and can be associated with other underlying comorbidities that need to be identified to properly diagnose and thereafter treat. Insomnia is a sleep disorder in which the patient experiences a predominant dissatisfaction with sleep quantity or quality. Insomnia can occur from difficulty initiating sleep, maintaining sleep, or early morning awakening with inability to return back to sleep. It must occur at least 3 nights per week and results in significant distress or impairment in social, occupational, educational, academic, and behavioral functioning. Insomnia can be episodic, acute, persistent, chronic, or recurrent. Acute insomnia lasts at least 1 month, but less than 3 months. Chronic insomnia lasts 3 months or longer, and recurrent insomnia is having 2 or more episodes within the space of 1 year. There are 2 types of insomnia: primary and secondary. Primary insomnia is insomnia that is not explained by currently known psychiatric disorders, medical conditions, or substance use disorders. Secondary insomnia is insomnia that arises from a primary mental health disorder, such as anxiety disorders, major depressive disorder, or post-traumatic stress disorder. Other medical conditions, such as asthma, gastroesophageal reflux disease, hyperthyroidism, or arthritis. Medications, such as certain medications used to treat asthma, chronic obstructive pulmonary disease, or antihypertensives. Substance use, such as caffeine, nicotine, or alcohol, or other sleep-related disorders, such as restless leg syndrome or sleep apnea. Anxiety is one of the leading risk factors for secondary insomnia. Therefore, screening for anxiety is essential in evaluating sleeping difficulties. Several studies have shown that patients with generalized anxiety disorder, GAD, even without depression, have significantly greater sleep disturbances than people without anxiety. Anxiety is a symptom that can be manifested in different psychiatric conditions that can all lead to insomnia. Treating the comorbid anxiety disorder and insomnia will result in a better response to the outcome of both conditions. The most common anxiety disorders that are associated with insomnia are panic disorder, GAD, post-traumatic stress disorder, and obsessive-compulsive disorder. Sleep and anxiety are interconnected. Anxiety can significantly impact an individual's sleep patterns. Excessive worry and ruminative thoughts that are typical of anxiety disorders can make it difficult to relax and fall asleep. Individuals who are anxious may also experience nighttime awakenings and restless sleep. These disruptions make it difficult for an individual to feel rested in the morning, and the lack of sleep can lead to concentration difficulties and poor energy, as in the case of Mr. P. Conversely, sleeping difficulties can be associated with increased anxiety levels. Having an anxiety disorder may perpetuate a cycle in which anxiety causes sleeping difficulties, and the lack of sleep exacerbates the anxiety symptoms. Other factors that can contribute to insomnia are stress and everyday concerns about work, school, finances, and family members, as in the case of Mr. P. Additionally, traveling and work schedules that need frequent changing in working hours and working night shifts can contribute to insomnia. Poor sleep hygiene, such as daytime naps, engaging in stimulating activities before bed, using screen devices such as smartphones before bed, and late-night heavy meals, all can negatively impact sleep as well. To evaluate the underlying causes of insomnia, we must start with a clinical interview, making sure to obtain a thorough sleep history and detailed medical, substance, and psychiatric history. Insomnia is diagnosed through a clinical assessment that relies on the patient's self-report and history. Diagnostic tests, such as a sleep study, are generally not recommended when initially assessing insomnia, but can be useful in diagnosing specific sleep disorders, such as obstructive sleep apnea. It is the clinical evaluation through history and examination that is most essential. The evaluation should encompass several aspects, such as the specific nature of the sleeping difficulties, the individual's sleep schedule, the individual's sleep hygiene practices, and the duration over which the problem has persisted. Providing detailed and accurate answers might be challenging for some people. It may be difficult for a patient to remember all events at night, given the fact that sleep habits and patterns are variable from night to night. Therefore, a sleep diary, also called a sleep log or journal, is a valuable tool for tracking sleep, monitoring sleep habits, and documenting sleeping problems. The typical sleep diary includes questions about nightly bedtime, wake-up time, how long it takes to fall asleep, the number and duration of sleep interruptions, the number and duration of daytime naps, perceived sleep quality, consumption of alcohol, caffeine and/or tobacco, daily medications, and exercise. A sleep diary is a subjective assessment of sleep that can provide useful information for the patient and the provider. Collecting this information will guide the provider to the correct diagnosis and will help facilitate the clinical interview. Table 21.1 is an example of a sleep diary. There are useful self-report measurements that can be used to arrive at a diagnosis and develop a case formulation. The most common self-report system questionnaires are the Insomnia Severity Index, ISI, and Pittsburgh Sleep Quality Index, PSQI, and the Sleep Hygiene Index, SHI. The ISI is a 7-item questionnaire assessing the nature, severity, and impact of insomnia, and studies have shown strong evidence that the ISI is a reliable and valid instrument to detect cases of insomnia in the population and is sensitive to treatment repose in clinical settings. The PSQI is a 19-item questionnaire evaluating sleep quality and disturbance retrospectively over the past month. Unlike the ISI, which is insomnia-specific, the PSQI is a more global measure of sleep disturbance across sleep disorders, and it can be used to detect patients who are likely to have a sleep disturbance concomitant with their psychiatric symptoms. The SHI is a 13-item questionnaire that is used to measure for the presence of sleep-disruptive behaviors, such as taking daytime naps, exercising within 1 hour of going to bed, and doing important work before bedtime. As mentioned previously, identifying and screening for caffeine consumption, substance use, lifestyle, and sleep habits is important to identify all the factors that contribute to insomnia. In addition, it is also important to consider other medical conditions that can cause sleep disorders and request the proper lab workup to rule them out. When evaluating insomnia in the context of anxiety, it is important to recognize the intricate relationship between these conditions and to consider how they might influence each other. It is important to assess for the presence and severity of anxiety symptoms, such as excessive worry, restlessness, muscle tension, and difficulty concentrating. It is also useful to ask about the sequence of onset for both insomnia and anxiety. Understanding which condition emerged first can shed light on potential underlying causes and offer insights into the chronological progression of these conditions. There are a variety of tools available to assess for anxiety, including self-report questionnaires, such as the Generalized Anxiety Disorder 7-item questionnaire, Beck Anxiety Inventory, and Anxiety Sensitivity Index. Table 21.1. Example of a sleep diary. Day of the week, Monday. Date, 4/21/12. Morning. What time did I get into bed? 10:20 p.m. What medications did I take? Melatonin, 5 milligrams. What time did I attempt to fall asleep? 10:30 p.m. How long did it take me to fall asleep? 40 minutes. What time did I wake up? 6:15 a.m. How many times was my sleep interrupted? 2 times. What is the rate of my sleep quality? 7 out of 10. Evening. Did I take a nap? If yes, how long? No. Did I drink coffee? If yes, how many and when? Yes, 2 cups, 8 a.m. and 11 a.m. Did I drink alcohol? If yes, how many and when? No. Did I exercise? No. Treatment. Treatment considerations include lifestyle modifications and pharmacological and non-pharmacological interventions. Lifestyle modifications. Sleep hygiene refers to a set of behaviors, environmental conditions, and other sleep-related factors that can be modified as a monotherapy or component of multimodal treatment for patients with insomnia. Sleep hygiene education, SHE, is widely used as a treatment of insomnia in general practice, and it involves educating the patient about reducing or eliminating caffeine and alcohol consumption, avoiding exercise and large fatty meals prior to bed, establishing nighttime routines, and ensuring a dark and quiet bedroom. SHE results in improvement in quality of sleep, and it is an initial intervention that can be used while identifying and treating other causes or using other techniques, such as cognitive behavioral therapy for insomnia, CBTI, that are more effective. Table 21.2 lists the sleep hygiene recommendations from the American Academy of Sleep Medicine. Table 21.2 Sleep Hygiene Tips, American Academy of Sleep Medicine. Keep a consistent sleep schedule. Get up at the same time every day, even on weekends and during vacations. Set a bedtime that is early enough for you to get at least 7 to 8 hours of sleep. Don't go to bed unless you are sleepy. If you don't fall asleep after 20 minutes, get out of bed. Go do a quiet activity without a lot of light exposure. It is especially important to not get on electronics. Establish a relaxing bedtime routine. Use your bed only for sleep and sex. Make your bedroom quiet and relaxing. Keep the room at a comfortable, cool temperature. Limit exposure to bright light in the evenings. Turn off electronic devices at least 30 minutes before bedtime. Don't eat a large meal before bedtime. If you are hungry at night, eat a light, healthy snack. Exercise regularly and maintain a healthy diet. Avoid consuming caffeine in the afternoon or evening. Avoid consuming alcohol before bedtime. Reduce your fluid intake before bedtime. Psychological and behavioral therapies. CBTI is a structured, evidence-based approach that can help to identify and replace thoughts and behaviors that cause or worsen sleep issues, which will lead to falling asleep faster and maintaining sleep. CBTI often takes from 6 to 8 sessions. Nevertheless, providing an abbreviated CBTI by the trained primary care provider in as little as 2 sessions is also effective for reducing subjective sleep disturbance and insomnia symptoms. CBTI is a multi-component treatment that involves various approaches and techniques, including relaxation therapy, involves reducing stress by biofeedback, mindfulness, meditation, hypnosis, and breathing exercises. Stimulus control therapy helps the patient to reassociate both the bed or bedroom and bedtime with sleep alone. Sleep restriction therapy. People with insomnia often stay awake in bed trying to sleep, which leads to poor sleep. Sleep restriction therapy helps to reestablish a consistent sleep schedule by restricting the time spent in bed and causing partial sleep deprivation, which will eventually increase the drive to sleep. According to the guidelines of the American College of Physicians, CBTI is the first-line treatment for patients with chronic insomnia. CBTI is more effective than medications. However, CBTI has moderate impact in patients who have insomnia with or without a comorbid anxiety disorder. Therefore, treatment of the anxiety condition should be initiated, as in the case of Mr. P. Pharmacological treatment. It is important to prioritize non-pharmacological treatments for insomnia as the initial approach. If a medication is prescribed, it is recommended to use it for a limited duration, typically less than 3 months. With pharmacological interventions, it is critical to discuss and understand the benefits, harms, and costs of short-term use of medications. Moreover, we need to identify if the insomnia is mainly sleep-onset insomnia, difficulty initiating sleep, or sleep maintenance insomnia, to decide the pharmacological treatment to add. Benzodiazepines are gamma-aminobutyric acid, GABA, agonists. GABA is an inhibitory neurotransmitter in the central nervous system that decreases neuronal excitability. Benzodiazepines enhance the normal inhibitory action of GABA at the GABA-A receptor complex, which promotes sedation, decreases anxiety, and causes muscle relaxation and retrograde amnesia. There are only 5 benzodiazepines approved by the U.S. Food and Drug Administration, FDA, for insomnia, which are astaxanthin, flurazepam, clozapam, temazepam, and triazolam. Practically speaking, of this list, only temazepam is now commonly used. Benzodiazepines improve short-term sleep outcomes, but they have the potential for dependency and misuse. Non-benzodiazepine hypnotics are a class of medications that are also called Z-drugs and include zaloplan, zolpidem, and esopiclone. Like benzodiazepines, the Z-drugs are also GABA agonists, and they bind to the GABA A receptor. However, differing from benzodiazepines, the Z-drugs bind more preferentially to certain subunits of the GABA A receptors, mainly targeting the sedative effect of the receptor rather than the anxiolytic effect. These medications also have the potential for misuse. Melatonin agonists. Melatonin is a hormone that is rhythmically secreted by the pineal gland and involved in regulation of circadian rhythm. It peaks at night and is suppressed by light. Disruption of the timing of melatonin release or decreased melatonin production can cause insomnia when changing time zones or doing shift work. Ramelteon is a melatonin agonist approved by the FDA for sleep-onset insomnia. Antihistamines. Diphenhydramine and doxylamine are over-the-counter agents that are FDA approved as sleep aids. They are also considered to be a safer treatment for insomnia in pregnant women, as they are generally safe and may be effective for nausea as well as insomnia. Hydroxyzine is another antihistamine with sedative effect, but has insufficient evidence for its use in the treatment of insomnia. Antidepressants. Some antidepressants, such as trazodone, have sedative effects and have been used widely in the treatment of insomnia. However, the tricyclic antidepressant doxepin is the only FDA-approved antidepressant for insomnia. The mechanism of action is not known, but is likely related to antagonism of the histamine H1 receptor. Trazodone has not been established as an effective medication for treating insomnia based on clinical studies, and is not recommended as a first-line treatment option. In the case of Mr. P, his insomnia needs to be addressed by identifying the anxiety disorder and then targeting the specific anxiety disorder accordingly. Generally, selective serotonin reuptake inhibitors, SSRIs, and serotonin norepinephrine reuptake inhibitors, SNRIs, are first-line treatments for most of anxiety disorders. It is important to note that both SSRIs and SNRIs can have negative effects on sleep and wakefulness. These medications may induce either insomnia or daytime sedation. Thus, in the early stage of treatment of the anxiety disorder with an SSRI or SNRI, it can be expected that the patient might report insomnia and/or oversedation in the daytime, and it should be considered that these symptoms are possibly related to the medication. It is also important to consider incorporating anxiety management techniques, such as relaxation exercises, mindfulness, and cognitive behavioral therapy for anxiety. By targeting anxiety symptoms, individuals can reduce the physiological arousal that contributes to insomnia. In summary, insomnia is often multifactorial. Therefore, combining both pharmacological and non-pharmacological treatments has shown better outcomes for quality and quantity of sleep. Key points to remember. Insomnia can be episodic, persistent, or recurrent, and it can be primary or secondary insomnia. Identifying underlying causes of insomnia is critical for the evaluation and management of insomnia. An anxiety disorder can create a cycle where anxiety disrupts sleep, and the resulting lack of sleep intensifies anxiety symptoms. Treatment of insomnia includes lifestyle modifications, psychological and behavioral therapies, and pharmacological treatment. 22. Mommy, my tummy aches. I can't go to school today. Lauren Celentano, MD, and Stephanie Friedman, MD. J, a 10-year-old girl with downcast eyes, fidgeting hands, and barely audible voice, is brought by her mother. Her mother expresses concern for new onset abdominal discomfort and more frequent asthma exacerbations, resulting in missed days of school over the past month. Prior to 1 month ago, when the child's class started preparing to take the state achievement examinations, she had been a self-motivated student. Now her mother nags her to complete chores and homework, provoking angry retorts and refusal to complete the tasks, resulting in a downturn of her previously stellar academic performance. When confronted, Jay tells her mother she is simply not smart enough to keep up with the school demands. Her mother proclaimed, "I wish she spent half as much time doing her homework as she does asking me for reassurance about her friends and grades." What do I do now? As we learned from the case of Jay, childhood anxiety rears its head in all manners, providing a challenge for both parents and clinicians alike. In its purest form, anxiety is characterized as excessive, uncontrollable worries regarding numerous everyday situations or activities. Teasing out which of the worries are pathological and which can be attributed to the growing pains of maturity and emotional development takes an astute clinician. Typical symptoms include physical tension, apprehensive expectations, negative self-image, need for reassurance, irritability, and physical complaints or somatization. Impressively, 75% of children with anxiety report all the aforementioned symptoms, and presentation does not statistically differ between age or gender. As such, when presented with this constellation of complaints, one should strongly consider the diagnosis of anxiety. Moreover, the course of anxiety tends to come in a waxing and waning fashion rather than one of increasing intensity over time. For instance, although Jay was brought in for seemingly vague symptoms, to the well-practiced clinician, a diagnosis of anxiety can be made swiftly, sparing both the child and caregiver a lengthy road to treatment and relief. Somatization commonly occurs in anxiety. As such, it is paramount when presented with frequent nonspecific complaints, such as abdominal pain, to consider the timing of the complaint. Once medical conditions are excluded, one must consider the diagnosis of anxiety with further screening and evaluation. It is important to take a step back and observe the entire environment of the child. When presented with an anxious parent or a child subjected to a household of unrealistic expectations, it is prudent to screen for anxiety in the child. Likewise, it does not necessarily have to be one overpoweringly negative event that can induce anxiety, as seen in post-traumatic stress disorder, PTSD. Rather, a child being subjected to repeated small stressors at home can more often lead to clinical anxiety. Having a developmentally sensitive approach to assessing anxiety can be the key in proper diagnosis and differentiation of commonly comorbid conditions. A thorough assessment should include common symptom combinations, frequency, severity, onset, duration, degree of social distress, functional impairment, developmental deviations, and physical signs. All these aspects will help to differentiate from other similar conditions, as well as to determine the severity of anxiety, which will affect treatment decisions. An additional challenge in the pediatric population, or advantage depending on the scenario, is the multi-dimensional source of information potentially available to understand the world of the anxious child. Of course, this depends on the age and developmental stage of the child or adolescent. Nonetheless, one should consider information given by not only the primary informant, child, and their caregiver, but also their teachers. Teachers have a plethora of information, as well as the privilege of seeing a child interact with their peers. A teacher's insight into the child's current mental status is invaluable for diagnosis, and when the time comes, monitoring of symptoms and treatment. On the initial interview and evaluation, the clinician must always document baseline symptoms with a standardized assessment. Assessment tools can also be used to track progress and determine the efficacy of treatments. It is also useful to send pre-appointment questionnaires to caregivers, teachers, and the child if appropriate, to gather all information. The current American Psychiatric Association recommendation is to use the Anxiety Disorders Interview Schedule to provide a framework for a thorough interview. The Mental Status Examination, MSE, of the anxious child is likely to contain features such as poor eye contact, increased psychomotor activity, perseverative or ruminative thought processes, and worry and fear-laden thought content. Unfortunately, these MSE features are prominent in many of the comorbid psychiatric conditions, and as such may have limited usefulness for a more finite diagnosis. In terms of the biopsychosocial model, childhood anxiety can be assessed by biological predisposition, including family history of anxiety, psychologically by attachment theory, and principally insecure attachment styles, and socially by a child subjected to peer rejection, anxiogenic parenting behaviors, and lack of social support. Anxiety is commonly comorbid with other conditions. As such, it is important to establish a robust differential diagnosis, as well as a complete assessment, to avoid an incorrect diagnosis. As a reminder, common symptoms of anxiety include muscle tension, poor concentration, insomnia, irritability, fatigue, and somatic complaints. Major depressive disorder, MDD, is comorbid in up to 40% of children with anxiety. Features of MDD include insomnia, distractibility, and somatic complaints, as seen in J. However, J does not report persistent sadness, inability to experience joy, or feelings of excessive guilt or hopelessness. Obsessive-compulsive disorder is associated with intrusive thoughts, repetitive behaviors, and reassurance seeking. Attention deficit hyperactivity disorder is associated with distractibility and restlessness that respond well to treatment with stimulants. To differentiate between oppositional defiant disorder, it would be prudent to understand if the child only is defiant when faced with anxiety-provoking questions. A child who presents with more prominent social withdrawal and social skills deficits should be considered for autism spectrum disorder, or if school performance is the primary concern, learning deficits should be assessed. Eating-related disorders come into play when the child displays cognitive rigidity, social withdrawal, and/or anxiety around food and weight gain. Finally, substance abuse disorders in children and adolescents can be either comorbid or as a result of the individual's attempt to self-medicate. Specifically, if alcohol use is on the differential, consider that withdrawal from alcohol also leads to increased anxiety. Either physical symptoms can be secondary to anxiety, or anxiety can be secondary to a physical condition. A good history, along with collateral information and timeline, can determine which of the two is more likely. Medical conditions associated with anxiety may include hyperthyroidism, migraine, asthma, diabetes, lead intoxication, hypoglycemia, hypoxia, central nervous system disorders, cardiac arrhythmia, dysmenorrhea, and others. In the case of J, it is likely that her physical symptoms are secondary to anxiety. Her symptoms began after the provoking feature of standardized tests, and her physical examination was normal. Finally, medication-induced anxiety should be part of the differential. Common culprits include bronchodilators, nasal decongestants, sympathomimetics, antihistamines, steroids, dietary supplements, antidepressants, antipsychotics, and withdrawal from benzodiazepines. Once again, in the case of J, one needs to consider increased bronchodilator use as possibly contributing to her anxiety. Treatment. The pillars of treatment for anxiety are cognitive behavioral therapy, CBT, as well as treatment with a serotonin reuptake inhibitor. In 2020, the American Academy of Child and Adolescent Psychiatry, ACAP, released evidence-based guidelines for best treatment choice for children and adolescents with anxiety from ages 6 to 18. The ACAP recommends that CBT be offered to patients 6 to 18 years old for the treatment of anxiety. Compared to controls, CBT improves primary anxiety symptoms, global function, and overall response to treatment. The goal of CBT is to achieve meaningful symptomatic and functional improvement within 12 to 20 sessions. CBT targets cognitive, behavioral, and physiologic responses that lead to an anxiogenic reaction in the patient. Cognitively, CBT is aimed at addressing cognitive distortions of harm, as well as teaching the patient how to self-monitor for connections between worries and fears. Behaviorally, it addresses the patient's avoidance of potentially harmful situations and can utilize techniques such as gradual exposure or live modeling to improve behavioral response to benign situations. As such, through these cognitive and behavioral modifications, the physiologic response found in clinical anxiety is quelled with reduction in autonomic arousal. Additionally, the ACAP recommends that selective serotonin reuptake inhibitors, SSRIs, be offered to patients 6 to 18 years old for the treatment of anxiety. Treatment with SSRIs typically results in statistically significant effects within 2 weeks, clinically significant effects within 6 weeks, and a maximum improvement seen in 12 weeks. In the dosing of SSRIs, as with most psychiatric medications, the tried-and-true mantra applies: start low and go slow. This is not only to limit the potential side effects, but also to find a minimally effective dose in patients. A common side effect of SSRIs is activation, which can be counteracted by dosing in the morning. Remarkably, despite earlier reports, the most recent evidence illustrates that SSRIs do not increase rates of abdominal pain, nausea, or vomiting compared to placebo, likely attributed to the high rate of gastrointestinal symptoms found in untreated anxiety. And even more critically, SSRIs were found not to increase treatment-emergent suicidality compared to placebo in children. It is the current recommendation to continue treatment for 12 months after remission of symptoms, and to decrease slowly to avoid any symptoms of discontinuation, which include but are not limited to dizziness and fatigue. Serotonin norepinephrine reuptake inhibitors, SNRIs, can also be utilized in the treatment of anxiety, with duloxetine being the only current SNRI that is approved by the Food and Drug Administration for anxiety in children. Nevertheless, there are significantly fewer studies on the effectiveness of SNRIs, and they have been shown to increase fatigue when compared to placebo. The ACAP recommends that a combination treatment of CBT and an SSRI should be offered preferentially over CBT or an SSRI alone to patients 6 to 18 years old for the treatment of anxiety, compared to CBT alone and to the SSRI sertraline alone. Combination of both treatments improved primary anxiety, global function, response to treatment, and overall remission of anxiety disorders. The combination of treatment is often suggested when symptoms are acute or very severe, as more monitoring can be achieved. Moreover, the strongest predictor of long-term outcome is the initial response to treatment, which is much higher in combined treatment groups than either CBT or SSRI alone. Thus, for Jay, if her symptoms of anxiety persist, the combination treatment of CBT plus SSRI is recommended. When treating children and adolescents, it is important to incorporate all parties invested in the outcome. This includes not only the patient, but also their primary caregivers and teachers. Without proper caregiver education, the clinician risks increased parental frustration, unrealistic expectations, and possibly an increase in the anxiogenic environment for the child. Likewise, the clinician should include the cultures and values of the family to increase adherence to treatment. In terms of overall environment, it is important to provide psychoeducation to the parents, as well as advise them to increase the structure of the child's environment, as this has been shown to reduce anxiety. If substance use is involved, Abstinence should be the end goal. Strategies include motivational interviewing, as well as education for both the child and the caregiver. Withdrawal from substances such as alcohol or benzodiazepines can increase anxiety, as many individuals may wrongly misuse these substances with the belief that they will decrease their anxiety. It is not recommended to treat anxiety in children and adolescents with benzodiazepines, especially in those potentially with comorbid substance use. In children, anxiety may result in an increased risk of suicidality, with 9% of untreated patients reporting suicidal ideations and 6% with suicide attempts. Thus, it is essential to include suicide risk assessment as a fundamental component of evaluating children who are experiencing anxiety. When educating patients and families about treatment, the prognosis with and without treatment should be highlighted. Without treatment, children with anxiety are at an increased risk to develop anxiety disorders as adults and have been shown to have lower school performance. Key points to remember. Anxiety in children typically presents with irritability, physical complaints, apprehension, negative self-image, and a need for reassurance. When working with children and adolescents, information from primary guardians and teachers should always be included in the evaluation. Suicide risk should always be assessed, as children with anxiety have an increased risk of suicidal thoughts and attempts. A combination treatment of CBT and an SSRI should be offered preferentially over CBT or an SSRI alone to patients 6 to 18 years old. 23. Why can't I stay home like during online school? Lawrence Gross, MD, and Raoul Paulson, MD. A mother brings her 9-year-old son, GP, to the clinic on account of frequent, explosive, and angry outbursts occurring over several months. GP was well behaved, engaged well with friends, and attended online school activities regularly during the COVID pandemic. Since starting in-person schooling and his extracurricular jiu-jitsu class, he now throws tantrums and appears distressed when preparing for these activities and prior to leaving home. After arriving at school, he requests to call his mother to check on her and expresses fear that she may contract COVID. GP often complains of abdominal discomfort, but on evaluation with his pediatrician, no laboratory or physical examination abnormalities were found. His mother questions whether her worries may have impacted her son, as she admits to being overly cautious. She often keeps him home from school during pandemic outbreaks in neighboring schools, carefully screening playdates' family members for vaccination status and mask usage, and also expresses concern for school safety after the news of school shootings. His mother reports that he enjoys attending playdates with his mother. On evaluation, GP has no current developmental or cognitive delays and appears calm. What do I do now? GP is experiencing significant distress and is adversely affected by anxiety of separating from his mother. His experience is not uncommon, as separation anxiety disorder, SA, is among the most frequently reported anxiety disorders in children, estimated as impacting at least 4% of children and adolescents. It is characterized by excessive, developmentally inappropriate fears of being apart from an attachment figure, which interfere with important areas of function, such as academic or social performance. It is unclear what role parenting style plays in the development of SA. However, overly protective parenting, as learned from the case, and conversely indifferent parenting styles, both have been associated with SA. As in other anxiety disorders, there does appear to be a component of hereditability to SA, as well as an association with mood disorders in parents of affected children. SA often can emerge after stressful life circumstances. Triggers include divorce, relocation, death of a pet, illness, traumatic events, or other losses. GP's mother should be counseled that the majority of children improve with time. However, the course of SA is difficult to predict. Some children have either spontaneous or gradual resolution of symptoms. Others may remain with anxiety and lose their preoccupation with separation. Alternatively, the symptoms of SA may evolve into other anxiety or mood disorders. While there is no specific age listed in the criteria of SA in the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, text revision, it distinguishes the developmentally inappropriate separation anxiety from the normal stranger and separation anxiety seen at an early age. Distress upon separation typically begins within the first year of life and subsides by 2 to 3 years of age. A disorder of separation anxiety falls outside of the infant and toddler period. At age 9, GP is within the peak age of onset of SA, which is between 7 and 9 years of age. In children, the duration of symptoms must be at least 1 month or greater, while in adults 6 months is required to make the diagnosis. There are various ways in which SA may present. GP displayed aggression and behavioral outbursts in the context of undesired separations from his mother. In other individuals, social withdrawal, low mood, or poor concentration upon separation from attachment figures may be prominent. The anxious attachment of some children may lead to intrusive, demanding, or attention-seeking behavior in the presence of their caregivers. Other children may become a caregiver's shadow, for example, following a parent through the home and/or refusing to sleep alone. Specific phobias related to themes of imagined dangers to the caregiver can sometimes occur. For example, children may fear the dark, believing that harm may occur to a parent at night. In some cases, children report disturbing perceptual disturbances while alone. For example, seeing monsters who they fear will remove them from their caregiver. School refusal and somatic complaints that develop in anticipation of separation are frequently seen, including symptoms of headaches, stomach aches, muscle cramps, and dizziness, as in the case of GP. Somatic symptoms are less attributable to other medical conditions, especially when symptoms are absent on weekends, when there is no school, or anticipation of being separated from attachment figures. Individuals with a diagnosis of SA have been found to be more likely to develop other psychiatric conditions, either concurrently or later in life. In children, SA is commonly comorbid with generalized anxiety disorder and specific phobias. While SA has been associated with an increased risk of suicide, this association is not specific to SA and is found in several anxiety disorders. Careful evaluation is indicated to distinguish SA from other conditions. GP demonstrates oppositional behavior and frequent outbursts, which certainly can be seen in children with oppositional defiant disorder. However, in SA, such oppositional behavior is less persistent and more clearly related to separation from attachment figures. The boy's avoidance of school and jujitsu class may have raised concerns for social anxiety disorder. However, school refusal or refusal to participate in social outings in SA is driven by fear of separation from attachment figures rather than fear of being judged negatively by others. As in generalized anxiety disorder, children with SA may divulge numerous fears, such as a fear of illnesses, accidents, natural disasters, or burglaries. However, in SA, the core of these various anxieties revolves around potential impact on the individual to whom they feel attached, rather than the feared occurrence itself. The distress of SA may culminate in a panic attack, though unlike panic disorder, SA does not necessarily involve fear of experiencing future unexpected panic attacks. Like unipolar and bipolar depression, SA may involve irritability, low mood, and a lack of motivation to leave home. Yet in SA, these features are mainly present in situations in which separation from an attachment figure is threatened. As in post-traumatic stress disorder, PTSD, SA may also be triggered by a traumatic event, and both PTSD and SA may involve fear of separation from a loved one. PTSD differs in that it would involve symptoms such as avoidance and intrusion, and changes in arousal or reactivity related to a traumatic event itself, rather than concerns about separation from an attachment figure. A complete psychiatric assessment is warranted to properly establish the diagnosis, clarify target symptoms, and guide treatment planning. While the interview will primarily involve discussion with GP and his parents, additional collateral information from school teachers and/or his pediatrician would be necessary. The clinical interview should address the reason for referral. In this case, the reason for referral is angry outbursts upon separation from the caregiver. The evaluation should also include the history of the current and past problems, a safety assessment, a psychiatric and physical review of symptoms, substance use screening, personal or family psychiatric and medical history, developmental history, the boy's strengths, social or home factors, and a mental status examination. As discussed previously, SA often presents comorbidly with other conditions, such as depression and other anxiety disorders, so it is important to consider the possible presence of multiple diagnoses. Somatic complaints are commonly seen in SA and deserve their own consideration as potential evidence of medical conditions as well. Routine laboratory evaluation may be of low yield in influencing the diagnosis, though it should be considered if other concerning signs or symptoms are present. In the case of GP, one may consider reviewing thyroid studies, basic metabolic panel, and complete blood cell count, especially if physical signs and symptoms are present. As part of the clinical interview, the use of assessment scales can assist in characterizing current and past symptoms. Both the screen for child anxiety disorders, SCARED, and the Spence Children's Anxiety Scale include questions that screen for SA. The most commonly used scale to screen for anxiety disorders in children is SCARED, as it provides a parent rating and a self-assessment version and includes GP's age within the target population for the scale. More specific self-rating scales with parent versions also exist and can provide more focused information in understanding SA. When identifying SA among other psychiatric diagnoses, one must consider onset, frequency, exacerbating factors, progression of symptoms, and alleviating factors associated with the listed behaviors. One can utilize a timeline of symptoms and life events to better elucidate the underlying cause of the symptoms. By using this strategy, the temporal aspect of life events can be visualized. This timeline helps identify, in a chronological manner, life events such as parental illness, death of a family pet, or even divorce and other contributing factors that surround the reported behaviors. The timeline can highlight factors to focus on when developing a treatment plan for GP and his family. Once a diagnosis of SA is made, a treatment plan may consider the following: psychoeducation on the disorder, parental training, family and school involvement, play therapy, cognitive behavioral therapy, CBT, and/or medications. Psychoeducation and parental training are key for the management of SA. The first step is psychoeducation, which is often provided to help the youth better understand the physiological, behavioral, and cognitive signs of anxiety in the context of the fearful situation. It can also help distinguish excessive and unrealistic anxious feelings from other feelings. One would help the youth identify the physical sensations, negative thinking patterns, and behavioral actions that are involved in their anxiety process. Many educational techniques can be utilized, including the use of illustrations or metaphors, to provide a therapeutic framework of their experience. Parents are also included in the psychoeducation of SA, since parents may play a major role in the development of SA symptoms, including reinforcing the avoidance behaviors. By providing psychoeducation on the behaviors to the parents, they gain a better understanding of the dynamics that are driving the development of the anxiety symptoms in SA, which in turn helps prevent future relapses of symptoms. Parental training would be included next in the treatment plan. The instruction would emphasize consistency and routine, as well as refraining from giving in to disruptive behaviors that the child employs when anticipating separation. Parents are also educated that separation from their child is a normal event throughout the week and are encouraged to support the youth in spending more extended periods of time away from them. After-school interactions, babysitting, staying with extended family, or other appropriate activities may serve as situations in which the youth can progressively spend more time separated from primary attachment figures and engaging with others. It is also important for parents to communicate with their child when to expect their return and maintain consistency when planning such return. Another crucial step is working with school personnel and helping the youth attend and remain in school on a regular basis. Clinicians can work with parents in the school to identify appropriate limits so as not to reinforce the youth's school-avoidant behaviors. For example, parental behaviors to avoid may include chaperoning the student directly to the classroom or providing pleasurable activities or rewards when the child immediately returns home from school. Communicating on a regular basis with teachers is essential, as teachers may be attentive to triggers, concerns, or strategies that have been effective in managing separation anxiety. If the youth is experiencing extreme anxiety related to attending school and separating from parents, a program should be arranged to gradually and progressively increase the time spent away from the parent with the least amount of distress. Depending on the severity of the symptoms, a comprehensive treatment plan involving the parent, the child, and the school needs to be developed. The behavioral intervention recommended may lead to severe distress, and the child may express this distress through aggressive behaviors. School refusal associated with SA can evolve into a psychiatric emergency requiring hospitalization if the behaviors are so severe that it leads to risk of harm to self or others. For patients who have minimal impairment and distress associated with SA, symptoms may remit over time. When symptoms persist, psychoeducation and psychotherapy alone may be beneficial. Such psychotherapy modalities include CBT, which is effective first-line treatment. CBT for SA requires the implementation of behavioral strategies. The initial step involves identifying distress-triggering events, and then assessing the severity to establish a hierarchy of anxiety-inducing situations. Providing real-life graded exposure would involve habituation to the feared situation with increasing frequency and for longer periods of time. Systemic desensitization, which involves the increased introduction of anxiety-provoking thoughts or images while using relaxation techniques like belly or diaphragmatic breathing to help cope with symptoms, is another behavioral technique that is frequently utilized during CBT. Furthermore, implementing the use of praise to reinforce the desired behaviors can be helpful. Youth with SA often report fearful thoughts, including cognitive distortions, perpetuating the symptoms of anxiety. Cognitive modifications can help teach them to recognize these thoughts and challenge maladaptive ones with more realistic and rational thoughts. As an example, if the child reports, "My mother will never come back if she leaves," this thought could be reframed as, "My mother told me that she will be back before 3 p.m. Play therapy can be a valuable technique to utilize not only during the evaluation process, but also during the treatment of SA. Play therapy is a beneficial approach that enables younger children to express their emotions more easily by engaging in play activities. Overall, the minimum duration for a psychotherapeutic intervention is 12 weeks. In cases of SA where the impairment is more severe or resistant to psychotherapy alone, pharmacotherapy, generally selective serotonin reuptake inhibitors, may be indicated in the treatment plan. The Psychopharmacology Working Group for the American Academy of Child and Adolescent Psychiatry guidelines recommend a medication trial if impairment persists after a minimum of 12-week CBT sessions. After providing psychoeducation to GP and his mother and developing a behavioral plan that involved teachers at his school and instructors at his jiu-jitsu class, GP was able to demonstrate improvement in avoidance symptoms. As GP was responsive to these interventions, a joint decision was made to forego initiation of pharmacotherapy. He was monitored with progressively greater intervals between visits once symptoms resolved, and remained in remission. Key points to remember. Among childhood anxiety disorders, SA is among the most common. SA is characterized by excessive fears of separation from a parent or guardian, with distress impacting the child's ability to function. For most children, SA improves over time. Psychoeducation and parental training are key for the management of SA. 24. I can't understand why she won't speak at school when she's perfectly fine talking to her siblings. Dennis Vallerstein, MD, and Anthony Castro, PsyD, PhD. E is a 5-year-old girl with a recent history of a urinary tract infection and otherwise no prior medical or psychiatric history, who presents to clinic with her mother after the school recommended evaluation for possible learning or intellectual disability. E started kindergarten 5 months ago, and her teacher reported she is having difficulties with communication, completing classroom activities, and interacting with her peers. Her mother states she was shocked by the school's report because to her, E always seemed like a bright girl who met all of her developmental milestones. Mom reports that E can be shy in large family gatherings, but is very talkative and engaging at home, where she speaks both Spanish and English with her parents and siblings. At the clinic, E did not want to leave her mother's side. She had avoidant, downcast eyes and did not provide any verbal responses to the questions asked. She did nod and shake her head a handful of times. Her mother is worried about the possibility of E being bullied at school. After reading on social media that mutism could be a sign of autism, her concerns have heightened. What do I do now? Selective mutism is an anxiety disorder in which a child cannot speak in certain situations or environments, despite being able to speak and understand the language in other settings. For selective mutism to be diagnosed, the condition must last for more than a month and cause a disruption with social communication and/or schoolwork. Most commonly, a child with selective mutism will not speak in school or public settings, but has no issues speaking at home with their close relatives, as we learned in the case of E. Signs of selective mutism usually occur in early childhood and can start as early as 2 to 4 years of age. However, sometimes it is only noticed between ages 5 to 8 after the child starts school, at which time they are exposed to more social interactions outside of the immediate family, as in the case of E. About 0.7% of children are affected by selective mutism, with girls being more likely to have the condition, about 2 girls for every boy. Children from immigrant families are more likely to have selective mutism. In rare cases, this condition can persist into adolescence and adulthood. When placed in an uncomfortable setting, children with selective mutism can appear shy, uncomfortable, tense, stiff, awkward, isolated, rude, or uninterested. They can display behaviors such as clinging to parents, refusing to go to school, avoiding eye contact, or speaking through someone they trust. These children will often have a hard time making friends and often have poor grades in school and may exhibit inflexible and domineering temperaments at home. Parents may notice an increase in tantrums, angry outbursts, and aggression. In some cases, children with selective mutism avoid using the toilet at school because they are afraid to ask for permission, which can lead to urinary tract infections, as in the case of E. Similarly, they might avoid eating or drinking at school because they want to avoid speaking up in the classroom in order to use the restroom. The degree of symptoms in selective mutism can vary. In severe cases, children will cease to communicate verbally and non-verbally. These children seem frozen, where they have minimal facial expressions and may avoid physically moving altogether. In less severe cases, as in E, children communicate in nonverbal ways like facial expressions, nodding or shaking of the head, and/or pointing. In milder cases, patients communicate with vocal sounds or whispers. It is known that anxiety and an intense fear of social interactions are the driving factors of selective mutism. In fact, 70% to 90% of patients with selective mutism also have social anxiety disorder. In addition, other symptoms commonly seen in childhood anxiety may be present, including vague somatic complaints and school avoidance. It is also known that selective mutism is not primarily due to an intellectual disability, hearing disability, or functional speech disorder. Selective mutism can go unnoticed until it is triggered by anxiety-provoking situations. Children with selective mutism may have difficulties coping with transitions. Common examples of triggers include beginning the new school year, changing schools, moving to a new location, attending social gatherings, or experiencing ridicule from others. These triggers may not be the direct cause of selective mutism, but simply what brings the symptoms to the surface. Although there is no clear cause for selective mutism, Table 24.1 outlines several risk factors that may interplay and contribute to the development of selective mutism. Children with shy or anxious temperaments tend to experience heightened anxiety in new or uncomfortable situations. Staying mute is a way to control their anxiety. The relief from anxiety reinforces future behaviors of not speaking. Family history of anxiety or shyness is believed to be a contributing factor to selective mutism. It is believed that in addition to genetics, a child mimics observed family behaviors, such as anxiety or shyness. Children from immigrant or bilingual homes, as in the case of E, may have a harder time in school, where they have the added stressor of adjusting to a different culture and language from home. In fact, 2% of children from immigrant homes present with selective mutism, which is almost 3 times higher than the general population. Children with speech or language difficulties may not want to speak for fear of being teased, therefore choosing silence as a safer alternative. Examples of speech difficulties may include stuttering, having a lisp, or having a different accent. In some cases, selective mutism may only start after being bullied or ridiculed for their manner of speaking. About 50% of children with selective mutism have a speech disorder. Children with developmental delay and intellectual disabilities typically experience a higher level of stress and anxiety when exposed to unfamiliar situations, and these children are at a higher risk for developing selective mutism. The duration of selective mutism varies. This condition can last from as little as 1 month to several years. In most cases, symptoms resolve by age 10. Complications of selective mutism include poor academic performance, social isolation, poor self-esteem, and comorbid psychiatric conditions, including social phobia, clinical depression, and even suicidal ideation. Unsurprisingly, the longer a patient has selective mutism, the worse the complications become. Selective mutism is diagnosed by a clinician through history taking. In the evaluation of a child, their medical, psychiatric, family, social, developmental, and educational histories must be obtained. It is also important to ask about recent stressors or life changes that may have triggered the onset of symptoms. Testing of speech, language, hearing, and intellectual functioning may be necessary, as these conditions may be the underlying cause of the child's mutism. To date, there is no lab work or imaging to diagnose selective mutism. There are several conditions to consider in the differential diagnosis of selective mutism. Autism, or an intellectual disability, may be mistaken for selective mutism due to their overlapping characteristics. Poor communication, poor peer interactions, increased anxiety, and poor eye contact. However, it is important to note that children with selective mutism only exhibit these symptoms in situations that make them uncomfortable or provoke anxiety. In contrast, children with autism and intellectual disability may experience these symptoms consistently, regardless of their surroundings or the people they are with, both at school and at home. Children with autism exhibit distinct symptoms that differentiate them from those with selective mutism. These include fixation on specific topics or routines, engaging in repetitive behaviors, struggling to comprehend people's emotions and nonverbal cues, and displaying heightened sensitivity to sound, which E does not display. Children who experience anxiety or shyness may go through a temporary phase where they refrain from speaking in anxiety-provoking situations, often seen as clinging to their parents and avoiding interactions with strangers. However, the crucial distinction lies in the fact that anxious or shy children without selective mutism eventually adapt to these situations and are able to speak and communicate, and the mutism does not persist over time. It is important to remember that having social anxiety is a risk factor for selective mutism, as approximately 70% to 90% of children with selective mutism also have social anxiety disorder. Children who speak a different language at home may refuse to speak in school, not because they are anxious, but because they are uncomfortable or cannot speak the language. These children should not be diagnosed with selective mutism. Children without selective mutism will respond in social situations when spoken to in their native language. The diagnosis of selective mutism can be considered for these children once they have acquired sufficient knowledge and competence in the new language, yet continue to remain mute. There are medical conditions that contribute to a child's inability to speak. Deafness or hearing impairment, vocal cord injury, or neurological conditions that lead to receptive and/or expressive language impairment can affect their ability to communicate. Children with these conditions would have difficulty with communication in all environments, not just when they are in anxiety-provoking situations, as we learned from E's case. A speech disorder or impediment, such as a lisp, is a risk factor for developing selective mutism. About 50% of children with selective mutism have a speech disorder. Table 24.1. Risk factors for selective mutism. Characteristics. Temperamental traits. Risk factors: shy, anxious, timid, or sensitive. Characteristics: genetic predisposition. Risk factors: family history of selective mutism, anxiety, or shyness. Characteristics: environmental factors. Risk factors: different culture or language spoken at home. Characteristics: speech or language difficulties. Risk factors: stuttering, speech impairment, or language disabilities. Characteristics: developmental milestones. Risk factors: developmental delay or intellectual disabilities. Treatment. As with most childhood conditions, it is important to consider not only the immediate challenges the child faces, but also any potential ongoing disruption that risks the acquisition of essential life skills. Childhood is a stage during which many skills are acquired and milestones are reached. If undetected or left untreated, selective mutism poses a risk for the attainment of these milestones and the development of essential social skills. Consider E's experience. Her inability to speak in the school setting can lead to poor academic performance. It also interferes with her ability to gain valuable social skills through verbal interaction with classmates. In the long term, these deficits increase her chance of developing feelings of inadequacy and sadness through self-exclusion or outright social rejection. Early diagnosis and intervention play a crucial role in the management of selective mutism in children, as they significantly increase the chances of symptom remission and lead to a more favorable prognosis. The treatment models commonly used for selective mutism are primarily based on the principles of social learning theory. This theory emphasizes the significant influence of the immediate environment on cognitive and behavioral development during childhood. According to this theory, a child acquires messages and learns specific behavioral patterns by observing and interacting with others in their surroundings. In the case of selective mutism, it is believed that certain aspects of these interpersonal interactions have been portrayed as undesirable or threatening, especially in unfamiliar situations or when interacting with unfamiliar individuals. As a result, Remaining silent or withholding speech is seen as a protective response. Treatment approaches build upon this observational learning process. The goal is to convey healthier messages regarding social engagement by modeling intentional behavioral patterns and associated social skills. Primary figures in a child's life, such as parents and teachers, play a crucial role in supporting this objective. The treatment for selective mutism is mainly psychotherapy. However, medications, speech therapy, and language therapy may play a role in certain cases. The earlier treatment starts, the better the results, and the cooperation of family and the school system helps the effectiveness of treatment. In psychotherapy, the goal is to reduce anxiety linked to speech, rather than focusing on the act of speaking itself. The most common form of psychotherapy used in the treatment of selective mutism is cognitive behavioral therapy, CBT. CBT focuses on altering a person's maladaptive thoughts, emotions, and behavior. Specifically, for selective mutism, a child would learn how anxiety influences their thoughts and behaviors, and would learn methods to manage their anxiety with coping strategies and techniques. Typically, CBT would be most beneficial for children 7 years and older because they have more awareness of their thoughts. Behavioral therapy alone is a step-by-step plan that uses positive reinforcement to encourage desired behaviors and replace bad habits with good ones. This approach in behavioral therapy is aimed at slowly increasing speech production by reducing avoidance, with the ultimate goal of overcoming the fear of speaking. Other treatment modalities include play and family therapy. Play therapy provides a non-threatening and supportive environment for the child to express themselves. Through play, the therapist can work on building rapport, reducing anxiety, and gradually facilitating verbal communication. Family therapy aims to improve communication and understanding within the family system, provide strategies for creating a supportive environment, and address any underlying family dynamics that may contribute to the child's mutism. In addition, collaborating with teachers and school staff is crucial for managing selective mutism in the educational setting. This may involve developing individualized education plans, creating a supportive classroom environment, gradually increasing speaking expectations, and providing appropriate accommodations. Speech and language therapy are often utilized in the treatment of selective mutism, especially when patients have a co-occurring speech disorder or speech impediment. These therapies can develop a patient's language and make them feel more comfortable speaking. Medications can be a helpful addition in cases that are resistant to psychotherapy or cases that have co-occurring contributing conditions, like social anxiety disorder or depression. The medications of choice are antidepressants called selective serotonin reuptake inhibitors, which have been proven beneficial in the treatment of anxiety disorders in children and adolescents. Key points to remember. Selective mutism is an anxiety disorder that begins in childhood and is characterized by a child's inability to speak in certain situations. Selective mutism is not primarily due to an intellectual disability or sensory, speech, or language disorder. Common risk factors for selective mutism include female gender, immigrant family or bilingualism, shy temperament, family history of anxiety, and difficulty with language or speech. Selective mutism is usually diagnosed between the ages of 3 and 8. Psychotherapy is the main treatment for selective mutism and can minimize complications and improve prognosis. 25. What if I fall and no one's around to help? Kelly Conley, MD, and Luminita Luca, MD, PhD. Ms. D, a 73-year-old woman with osteoporosis and depression, is accompanied by her husband and presents with worsening depression and anxiety. Her husband is concerned that she has become much more dependent on others. 5 months ago, she was taken to the emergency department after tripping over a rug and sustaining a fall. Due to soft tissue damage, she had significant pain and range of motion problems that took time to resolve. Prior to the fall, she was independent in her ambulation as well as her ability to take care of her home. After the fall, the family hired a housekeeper to do all her laundry and cleaning. She also needed assistance for shopping for groceries because the carts were too unstable. Over time, her physical symptoms improved, but she remained reluctant to walk without assistance. She no longer takes walks around the neighborhood or plays with her grandchildren, and she feels weak. As a result, Ms. D spends most of her time indoors and has become socially isolated. She frequently worries that she will have another fall. What do I do now? Fear of falling, FOF, has been defined as a persistent and excessive worry of falling that leads to avoidant behavior toward activities a person is still physically capable of performing. FOF broadly encompasses both low confidence in one's ability to avoid falls and anticipatory anxiety regarding the likelihood and consequences of falling. When these concerns were first described in the 1980s, they were considered to be part of a post-fall syndrome, frequently seen in older adults after a fall event, as we learned from the case of Ms. D. However, almost half of all individuals with FOF have not experienced any actual falls. The estimated prevalence of FOF varies from 21% to 85% among community-dwelling older adults, with higher rates generally found in individuals with movement disorders, neurocognitive disorders, or a history of falls. After a fall event, 21% to 39% of older adults will develop new FOF. Several risk factors are known to be associated with FOF, including female sex, visual impairment, the presence of multiple medical comorbidities, and measurable disturbances in gait and balance. The most significant predictors of FOF development are older age, the use of a walking aid, and depression, as we learned in the case of Ms. D. Individuals who already used a walking aid are significantly more likely to develop FOF than those who do not. As in the case of Ms. D, use of a walking aid may be a sign indicating that a person feels unsteady despite the lack of pain or gait disturbance. An individual may not even be aware that their maladaptive fear response is contributing to their avoidant behavior. Furthermore, those who suffer from depression may exhibit less confidence in their own physical abilities and decrease self-efficacy in performing activities of daily living. As depressive symptoms emerge, including low energy and poor motivation, it becomes more challenging for an individual to engage in physical activity. In turn, this lack of activity contributes to deconditioning and reduced balance, further increasing the risk of falling. Individuals who are more cautious about their surroundings and movements are theoretically at lower risk of falls or other injuries. To some extent, FOF is thought to be a potentially protective mechanism. However, excessive FOF generates avoidance of physical activity, even in situations where the individual previously felt confident. These self-imposed restrictions may precipitate reduced muscle strength, leading to deconditioning and ultimately physical decline. Indeed, FOF is associated with frailty, decreased strength in the lower extremities, and inability to complete activities of daily living. FOF correlates with an increased incidence of functional disability, measured by both self-reported evaluations and performance on objective mobility assessments, such as the Short Physical Performance Battery. Rates of physical decline are highest in individuals with longer durations of FOF. Perhaps paradoxically, FOF is therefore one of the most significant factors in predicting future falls. While numerous health outcomes correlated with FOF have been established, the strength and causality of these associations are still under investigation. Depression, for example, has been demonstrated in some studies to correlate with FOF. That is, individuals with depression like Ms. D are more likely to be afraid of falling. But FOF in some cases precedes the development of depressive symptoms. This may be related to an increase in social isolation as individuals remove themselves from activities outside of their home. Ms. D has withdrawn from interacting with her own family due to fear. In general, FOF and the adverse outcomes associated with it are believed to be a self-perpetuating cycle. Perceived balance disturbances or an actual fall event may incite FOF, which then leads to a self-imposed decrease of physical activity. The decompensations, described previously, may then precipitate additional falls. Alternative models of the relationships among FOF, anxiety, and falls have been proposed. Anxiety can be the first manifestation of FOF in older adults who are not frail yet. Anxiety itself may be associated with both reduced walking speed and stride length. When navigating a path with obstacles present, older adults with higher levels of self-reported anxiety look away from their footsteps earlier than their less anxious peers. The more anxious individuals switch their attention to the next obstacle prematurely, which decreases their step accuracy and increases the risk of tripping. Anxious adults are also more likely to experience dizziness and vertigo. Anxiety may therefore be a direct contributor to instability and fall events. Finally, FOF can be a realistic appraisal of one's own balance and mobility. Individuals at higher risk for falls may simply be more aware of their physical limitations. In these situations, FOF should not necessarily be considered excessive. It is important to address an individual's FOF early in the course of its development to prevent significant deconditioning, frailty, and long-term loss of independence. Conducting a comprehensive evaluation of an individual with FOF is essential. The assessment should include physical, cognitive, psychiatric, and environmental factors. Any modifiable risk factors in the patient should be addressed. Medication regimens should be carefully reviewed for drugs that can increase fall risk, such as antihypertensives, anticholinergics, and sedative hypnotics. Although some of these may not be appropriate for discontinuation, safer alternatives and/or lower doses should be considered when possible. Depending on the underlying cause, medical conditions such as vision impairment and osteoporosis may be treatable or at least stabilized to prevent further decline. Treatment. A number of interventions have been investigated as potential treatments for FOF. The majority of these are physical activity-based, for example, strength training, balance training, and holistic exercise such as Tai Chi, yoga, Pilates, and Qigong. Making an improvement in physical conditioning is naturally presumed to be an effective way to boost confidence and reduce a person's FOF. Some newer exercise interventions utilize technology such as virtual reality headsets and gaming consoles with motion detection and/or balance sensor accessories. These interventions may provide an alternative to traditional exercise for those with low access to typical fitness equipment or settings. Virtual reality is also being investigated as a form of exposure therapy. Individuals with FOF can use virtual reality to safely explore 3D environments that feel challenging to navigate. Structured fall prevention interventions, such as the Falls Management Exercise Program and the Otago Exercise Program, have been developed to reduce actual fall risk. These programs typically combine both balance and strength exercises. They frequently include other components to promote regular walking, flexibility, endurance, and other physical skills. Programs may be offered through local senior centers, community centers, assisted living facilities, and other care agencies. Participation in such programs can also reduce FOF, even when actual fall incidence does not improve. Synthesizing the results of individual FOF studies is difficult given the extremely large variation in trial populations and methods. However, a few intervention categories and characteristics were found to be of significant benefit in the literature. Holistic exercise has been repeatedly demonstrated to reduce FOF, especially in community-dwelling adults. Tai Chi in particular has received the most attention for its benefits in coordination and body awareness for individuals with FOF. Older adults may also prefer its slower movement speed and low joint impact compared to other exercise types. Supervision with a Tai Chi instructor has been found to be the single most effective intervention in reducing FOF, more than even physical or occupational therapy. Other exercise-based interventions that yielded small reductions in FOF were strength training, balance training, and endurance training. Regardless of the exercise type, activity-based interventions generally create larger reductions in FOF when delivered in a group setting as opposed to individually. The group format is hypothesized to provide additional benefits through social engagement, peer support, and an increased sense of accomplishment after successfully attending a scheduled class. Interestingly, one meta-analysis found that tailoring exercises specifically to a participant's current level of functioning may actually be detrimental to FOF. The author suggested that visibly adjusting exercise instructions may make a participant more keenly aware of their own limitations, leading to increased anxiety and decreased self-confidence. Providing standardized instructions avoids this detrimental effect. Psychological interventions such as cognitive behavioral therapy, CBT, have also been explored as a treatment for FOF. Individuals with FOF may have overly pessimistic beliefs regarding their ability to avoid falls and the consequences of actual falls. These maladaptive thoughts could be challenged and subsequently altered via CBT. Motivational interviewing techniques used in CBT also encourage participants to identify their own reasons for increasing their physical activity and to set feasible goals. CBT appears to have an immediate effect on FOF as well as on balance. The CBT effects on improving balance are mediated by increasing levels of daily activity. The benefits of CBT seem to persist for at least 6 months post-intervention, and possibly up to 20 months or longer. A small number of studies have combined CBT with an activity-based intervention. These combined protocols led to greater reductions in FOF compared to either type of intervention alone. Unlike activity-based interventions, CBT appears to be more effective when delivered individually, as opposed to in a group setting. Home assessments have long been used to screen for environmental factors that contribute to fall risk. Modifications such as railings and bathroom grab bars are frequently promoted for fall prevention in the homes of older adults. While these home assessments and modifications are not yet proven to reduce FOF, there is some evidence that they do prevent actual fall events. Ms. D was referred to a Tai Chi program that offers twice-weekly classes at her local community center. She also received treatment for her depression. 3 months later, she reported feeling more confident in her movements and had resumed some of her prior activities, including shopping for groceries and taking her grandchildren to the park. Key points to remember. FOF includes not only anxiety regarding the likelihood and consequences of falls, but also low confidence in one's ability to avoid falls. FOF is common among the elderly and occurs even in those who have not previously fallen. Risk factors include female sex, depression, older age, and mobility issues. Activity restriction due to FOF leads to physical decline, paradoxically increasing the risk of future falls. Holistic exercises such as Tai Chi and yoga have the most evidence for reducing FOF, although other group exercises and individual CBT may also be beneficial. 26. I can't help but worry about my bills and finances. Sean E. Oldak, M.D., Firas Al-Karbouche, M.D., and Elizabeth Crocco, M.D. Mr. B is a 72-year-old man who presents with his wife due to concerns about anxiety. He relates feeling anxious about his bills and finances. He has recently been making mistakes in accounting, such as miscategorizing his grocery spending into his entertainment budget. He has been keeping physical receipts to review his spending. His wife notes that he has been inquiring about how well she manages their money, causing marital strain. He becomes defensive and insists that since his retirement, he has been feeling lonelier and needs to know where she is going and where the money is going. He repeats stories during the interview and becomes slightly irritated when this is pointed out. His wife expresses worry that his memory seems to have worsened recently, as he periodically would repeat himself. She also suspects he may have been forgetting to take his medications, as she often finds his pill bottles too full. Otherwise, the patient shows no other changes in his daily function. What do I do now? Recognizing Mr. B's anxiety and its relationship to his cognition is vital to diagnosing his condition. In the elderly, it is necessary to perform a comprehensive evaluation that fully assesses an individual's cognitive, neurological, psychiatric, and functional impairments. The possibility of a neurocognitive disorder such as Alzheimer's disease and related dementias, including vascular and diffuse Lewy body disease, as well as other neurodegenerative conditions, is quite high. In this assessment, an interview with a caregiver or family informant can provide insight into the nature and duration of symptoms. Both an objective cognitive and functional assessment are necessary to arrive at a cognitive diagnosis. In addition, medical workup including serum blood tests and neuroimaging is used in determining the etiology. Monitoring changes over time, including behavioral and neuropsychiatric symptoms, can aid in understanding the disease progression. Mr. B presented with anxiety related to specific areas of his life, most notably tasks involving accounting and managing money. These cognitive demands, though still within his capacity, have become progressively more difficult for him to handle independently. Even routine activities like shopping have become more challenging, prompting him to adopt the habit of saving his receipts. Complicating matters is an interpersonal element, as he has gradually developed symptoms of separation anxiety. In the presence of his wife, Mr. B experiences a heightened sense of security. Paradoxically, this reassurance appears to create an increasing need for in-person interactions with her. As a result, his focus on financial stressors, essentially stemming from his cognitive challenges, intensifies during these interactions. Late-onset anxiety has been found to be associated with neurocognitive disorders, particularly in older adults. Neurodegenerative disorders, such as Alzheimer's disease and related dementias, ADRDs, are characterized by cognitive decline and impairment in various cognitive domains, including memory, attention, language, visuospatial skills, and executive function. Behavioral disturbances, including anxiety, have been shown to exacerbate the cognitive decline and functional impairment seen in neurodegenerative illnesses. The relationship between anxiety and neurocognitive disorders is complex and multifaceted, with several possible mechanisms contributing to their association. Indeed, circuits mediating various cognitive domains can be part of, or closely related to, those involved in emotions or behavior. Psychologically, the experience of cognitive deficits, memory loss, and difficulties in daily functioning can trigger anxiety symptoms, as we learned in the case of Mr. B. Patients such as Mr. B can be concerned about their anxiety and may not connect it to their cognitive struggles. In patients with mild cognitive impairment, MCI, the precursor state of ADRDs, the prevalence rates of anxiety symptoms range from around 10% to over 50%. Individuals with MCI are more likely to experience anxiety when compared to cognitively healthy older adults. The presence of anxiety in MCI may also be associated with an increased risk of progression to dementia. Indeed, research suggests that late-onset anxiety can be both a risk factor for and a symptom of neurocognitive disorders. Among individuals with ADRDs, the prevalence of anxiety symptoms tends to be higher compared to MCI. Estimates of anxiety prevalence in dementia range widely, from approximately 20% to 50% or higher. The presence of anxiety in dementia may be associated with more severe cognitive impairment, increased caregiver burden, and poorer quality of life for both the individuals with dementia and their caregivers, and it increases the risk of needing placement in a long-term care facility. Of note, anxiety symptoms in patients with MCI or dementia can manifest in a variety of ways and may not always be easily recognized. Symptoms of anxiety in this population may include excessive and persistent worry about their cognitive decline, memory loss, or difficulties in daily functioning. They may constantly fear making mistakes or forgetting important information, as we learned in the case of Mr. B. Anxiety can also present as restlessness, pacing, or an inability to sit still. Individuals may exhibit increased motor activity, such as fidgeting, hand-wringing, or repeatedly getting up and down from chairs. Anxiety can also present as increased irritability and emotional reactivity. Individuals may become easily frustrated, have mood swings, or display heightened emotional responses to situations that would not have previously elicited such reactions. For example, in the case of Mr. B, he would become angry at a cashier's register due to anxiety surrounding managing his spending. Anxiety can be accompanied by various physical symptoms, such as palpitations, shortness of breath, muscle tension, trembling, and sweating. It can also disrupt sleep patterns, which is of particular importance given how important sleep is to this patient population. Finally, anxiety can be associated with hoarding behaviors, as patients may fear forgetting important information or believe the items have sentimental value or future utility. This leads to cluttered living spaces and further significant distress and impairment in daily functioning. This hoarding behavior and subsequent distress and impairment in daily functioning are evident in the case of Mr. B and created problems in his marriage. Anxiety symptoms can have a detrimental effect on patients' interpersonal lives as well. Table 26.1 outlines common symptoms of anxiety and neurocognitive disorders. Patients may seek constant reassurance from their caregivers or family members, leading to separation anxiety, as we learned in the case of Mr. B. They may rely heavily on others for support and guidance due to heightened anxiety about their own cognitive abilities. Furthermore, anxiety can lead to a social withdrawal and avoidance of interpersonal interactions due to fear and shame surrounding these social situations and how they will be perceived. Patients may feel self-conscious about their cognitive deficits and fear embarrassment or judgment from others, resulting in isolation and decreased social engagement. Table 26.1 Symptoms of anxiety and neurocognitive disorders. Symptoms: excessive worry. Examples: constant fear of memory loss or making mistakes. Symptoms: irritability and emotional distress. Examples: becoming easily frustrated or having mood swings. Symptoms: physical symptoms. Examples: palpitations, shortness of breath, muscle tension, restlessness. Symptoms: sleep disturbances. Examples: difficulty falling asleep or staying asleep. Symptoms: increased sensitivity to sensory stimuli. Examples: being easily startled by loud noises or bright lights. Symptoms: separation anxiety. Examples: constantly seeking reassurance from caregivers. Symptoms: social withdrawal and avoidance. Examples: avoiding social interactions due to fear of embarrassment. Symptoms: difficulty concentrating or making decisions. Examples: trouble focusing or feeling overwhelmed. Symptoms: hoarding behaviors. Examples: excessive clutter in living spaces, difficulty discarding possessions, excessive acquisition of items. Treatment. Treating anxiety in patients with neurocognitive disorders is of clinical importance, as anxiety is associated with a greater burden on caregivers and increases the risk of needing placement in a long-term care facility. Treating anxiety in neurocognitive disorders involves a combination of pharmacological and non-pharmacological interventions tailored to the specific context and triggers of patient symptoms, cognitive status, and social support. Table 26.2 outlines the non-pharmacological treatment approaches for anxiety and neurocognitive disorders. Psychoeducation is an essential portion of the treatment, as it can reduce fear and uncertainty and promote acceptance in both the patient and their caregivers. Providing information and education about the nature of neurocognitive disorders and their relationship to anxiety can help individuals and their caregivers better understand and cope with the condition. Cognitive behavioral therapy can be beneficial. However, its efficacy can be limited by the severity of the patient's cognitive impairment. Creating a calm and structured environment can help reduce anxiety in individuals with neurocognitive disorders. This may involve minimizing noise and clutter, establishing predictable routines, and providing visual cues or reminders to enhance orientation and reduce confusion. Encouraging social engagement and maintaining meaningful social connections can help reduce feelings of isolation and anxiety. Support groups, social activities, and interactions with family and friends can provide emotional support and a sense of belonging. Medication can also be prescribed to manage severe, persistent anxiety symptoms. Antidepressants or anti-anxiety medications, such as serotonin reuptake inhibitors, continue to be the mainstay of treatment. Medication decisions should take into account individual factors, potential side effects such as increased risk of bleeding and hyponatremia, and drug-to-drug interactions, as well as severity of disease. Table 26.2 Non-pharmacological treatment approaches for anxiety and neurocognitive disorders. Intervention. Psychoeducation. Examples: set realistic expectations about the course of the illness. Differentiate between symptoms of anxiety and those typical of neurocognitive disorders. Intervention. Social support. Examples: have a support network of family and friends as a source of emotional comfort and reassurance. Address social withdrawal by engaging in social activities and outings. Intervention. Environmental modifications. Examples: simplify the environment by minimizing clutter, maintaining a tidy environment, and creating clear pathways that can help individuals feel more calm, more oriented, and less overwhelmed. Use visual cues and reminders such as labeled drawers or cabinets and prominent calendars to assist in remembering information and reduce anxiety related to memory difficulties. Intervention. Behavioral modifications. Examples: use pill organizers to assist in self-medication administration. Establish consistent routines and daily schedules, such as regular meal times, exercise routines, and consistent sleep schedule, to provide predictability and reduce anxiety. Engage the individual in meaningful activities, such as art therapy, music therapy, gardening, or working with puzzles to redirect anxious thoughts and promote a sense of purpose. Intervention. Psychotherapy. Examples: cognitive behavioral therapy can help in addressing maladaptive cognitive distortions. Train patients in relaxation techniques, stress management skills, and problem-solving strategies. Key points to remember. Anxiety in older adults can be a manifestation of a neurocognitive disorder. Treating anxiety in patients with neurocognitive disorders is of clinical importance, as anxiety is associated with a greater burden on caregivers and increases the risk of needing placement in a long-term care facility. Treatment can use multiple modalities, such as serotonin reuptake inhibitors, as well as behavioral modification strategies. 27. At first, I tried fluoxetine, but it made my anxiety even worse, and I had stomach problems. Sung Min Ma, MD, and Daniel Moss, MD. Ms. O is a 27-year-old female who presents for treatment of anxiety. Initially, she was prescribed fluoxetine 20 milligrams daily, but could not tolerate it due to increased anxiety and gastrointestinal distress. She was then started on sertraline 25 milligrams daily, and the dose was gradually increased to 200 milligrams daily. More recently, her anxiety symptoms have been inadequately controlled. Ms. O reports having panic attacks for the past 2 months. In addition, she has been experiencing sleep difficulties. Her primary care physician prescribed alprazolam. She acknowledges that recently she was taking more than the prescribed amount because the recommended dose had not been helpful. In light of this, she requested that her dose of alprazolam be increased. Ms. O states that she stopped drinking alcohol last year and has a strong family history of substance abuse. What do I do now? Anxiety is a normal emotional state that can serve many purposes in life. Anxiety can be a driving force for change or an alarm system that places one on high alert to identify perceived threats. Anxiety can be an expected and an understandable response to a stressor. The experience of anxiety does not always indicate a psychiatric disorder. However, excessive anxiety can be debilitating and paralyzing. Persistent anxiety may cause physical and emotional stress, cloud one's judgment, affect cognition, and worsen other comorbid psychiatric and medical conditions. Although psychotherapy can be beneficial in the treatment of anxiety, pharmacotherapy may be indicated based on the anxiety's underlying source, context, and severity. Additionally, clinicians should delineate specific symptoms because when patients use the term anxiety to describe their mood state, their symptoms may be due to different psychiatric conditions, which requires pharmacotherapy tailored to those specific diagnoses. Key elements in the evaluation and treatment of anxiety disorders include the assessment of the symptoms and their severity, as well as the identification of comorbid psychiatric or medical conditions. The main goals of treatment are to reduce anxiety symptoms and improve quality of life. Mild symptoms that do not significantly impact daily functioning may not require immediate treatment, but regular follow-up with the patient is important to monitor the course of the condition. The choice of treatment is individualized and involves shared decision-making, with the patient having their own preference for medications or psychotherapy. For those with severe anxiety symptoms or comorbid psychiatric conditions, such as depression, initial treatment with pharmacotherapy may be preferred. While a combination of pharmacotherapy and psychotherapy may be beneficial for some patients, most benefit from one or the other, and the addition of a second modality is typically reserved for persistent and severe symptoms. Serotonin reuptake inhibitors, SRIs, such as selective serotonin reuptake inhibitors, SSRIs, and serotonin norepinephrine reuptake inhibitors, SNRIs, are the preferred initial pharmacotherapy for anxiety disorders due to their safety and tolerability. The choice of a specific SRI is based on factors including the medication's side effect profile, potential drug-to-drug interactions, patients' preferences, and patients' treatment history. Table 27.1 summarizes Food and Drug Administration, FDA, approved medications for specific anxiety disorders. However, all SRIs have demonstrated efficacy in the treatment of anxiety disorders, and the choice of medication is dictated by the factors described previously. Although the Diagnostic and Statistical Manual of Mental Disorders, 5th edition text revision, separated obsessive-compulsive disorder and post-traumatic stress disorder from other anxiety disorders, SRIs are also regarded as first-line treatments for these conditions. Before starting treatment with an SRI, providers should discuss with the patient the potential side effects, drug-to-drug interactions, and duration of treatment before a response is expected to occur. It should be noted that while some improvement may occur within the first 4 weeks of treatment, it can take up to 8 to 12 weeks to reach the medication's full clinical effect. If an SRI is to be discontinued, the patient should be aware that these medications should be tapered down to minimize discontinuation symptoms, especially the SRIs with shorter half-lives such as paroxetine. SRIs can have paradoxical side effects initially, including exacerbation of anxiety, insomnia, or agitation, An adjunctive therapy may be used to manage these side effects. It typically takes around 4 weeks for SRIs to have a clinically meaningful effect, and the initial therapeutic dose should be maintained for 4 to 6 weeks to allow time for improvement. It is important to educate patients that the medication must be taken every day to have the desired effect. If there is no significant response, the SRI dose may be gradually increased until improvement is observed or the maximum recommended dose is reached. The dose can generally be increased every 4 weeks based on response and tolerability, and more rapid titration will need closer monitoring. Patients who show gradual improvement are monitored for up to 12 weeks at the maximum tolerated dose. Common side effects of SRIs include gastrointestinal problems, insomnia, sedation, dizziness, headaches, and sweating. It is important to note that patients with anxiety may experience somatic symptoms as manifestations of the anxiety disorder itself. It is crucial for the clinician to educate the patient that anxiety can be associated with physical symptoms. On the other hand, patients must be informed about the potential side effects of SRIs. If these side effects occur, they are usually transient, and there are strategies to minimize them. The clinician can recommend taking the medication with food or increasing the dose at a slower rate. These recommendations may prevent the patient from abruptly stopping a medication that in the long term will be effective, safe, and well tolerated. During longer-term use, sexual side effects such as anorgasmia, delayed ejaculation, and decreased sex drive can occur. Strategies for the management of sexual side effects with the use of SRIs include watchful waiting, decreasing the dose within the therapeutic range, adjunctive treatment with medications for erectile dysfunction, and switching to a different class of antidepressant. In the case of Ms. O, she was started on sertraline for GAD. Even though it is not FDA approved for GAD, it is a reasonable first-choice SSRI, as studies have shown its clinical efficacy and tolerability in the management of GAD. Sertraline may cause gastrointestinal side effects, such as nausea and diarrhea, but otherwise, its side effect profile is mild, and taking sertraline with food can mitigate gastrointestinal upset. Ms. O tried sertraline at a therapeutic dose for an appropriate period of time, 8 weeks or longer, but it failed to address Ms. O's worsening anxiety adequately. If sertraline had been the only antidepressant she had ever tried, it would be reasonable to cross-taper her to a different SSRI. For example, escitalopram may be the next suitable choice for Ms. O, given that it is FDA approved for GAD and is generally well tolerated. If Ms. O fails 2 adequate SSRI trials, it would be reasonable to try an SNRI, such as duloxetine or venlafaxine. If multiple SSRI or SNRI trials are unsuccessful, one may consider tricyclic antidepressants, TCAs, and monoamine oxidase inhibitors. These antidepressants have been shown to be very efficacious options, but they are generally reserved for select cases due to their considerable side effect profile and safety issues. Table 27.2 lists common side effects in antidepressant use. In choosing SRIs for the treatment of anxiety, select patient populations require special considerations. In patients with hepatic or renal impairment, duloxetine should be avoided, as its clearance can be reduced by more than 80%. On the other hand, duloxetine has an advantage in patients with pain comorbidities, as it has FDA indications for peripheral neuropathic pain, fibromyalgia, and chronic musculoskeletal pain. SNRIs are associated with increased blood pressure, and this should be monitored especially in patients with hypertension or cardiovascular disease. When starting an SRI, gastrointestinal bleeding risk should be assessed, as they have been shown to inhibit platelet aggression. For example, the risk of bleeding increases when the patient takes an SRI and a nonsteroidal anti-inflammatory drug simultaneously. Patients with significant cardiovascular disease and chronic arrhythmias may want to avoid citalopram, as it has a risk of prolonging the electrocardiogram QT interval at higher doses. In women of childbearing potential like Ms. O, or in pregnant women, the potential risk-benefit profile to the fetus should be considered, and the benefits and risks of pharmacotherapy must be weighed. Ms. O reports that alprazolam was helpful in managing her panic attacks. In general, sedative hypnotics such as benzodiazepines should be reserved for those patients who require immediate alleviation of anxiety, as an SRI often cannot provide this acute short-term relief. Additionally, a benzodiazepine can be prescribed to alleviate the symptoms that may occur when initiating an SRI. Although most guidelines advise limiting the use of benzodiazepines therapy, many patients like Ms. O may ask for increasing dosages of the benzodiazepine because their symptoms are not well controlled. One downside of alprazolam is that although it is quite potent and has a rapid onset of action, it has a short half-life and, paradoxically, may worsen Ms. O's symptoms and cause rebound anxiety when the effects wear off. Switching her to a longer-acting benzodiazepine would be preferable, with the understanding that this treatment is best utilized in the short term or on an as-needed basis until the antidepressant takes effect. In elderly individuals, benzodiazepines with a longer half-life should be avoided, as sedative hypnotics can impair cognition and increase their risk for falls. In patients with respiratory diseases such as obstructive sleep apnea and chronic obstructive pulmonary disease, benzodiazepines pose a greater risk of respiratory depression. When tapering benzodiazepines, care should be taken to wean slowly in patients with epilepsy, as this population is more vulnerable to benzodiazepine withdrawal seizures. Table 27.3 compares commonly prescribed benzodiazepines. For the treatment of anxiety disorders, other medications such as buspirone, pregabalin, hydroxyzine, mirtazapine, and TCAs have been utilized. These medications have been found to decrease anxiety symptoms and are used as adjunctive agents. However, they are not commonly used as first-line treatment due to insufficient evidence to support their use as monotherapies and the potential for side effects. The response to pharmacological treatment for anxiety disorders ranges from full symptom remission to no discernible effect. A full response to treatment means that a patient experiences significant improvement in their symptoms to the extent that they do not significantly affect quality of life. A partial response means that a patient exhibits some symptom improvement, but residual symptoms are present and continue to affect day-to-day function. In non-response, a patient experiences minimal or no improvement in their symptoms with treatment. Finally, treatment resistance refers to a lack of response to at least 2 adequate medication trials, with or without augmentation. A treatment-resistant condition is more difficult to manage and may require more intensive or specialized treatment approaches. Ms. O has a partial response to her current treatment regimen. It is essential to reevaluate her symptom profile and explore other potential sources of anxiety with careful history-taking. In addition to generalized anxiety, she suffers from panic attacks, which are causing impairment and distress. Panic attacks can occur in other anxiety disorders and psychiatric conditions. For example, determining whether Ms. O has developed anticipatory fear of recurrent panic attacks or avoidance is important, as these are hallmark features of panic disorder and may necessitate a different treatment approach. Screening for mood disorders, trauma, and stressor-related psychotic and substance use disorders is also necessary. Anxiety is frequently related to mood disorders, including both major depressive disorder and bipolar disorder. In the case of Ms. O, she did not report having any symptoms of depression or suicidal ideation. Substance abuse may also present as anxiety. Depending on the type of substance, a person intoxicated or withdrawing may exhibit severe anxiety and agitation. Ms. O stated that she does not abuse alcohol or recreational drugs, but more granular information should be elicited regarding both her personal and family history of substance use. Such information is relevant, especially when considering benzodiazepines, because some patients are more vulnerable to developing sedative hypnotic dependence. Furthermore, benzodiazepines should be avoided in patients with a history of prescription misuse or addiction to benzodiazepines, opioids, alcohol, or other sedatives. When benzodiazepine dependence and withdrawal occur in a small fraction of the patients taking the medication for brief periods, it is essential to identify high-risk patients to provide a safe, targeted approach. Ms. O was eventually diagnosed with comorbid panic disorder in addition to her diagnosis of GAD. Upon further history gathering, she was found to have a low risk of substance use or misuse. She was tapered off sertraline at a rate of 25% per week. At the same time, she was started on escitalopram 5 milligrams, which was slowly titrated to a dose of 20 milligrams. During this cross-titration, alprazolam was switched to a longer-acting benzodiazepine, clonazepam, to be taken at bedtime to target anxiety and insomnia. A few weeks later, as her symptoms improved, clonazepam was discontinued, and she engaged in cognitive behavioral therapy for the continued management of her anxiety symptoms. Table 27.1. Food and Drug Administration approved medications for anxiety disorders. Selective serotonin reuptake inhibitors. Fluoxetine. Panic disorder. Obsessive-compulsive disorder. Sertraline. Panic disorder. Social anxiety disorder. Obsessive-compulsive disorder. Post-traumatic stress disorder. Paroxetine. Generalized anxiety disorder. Panic disorder. Social anxiety disorder. Obsessive-compulsive disorder. Post-traumatic stress disorder. Citalopram. Escitalopram. Generalized anxiety disorder. Fluvoxamine. Social anxiety disorder. Obsessive-compulsive disorder. Selective norepinephrine reuptake inhibitors. Venlafaxine. Generalized anxiety disorder. Panic disorder. Social anxiety disorder. Duloxetine. Generalized anxiety disorder. Benzodiazepines. Alprazolam. Generalized anxiety disorder. Panic disorder. Clonazepam. Panic disorder. Tricyclic antidepressants. Clomipramine. Obsessive-compulsive disorder. Table 27.2. Common side effects of antidepressants, serotonin reuptake inhibitors, tricyclic antidepressants, TCAs, and monoamine oxidase inhibitors, MAOIs. Medication. Selective serotonin reuptake inhibitors and selective norepinephrine reuptake inhibitors, SNRIs. Side effects. Gastrointestinal upset, sexual dysfunction, dizziness, and headaches. Specific considerations. Paroxetine has anticholinergic effects. Medication. SNRIs only. Side effects. Hypertension. Specific considerations. Venlafaxine is contraindicated in glaucoma. Medication. TCAs. Side effects. Sedation, constipation, dizziness, diaphoresis, drowsiness, weight gain, tremor, hypotension, urinary retention. Specific considerations. Cardiac conduction delays, ventricular arrhythmias and overdose. Medication. MAOIs. Side effects. Dry mouth, headache, drowsiness or insomnia, dizziness, gastrointestinal upset, hypotension. Specific considerations. Risk of hypertensive crisis with tyramine-containing foods. Table 27.3. Comparisons of commonly used benzodiazepines. Medications. Alprazolam. Onset of action, hours, 1 to 2. Half-life, hours, 6 to 27. Equivalent dose, 0.5 milligrams. Medications. clonazepam. Onset of action, hours, 1 to 2. Half-life, hours, 18 to 50. Equivalent dose, 0.5 milligrams. Medications: clorazepate. Onset of action, hours, 0.5 to 2. Half-life, hours, 30 to 100. Equivalent dose, 15 milligrams. Medications: diazepam. Onset of action, hours, 1 to 2. Half-life, hours, 20 to 80. Equivalent dose, 10 milligrams. Medications: lorazepam. Onset of action, hours, 1 to 6. Half-life, hours, 10 to 20. Equivalent dose, 1 milligram. Medications: oxazepam. Onset of action, hours, 1 to 4. Half-life, hours, 5 to 15. Equivalent dose, 15 milligrams. Medications: temazepam. Onset of action, hours, 1 to 2. Half-life, hours, 8 to 15. Equivalent dose, 20 milligrams. Key points to remember. While psychotherapy can offer valuable benefits in addressing anxiety, pharmacotherapy may be warranted depending on the underlying source, context, and severity of the anxiety. SRIs are first-line treatment for all major anxiety disorders due to their tolerability and efficacy. Benzodiazepines are effective for acute anxiety, but their use must be balanced by the risk of physical dependency and abuse. 28. My doctor prescribed medication, but I am afraid to take it. Diana Incapie, Psy-D, Alexandra Ortega, Psy-D, and Marcella Kitai-Gorodsky, Psy-D. Ms. V is a 68-year-old female who sought an evaluation in light of ongoing symptoms of anxiety triggered by a wide range of everyday situations. Approximately 10 years ago, Ms. V was involved in a car accident resulting in multiple injuries, along with the penetration of her intestinal tract and a colostomy. Since the incident, Ms. V has been experiencing frequent fears and worry about being in cars or situations in which she may not be able to leave and change her colostomy bag. Notably, in recent years, she has begun to spend more time alone. Her friends and family have expressed concern about these changes and her inability to do the things she used to do. While her physical health is stable, she mentions undergoing brief moments of intense fear where she experiences sweating, nausea, shaking, fast heart rate, and shortness of breath. She reports she has been prescribed medication. However, she has not started it because she is afraid of the side effects. What do I do now? Agoraphobia is a term resulting from a mix of the Greek words agora, meaning open space or place of assembly, and phobos, meaning fear. Agoraphobia is an anxiety disorder characterized by an intense fear of being in situations where escape can be seemingly difficult or help might not be readily available. Examples of such situations include leaving home alone and being in crowded places such as shopping malls or train stations, enclosed spaces such as public transport or movie theaters, and open spaces such as traveling on bridges or highways. At its core, agoraphobia is a type of disorder in which the patient fears and avoids places or situations that might cause feelings of entrapment, helplessness, or embarrassment. This anxiety is a direct result of fearing that escape or finding help will be impossible in such situations. Anxiety can also be exacerbated by the fear that one cannot be helped if the anxiety intensifies, or that panic will lead to disabling or embarrassing symptoms. Those with agoraphobia often have a hard time feeling safe in public places, especially around large crowds. As a result of this fear, avoidance of public and open areas often results in confinement to safe places, such as the patient's home. It is not uncommon for people affected by this condition to request help from a companion, such as a relative or friend, to go and navigate the outside world. However, the fear can be so intense that it renders the patient unable to leave, even with the help of others. Another aspect of this diagnosis is that fear tends to be out of proportion to the actual danger of the situation, whether the threat is real or imagined. When unable to circumvent stressors, such as needing to leave the house due to an emergency, individuals with this condition often find themselves extremely distressed. This psychiatric condition usually results in significant distress and/or impairment in social situations, work, and other important areas in the person's life. The exact causes of the disorder are unknown. However, evidence suggests that stressful or traumatic events can contribute to the development of this condition. It can also occur in individuals who have had a panic attack in the context of the feared situations. The linkage of these two events can lead to a feedback loop in which a previously neutral situation becomes associated with a fearful response or sense of danger, leading to avoidance of that situation to prevent the recurrence of the perceived threat. The fear can be triggered either by having to endure the actual situation or as a result of the anticipation of such an event, as imagining oneself in the feared scenario. It is not uncommon for patients to present with a dual diagnosis of panic disorder in addition to agoraphobia. Panic disorder is a type of anxiety disorder in which one experiences sudden attacks of extreme fear that reach a peak within a few minutes and trigger intense physical symptoms. The fear of another panic attack can lead to avoiding similar circumstances or the actual place where the panic attack occurred, as an attempt to prevent the high level of distress experienced. People with agoraphobia who find themselves in stressful situations can develop the physical and psychological or emotional symptoms of a panic attack. Typical panic attacks are unexpected and seem to emerge out of the blue, triggered by no obvious event. Even though short in duration, for example a few minutes, panic attacks can develop into disabling dread of their recurrence and impair functioning in those who experience them. Depression commonly accompanies agoraphobia and can impact the individual's functioning even further. Anticipatory anxiety happens when people experience distress as they begin to think about an event that will or could happen in the future. While this is not a distinct mental condition, anticipatory anxiety is a common symptom of most anxiety disorders, including panic disorder, agoraphobia, specific phobia, and generalized anxiety disorder. Anticipatory anxiety may occur in response to both large and minor events alike, such as giving a presentation at work, driving, parking your car, or having conversations with coworkers. Those with anxiety conditions often find themselves anticipating routine life events excessively. This preoccupation tends to disrupt daily activities, impair concentration, and affect their well-being. Plenty of human experiences can cause anticipatory anxiety, including completing a major task, such as taking a final exam, trying something new, such as skydiving, or navigating an upcoming life event, such as becoming a parent. Fear, the main emotion behind anxiety, can be both crucial and functional when it works to our advantage. Conversely, it can become dysfunctional and disabling when it fails to do so. Events such as going on a first date or a job interview or moving to a different state can come with a healthy dose of anxiety necessary to keep one focused on a goal. This type of anticipatory anxiety is normal. Normal, healthy fear is functional in that it prepares the person's fight or flight response to the appraised danger. On the other hand, for a person with an anxiety disorder, misanticipation and worry becomes disproportionate and excessive, leading to a pathological response. The visualization of future events is solely focused on catastrophic results that can, in the mind of the beholder, lead to a panic attack. But what makes one person prevail while others retreat in the face of a threat? One psychological variable that has been considered as a possible vulnerability factor is anxiety sensitivity. Anxiety sensitivity refers to the apprehension of possible risk or harm. For example, A person with high anxiety sensitivity may fear that heart palpitations signify an impending heart attack, whereas a person with low anxiety sensitivity is likely to regard palpitations as harmless, transient physical responses. Patients with an anxiety-based disorder may find themselves thinking in the following manner: what if I have a panic attack and drive my car into oncoming traffic? What if I start to panic while giving a presentation and embarrass myself? What if I start choking on my food in a restaurant and no one can assist me? What if I walk around the block and start to panic and can't get back home? Many individuals experiencing agoraphobia and panic disorder do not receive timely diagnosis and appropriate interventions, leading to prolonged distress and impairment in their daily lives. One of the reasons for the underrecognition and undertreatment of agoraphobia is the complex nature of the condition. Symptoms of agoraphobia can be misconstrued or overlooked, as individuals may not readily disclose their avoidance behaviors. In addition, anxious patients commonly present with other physical or psychological complaints. Cognitive interventions. The gold standard psychotherapeutic treatment for anxiety disorders is short-term cognitive behavioral therapy, CBT. CBT is an evidence-based and non-pharmacological treatment approach that can be applied to a broad range of patients. CBT is a common treatment approach to be used with adults, as it allows the individual to take on an active role, learn positive coping skills, and experience symptom reduction early in the treatment as they build on their own success. CBT empowers individuals to regain their independence, increase their tolerance for anxiety, and reclaim a fulfilling and meaningful life. CBT involves a structured and goal-oriented approach to therapy. Typically, CBT offers a limited number of sessions, often ranging from 12 to 20 encounters, depending on individual progress and severity of the symptoms. The patient and the therapist work collaboratively to identify and challenge the patient's unproductive or maladaptive thoughts and beliefs related to their fears and anxiety. An essential component of CBT is psychoeducation, as understanding the nature of anxiety, the role of avoidance behaviors, and the therapist's role in the maintenance of the cycle can itself be empowering. With knowledge comes the realization that symptoms are manageable and not life-threatening. The primary focus of cognitive interventions in CBT is to challenge unhelpful thought patterns or cognitive distortions, which are patterns of biased and inaccurate thinking that can contribute to anxiety and distress. Examples include catastrophic thinking. For example, if I leave my house, I will get into an accident. Catastrophic misinterpretation. For example, my heart pounding means I am having a heart attack. Overgeneralization. For example, no one wants to be near people with colostomy bags. And black and white thinking. For example, people will never like me because of my disabilities. There are different techniques used to challenge these thinking patterns, which in turn improve perception and problem solving. Cognitive restructuring involves self-monitoring of thought content, identifying challenging cognitions or irrational thoughts, and reframing thinking patterns to aid the development of adaptive interpretations or responses. Therapists help patients identify common cognitive distortions and challenge them to gain a more balanced perspective on their fears and anxieties. Cognitive coping strategies also involve teaching alternative ways of thinking and responding to these situations, and learning to tolerate uncertainty and develop coping statements to challenge their anxious thoughts. Behavioral interventions. While behavioral interventions for anxiety frequently center on the reduction of worry by employing relaxation techniques, exposure therapy remains a hallmark for treatment of anxiety and trauma-related disorders. Exposure therapy is a behavioral intervention that is commonly used to treat anxiety-related disorders, and its major tenets are derived from behavioral learning theory. In the case of agoraphobia and panic, exposure therapy helps individuals confront their fears related to being in situations where they believe they may not be able to leave. Through exposure to these situations, individuals gradually learn that their fears are unfounded or manageable. leading to a reduction in anxiety and avoidance behaviors. Conducting exposures in a therapeutic setting involves the identification of feared situations or stimuli, controlled and planned introduction of anxiety-inducing stimuli, and prevention of safety or avoidance behaviors. The ultimate objective is to aid patients in the reduction of feared stimuli by engaging in these events and learning that engagement with feared stimuli does not lead to catastrophic outcomes. Exposure often follows a gradient that begins with breaking down feared situations into smaller, manageable steps. Patients start by exposing themselves to less anxiety-provoking aspects of the situation and gradually progress to more challenging elements. For example, if someone fears going to a shopping mall, they may begin by driving past the mall, then walking near it, and eventually entering the mall and engaging in shopping activities. Other therapeutic variations of exposure therapy include interoceptive exposure and systematic desensitization. Though very similar, interoceptive exposure is a specific technique that focuses on intentionally triggering and experiencing physical sensations that resemble panic symptoms, while systematic desensitization combines relaxation techniques with gradual exposure to help the patient slowly overcome their fears. Together, these techniques help individuals with agoraphobia and panic become desensitized to bodily sensations that may be perceived as threatening or dangerous. Individuals learn relaxation techniques, such as deep breathing or progressive muscle relaxation, to manage their anxiety. Then, they create a hierarchy of feared situations and systematically expose themselves to each step, while practicing relaxation techniques to reduce anxiety. By repeatedly pairing relaxation with the feared situations, individuals can gradually reduce their fear response. Ultimately, by repeatedly exposing themselves to these sensations and learning that they are not harmful, individuals can reduce their fear of physical symptoms and break the cycle of panic. Merging cognitive and behavioral interventions allows individuals with agoraphobia and panic the ability to address both the cognitive distortions and the behavioral avoidance that contribute to their symptoms. This comprehensive approach allows for a more holistic treatment experience, empowering individuals to overcome their fears, reduce avoidance behaviors, and regain a sense of control. Mindfulness. Mindfulness is the practice of maintaining awareness of the present moment. These exercises allow individuals to attend to their immediate internal and external surroundings, including thoughts and emotions, with openness, acceptance, curiosity, and empathy. While a broad range of practices can be conducted to help patients achieve continued awareness, self-monitoring is a major pillar of mindfulness practice. Specifically in anxiety-related disorders, the undertaking of monitoring worry and internal physiological responses promotes attention to behaviors and cognitions that are often the source of avoidance. Increased self-awareness will allow an individual's ability to decenter and raise awareness of alternative behaviors, cognitions, and solutions. Research on regular mindfulness practice indicates increased emotion regulation and decreased reactivity to internal and external cues. Psychotherapy for Ms. V. One of the primary components of CBT for agoraphobia and panic disorder is psychoeducation. In the case of Ms. V, therapy would focus on addressing her fears and worries regarding being in cars or situations in which she may not be able to change her colostomy bag. During sessions, the therapist would help the patient understand the nature of her anxiety and panic attacks and the connection between thoughts, emotions, and behaviors. This knowledge is used as an empowerment tool to help Ms. V recognize and challenge her anxious thoughts and develop more adaptive coping strategies via cognitive restructuring. This process involves first identifying the maladaptive thoughts and then replacing them with more realistic and helpful ones. For example, Ms. V might have thoughts such as, "If I go out alone, I will have an accident and will not be able to change my colostomy bag." In this case, the therapist would help her examine the evidence for and against this belief and collaboratively develop more balanced thoughts. For example, an alternative would be, "I have managed my colostomy bag successfully in the past, and if something unexpected happens, I can handle it." During the treatment course, patients learn a set of specific skills to increase their tolerance to panic and anxiety, and learn how to effectively self-monitor to identify factors that are likely to trigger panic symptoms, with the aim of progressively challenging distorted or unproductive thoughts. In addition to cognitive restructuring, CBT often includes exposure therapy. This component aims to gradually increase exposure to activities or situations that have been avoided due to anxiety. In Ms. V's case, the therapist would help her develop a hierarchy of feared situations related to going out alone and engaging in various activities, starting with less anxiety-provoking situations, such as taking short walks outside her home and moving to her most feared scenario. It is the therapist's job to support Ms. V as she gradually faces and tolerates increasingly challenging situations, such as going to the grocery store or the gym independently. Self-monitoring is an essential skill that the patient learns throughout the therapy process. Ms. V would be encouraged to track her thoughts, emotions, and physical sensations related to anxiety and panic attacks, to become more aware of triggers, patterns, and the impact her thoughts have on her symptoms. By recognizing these patterns, the patient can gain a sense of control and actively intervene to challenge and change her maladaptive thinking patterns. The patient would also be encouraged to systematically plan and engage in activities she has avoided. The therapist would help the individual identify specific activities they would like to engage in and gradually incorporate them into their daily routine. This process helps individuals regain a sense of control and confidence in participating in activities they have been avoiding. For those patients who cannot tolerate the level of anxiety induced by the behavioral therapy, or those individuals who suffer from comorbid clinical depression, pharmacotherapy may be indicated. In addition, the patient may have a preference to start treatment with medication before engaging in therapy. For Ms. V, a previously outgoing woman, returning to activities with others and learning new things was her goal. Toward the end of treatment, Ms. V successfully enrolled in a culinary class 10 minutes away from her home. Once individuals have made progress in treatment, it is essential to focus on relapse prevention and maintenance strategies. This involves helping patients consolidate the gains they have made, develop coping strategies for future challenges, and continue practicing the skills they have learned. Key points to remember. The gold standard psychotherapeutic treatment for anxiety disorders is short-term CBT. CBT is an evidence-based and non-pharmacological treatment approach that can be applied to a broad range of patients. CBT enables patients to actively engage in the process, acquire effective coping strategies, and witness early symptom relief as they build upon their successes. Supplementary interventions such as mindfulness and pharmacological therapy are additional strategies that can be used for the treatment of anxiety in conjunction with CBT. 29. I can't believe he did this to me. He put a curse on me. Ahmed Valdez, MD, and Stephen McLeod Bryant, MD. Ms. B is a 68-year-old Haitian woman who was brought to the emergency department by police after being found outside her church setting fire to 2 human-shaped wooden representations. Ms. B is markedly anxious with prominent restlessness, tearfulness, and preoccupation with a voodoo curse being placed on her by her ex-husband. Ms. B also complains of headache and shakiness. 2 months ago, she had a magnetic resonance image, MRI, of the brain after awakening with a severe headache. The patient states that she was told the MRI was normal. Several months ago, she immigrated to the U.S. after separating from her husband. Ms. B has limited family or social support and speaks few English words. Medical workup, including routine blood, urine, and imaging tests, returns within normal limits. Ms. B is periodically seen crying, rocking back and forth in bed, screaming the name of her ex-husband, and asking God for forgiveness, interspersed with periods of prayer in the room. Upon medical clearance, given the patient's continued despair, anxiety, and possible psychosis, she is transferred to psychiatry for further evaluation. What do I do now? Anxiety disorders are strongly influenced by ethnic, racial, social, spiritual, and additional factors that collectively contribute to the cultural identity of the individual and shape their thoughts and behaviors. Reductionist thinking can lead clinicians to focus solely on specific symptoms and neglect key aspects of a person's broader cultural context. To truly understand their patients, it is essential for clinicians to adopt a comprehensive understanding of a person's culture. As per the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, text revision, DSM-5 TR, culture encompasses a wide range of learned elements such as language, religion, spirituality, family structures, life cycle changes, ceremonial rituals, customs, and moral and legal systems. It represents a collection of knowledge, rules, and practices that have been passed down through generations and evolved over time. Culture shapes numerous aspects of patient care, influencing the patient's experiences of illness, distress, and symptoms, and how clinicians interpret and understand them. Culture also influences the patient's perceptions of care, including what types of interventions and treatment are acceptable. Even when patients and clinicians seemingly share similar ethnic or linguistic backgrounds, other cultural aspects may affect care, including gender, race, sexual orientation, religious practices, and spirituality. Recognizing the impact of culture context and expectations is vital in understanding the clinical encounter for every patient, and not just those from minoritized groups. As a result, the cultural formulation is an essential component of any comprehensive psychiatric assessment. In the U.S., anxiety disorders manifest with a wide variety of symptoms among distinct cultural groups. For example, when compared to other racial groups, Asian Americans consistently report lower frequency of symptoms associated with anxiety disorders. On the other hand, white Americans tend to report symptoms of anxiety more frequently than African Americans, Hispanics, and Asian Americans. These differences highlight the importance of recognizing the cultural influences on the presentation and expression of anxiety disorders within different racial and ethnic groups. The expression of anxiety and related disorders is influenced by a wide range of culturally bound factors. Ethnic beliefs regarding bodily systems shape the way somatic symptoms such as palpitations or diaphoresis and psychological symptoms such as forgetfulness or difficulty concentrating are reported and experienced. These cultural beliefs about the human body and psychological processes are closely linked to culture-specific disorders, contributing to the unique presentation and understanding of anxiety within different contexts. Contextual factors encompass the social context and norms that shape the experience of anxiety. These factors can be categorized into two broad types based on collectivistic and individualistic societies. In collectivistic societies, the emphasis is on interdependence among individuals. The harmony and cohesion of the group takes precedence over individual autonomy or personal gain. On the other hand, individualistic societies prioritized individual autonomy over collective harmony. Emotions associated with anxiety will vary based on the context. In collectivistic cultures, as seen in some Asian cultures, anxiety may be associated with feelings of embarrassment, as it is often triggered by external sanctions or expectations of the social group. In the individualistic cultures, as seen in North American cultures, anxiety is more commonly linked to feelings of guilt and self-blame, as it arises from internal standards or personal expectations. Other factors such as gender and religious beliefs may influence the expression of anxiety. Gender identification can lead to culturally bound expectations and therefore be a cause of anxiety when there is a mismatch. In general, individuals with higher levels of religiosity tend to experience less worry and anxiety. Engaging in contemplative prayer, either individually or as part of a religious community, is associated with increased feelings of security and reduced stress. Culturally specific anxiety disorders. There are various culturally specific manifestations of anxiety disorders described in the DSM-5 TR under the concept of cultural concepts of distress. Panic attacks are generally considered universal phenomena, but their expression can vary across cultural groups. For instance, among African Americans, the disproportionately high incidence of stroke and heart attacks can influence the symptoms experienced during panic attacks. The fear of a heart attack may contribute to catastrophic thoughts during panic, amplifying cardiovascular symptoms. Numbing and tingling sensations in the extremities might be associated with the belief that one is having a stroke. Other cultural groups express panic attacks according to their unique understanding of bodily functions. For example, Cambodians often exhibit multiple anxiety-related symptoms related to concerns about disturbances in the inner wind and blood flow, referred to as wind attacks or Kyle attacks. These events are associated with excessive worry, insomnia, and fear, and manifest somatically in the neck area. In traditional Chinese medicine, for example, anxiety states are often attributed to organ dysfunction, such as to a weak heart, or sin shu. Thus, they may be especially hypervigilant to cardiac symptoms, such as dizziness, blurry vision, and tinnitus. Among Puerto Ricans and other Hispanic groups in the Caribbean, a condition known as ataque de nervios, or attack of nerves, displays similarities to panic attacks. Typical symptoms include a sense of loss of control, chest tightness, sensations of body overheating, palpitations, tremors in the arms and legs, and fear of imminent syncope. Contextual factors also play an important role in the development and expression of specific anxiety disorders within certain populations. Social anxiety disorder is well recognized in Western cultures and is characterized by an intense fear of anxiety in social situations where scrutiny by others is expected. In Japanese and Korean cultures, there are culturally specific expressions of social anxiety known as Taijin Kyofusho, TKS. Individuals affected by TKS are primarily concerned about doing something or presenting themselves in a way that might offend or embarrass others. TKS presents with various manifestations, such as the fear of emitting offensive odors, blushing, staring inappropriately, or having an improper facial expression or physical deformity. Treatment. Developing culturally sensitive treatments for anxiety disorders is increasingly important, given the multicultural nature of the population healthcare providers serve. Recognizing and respecting the cultural aspects that influence the experience, expression, and treatment of anxiety disorders is crucial for providing effective and meaningful care to individuals from diverse backgrounds. By adapting therapeutic approaches to incorporate culturally specific factors, healthcare providers can enhance the overall effectiveness and relevance of treatments for anxiety disorders. When treating anxiety, it is important to recognize and address the stressors specific to each patient, particularly with ethnic minority and refugee populations. These stressors include financial stress, safety concerns in dangerous neighborhoods, interpersonal stress related to gender-based violence, acculturative stress, and coping stress, resulting from language barriers and limited access to resources. Modifying catastrophic cognitions is a crucial aspect of evidence-based psychotherapies for anxiety disorders. Treatment can take the form of structured therapies, such as cognitive behavioral therapy, to address negative automatic thoughts, such as the catastrophizing that can lead to panic. In addition, such treatment can provide supportive measures to de-escalate the patient in session when they are becoming more anxious, such as grounding techniques, breathing exercises, or practicing mindfulness. To ensure cultural sensitivity and competence, a multidisciplinary team composed of social workers, case managers, lawyers, clergy, peer specialists, or other healthcare workers may be necessary to provide resources that address the specific needs and stressors faced by the patient. In marginalized groups, trauma exposure can be experienced transgenerationally. Thus, carefully assessing and treating trauma symptoms is crucial. Limiting trauma exposure and addressing trauma-related symptoms are paramount, given the high rates of trauma in these populations. Traditional exposure therapies may need to be adapted for cultural groups to enhance tolerance and effectiveness. Certain cultural groups tend to present with somatic complaints rather than affective symptoms. It is important to address these somatic complaints as key components of treatment. For example, anxiety may be accompanied by catastrophic cognitions about somatic symptoms, as seen in ataque de nervios, leading to increased intensity and distress. Treating specific somatic manifestations, such as gastrointestinal distress or shortness of breath, rather than focusing on treating the anxiety itself, can be more effective in reducing hyperarousal in symptom escalation. Beliefs about medications can significantly impact adherence to treatment regimens and may vary across cultures. Cultural-specific medication beliefs, such as concerns about addiction or the belief that mental disorders cannot be treated with medications, should be addressed. Additionally, considering medication side effects that are culturally relevant can help tailor treatment plans and avoid potential harm. Stigma associated with mental health conditions, including anxiety disorders, may exist in certain cultures. Focusing on treating non-stigmatized symptoms while addressing the overall condition can help alleviate concerns and improve treatment acceptance. Tailoring treatment plans to address culturally specific concerns and symptoms can enhance adherence. For example, among Asian populations, dizziness, insomnia, and depletion, fatigue, seem to be key complaints that lead to catastrophic cognitions of the heart being weak with impending doom approaching. In such cases, framing the treatment as alleviating the processes that are thought to deplete the body, excessive worry leading to poor sleep leading to fatigue, will greatly increase adherence, rather than stating that medications will alleviate anxiety. The existential dimension of the patient's experience should be acknowledged, as existential worries and concerns can significantly impact anxiety. Cultural beliefs, including religious and spiritual attitudes, play a role in addressing existential questions. Understanding the patient's religious and spiritual framework can provide insights into their coping mechanisms. Addressing existential anxiety may involve supporting religious practices, finding meaning through volunteer opportunities, or exploring other means of maintaining life's purpose, depending on the patient's cultural background and beliefs. Ms. B presented with a wide range of factors contributing to her distress, including interpersonal, coping, immigration, and acculturation stressors. Additionally, she experienced existential concerns such as isolation, meaninglessness, safety worries, and a loss of sense of self. These combined factors overwhelmed her ability to cope, leading to a panic-like state, dysphoria, lability, and engaging in unusual ritualistic-like behaviors that initially made her appear psychotic. However, upon further exploration, these behaviors were found to be relevant in the context of her Caribbean culture. Examination of the patient's beliefs revealed that she believed purging the wooden images shaped like her husband would remove the perceived curse, thereby alleviating her suffering. Addressing her basic needs such as adequate housing, food, support system, and immigration status may bolster her ability to cope with the loss of her marriage, moving to a new country, and adapting to a new culture. Efforts were made to establish community connections and support by involving Haitian staff and contacting the church where she was found by the police in order to address her existential, spiritual, and loneliness-related fears. Her somatic complaints of headache provided a focus for initial treatment that could be framed in a non-stigmatizing way. Overall, her manifestations of distress, including her behaviors and beliefs, do not constitute psychosis or a psychotic disorder. Additionally, her anxiety does not overall warrant acute psychiatric hospitalization. Instead, her profound distress and anxiety stem from the multitude of stressors she is facing, which she expresses within the bounds of her culture. Key points to remember. Culture plays a significant role in shaping how anxiety is manifested, perceived, and expressed. Beliefs about the body, psychological processes, and social norms vary across cultures, leading to cultural-specific presentations of anxiety disorders. Cultural groups may express anxiety through somatic complaints rather than emotional or affective symptoms. Culture must be considered when designing and implementing treatment for anxiety disorders. This concludes Anxiety Disorders, edited by Zelda Espinel, MD, MPH, and Elizabeth A. Crocco, MD. Narrated by Eleanor McCormick. Copyright 2024 by Oxford University Press. This unabridged audiobook is published by arrangement with Oxford University Press and was produced in the year 2026 by Tantor Media Incorporated, a division of Recorded Books, which holds the copyright thereto. Please visit tantor.com for more information on our growing library of unabridged audiobooks.
Audible hopes you have enjoyed this program.